has a direct access, obviously, to the sphenoid sinus and can be a source of leak as well when we do transcranial approaches. And here we have performed an anterior clinoidectomy as well. We see the sphenoid sinus here and here. And then the third nerve, the fourth nerve, the sixth nerve in the cavernous sinus, and the trigeminal nerve in V1, V2, and V3. So moving on to what we see in surgery, it's a classical arterional approach view with the optic nerve, carotid artery, and this picture is centered on the MCA. And we can also see here the third nerve, the basilar artery here, and PCA, PCOM, and the carotid artery. So classical surgical view. But if we move laterally towards the approaches that we can, or what we can approach with the middle fossa classic approach, which is its craniotomy centered here around the root of the zygoma. This is an approach performed in a cadaver of the classical middle fossa approach. Small craniotomy can be tailored depending on if we want to also access the anterior part of Meckel's cave, or we're going more posterior. But anyway, the main reference once we open skin incision is the zygomatic root. And we have centered this craniotomy in the zygomatic root here just to expose all this anatomy of the middle fossa that we saw in the lab that we can relate all this anatomy, foraminal valley here, spinosum with the middle meningeal artery, GSPN. We can reference all this to the zygomatic root and to the external acoustic canal. So we know that approximately 3 millimeters posterior to the anterior part of the zygomatic root, we have foraminal valley. A little posterior, we have spinosum, and about 17 millimeters to 2 centimeters posterior to that, we can find the posterior aspect of GSPN, and that's been very useful in the OR, as well as the relative depth as compared to the border of the craniotomy, in which we can find all these superficial structures, including the arcuate eminence here. So in between 2 and 3 centimeters deep, we can find all these structures. And we also look at, when we look at the middle fossa approach, we can also perform 2 additional variations of that approach that are, we can either access the internal acoustic canal and drill it for acoustic neuroma, for vestibular schwannoma, for instance. And we can also drill the anterior, perform the anterior Petrosectomy and access through the middle fossa, we can access the posterior fossa. And we saw in the lab also that the internal acoustic canal usually projects towards the zygomatic root. So it's another point of reference that is very useful. So this is the classical view of a middle fossa approach, where we see V3, the trigeminal ganglion here. This is V2. This is the middle meningeal artery, and GSPN, the arcuate eminence, and the ridge of the Petrous bone, so the Petrous ridge, where the superior petrosal sinus sits. So having these references with GSPN, the classical reference of the arcuate eminence, and bisecting that, we can find the IAC, and then we will look and we take and open the dura, we can see 7 and 8 very well. We can put the endoscope and we see that a little bit better. We'll show another picture of that. But just to complete what we can access with the middle fossa approach, we can perform an anterior Petrosectomy in between the root, the trigeminal nerve, GSPN, and below GSPN, we know that there's the Petrous carotid artery, the cochlea here, and the medial aspect of the IAC. So this can be safely drilled. And once we do that in the lab, so this is the IAC dura, we can expose all this anatomy, and by cutting this and the tentorium, we can, in the supratentorial dura, we can see the fifth nerve all the way, and we can also put the endoscope and look around, and we see a lot more anatomy. This is 7 and 8. This is the sixth cranial nerve, and this is the trigeminal nerve. And this is an endoscopic view of 7 and 8. So just to finish this overview lecture of the approaches, then we move on to the posterior cranial fossa, and then we can have, which is a relatively small area as compared to the rest of the cranium. In between the zygomatic root and the inion, we find the posterior fossa, and the transverse and sigmoid sinus are going to be our references. And we can perform a transpetrosal approach, very often combined with a supratentorial extension in a combined transpetrosal approach, or also called posterior petrosectomy approach, supra and infratentorial. And then the retrosigmoid classical approach. And so this is all the anatomy that we are going to see and to know here. This is the transverse and sigmoid sinus and the jugular bulb. This is the labyrinth. And this is the Asterion. Very good reference of the sigmoid sinus is the mastoid groove, and the line that joins the mastoid groove towards the Asterion. This is all the anatomy of the posterior fossa. Here the cerebellum has been partially resected. And then we see 7 and 8. We see the fifth cranial nerve. And we see 9, 10, 11. This is a posterior view of the posterior fossa contents and the CP angle. This is again the fifth cranial nerve. This is 7 and 8. And on the left side, we can see it completely dissected with the labyrinth here. And this is 9, 10, and 11. And so when we combine the transpetrosal approach with the supratentorial extension, we have to divide, we have to ligate the superior petrosal sinus, and then we have to divide the tentorium. And we have to be very careful with the fourth nerve that runs in the tentorium here. And then, so that's the combined approach that looks at the CP angle structures plus the middle fossa structures. And dividing the tentorium, we can have access from the third cranial nerve and the posterior fossa contents. So when we look at this lateral view of the, that's the right side. So we see the sigmoid sinus here, the transverse sinus, and the jugular bulb. We see how we can perform a pre-sigmoid approach that, as I said before, we can combine with the middle fossa approach. So we have supra and infratentorial extension, and then the retrosigmoid approach. We have to also, so in the posterior petrosal approaches or pre-sigmoid approaches, we can also have all the variants, the retrolabyrinthine approach, that would be this one, in which we preserve the labyrinth and hearing, the translabyrinthine approach, and then sometimes the transcochlear approach that we'll see later. So when we have an overview of the posterior and posterolateral approaches, we have to talk about the far lateral approach, that is a craniotomy, the retrosigmoid craniotomy, lower than the retrosigmoid craniotomy, down to the foramen magnum, and then we usually combine that with the C1 laminectomy and with condylar drilling, that with all its extensions. I'm not going to to detail too much of that, because we're going to see that in subsequent lectures. But here, one of the most important aspects of this anatomy and this approach would be the location of the vertebral artery that is located on the groove of C1. And this is how this anatomy is very complex. This shows in this anatomical specimen, this is the vertebral artery, and this is C1's occipital C1 junction. And here would be the craniotomy for a far lateral approach. And the area that we are going to combine and we are going to see includes also this anatomy here, the upper part of the spinal cord and medullas, as well as all the anatomy of the CP angle that we saw before, with all these structures that we are going to see. This is the 5th nerve, the 6th nerve, 7 and 8, 9, 10 and 11. This is the 12th cranial nerve. So this is the area of C1. And we're going to see the vertebral arteries joining here in the vascular artery and all this anatomy. So thank you very much for the invitation to talk in this symposium. It's really an honor for me. And of course, this is dedicated to Dr. Rhoton, who was the greatest mentor and most brilliant neurosurgeon and kindest human being that I've ever met. And he saved thousands of lives, and I hope we can carry on part of his legacy with this kind of symposiums and with our laboratories around the world. And I just want to acknowledge, and I'm very grateful to my fellows, my current fellows in the lab. Thank you very much.
Thanks, Maria. That was a great talk. Difficult task to talk about so much anatomy in just 15 minutes, but you did great. And it serves as a great introduction. So thank you very much.
Thank you.
We'll have next with us Dr. Abhinav Kumar. Are you with us, Kumar? So Kumar did a 2-year fellowship with me in Pittsburgh in the lab. So he's an expert anatomist, and then he came up to do a fellowship at Stanford with Gary Steinberg on vascular, and then another one with me, clinical fellowship on skull base. So as we said yesterday at the beginning of the meeting, this meeting is not only about having real, true masters and very experienced surgeons, but also having some of the younger generation that bring up new concepts and ideas. So please, Kumar, welcome. We can't hear you. You have to unmute. You're unmuted. You are muted. I don't know why, but we cannot hear you. I'm not sure what's happening. CME, you guys know what's going on? Because we cannot hear him.
Dr. Kumar, at the bottom of your screen where it shows the icon of the microphone, there should be an arrow where you can click to select the microphone that you're using. So you might have to select your earphones since you're using your microphone from your earphones. So on the bottom left of your Zoom screen, we still can't hear you.
Did you take the headphones out? We can't hear you, Kumar. Yeah, it seems that he's muting and unmuting okay, but it doesn't make any change, right?
Yeah.
You suspect it because he's using the headphones?
Yeah, I think his computer might be wondering which audio to pick up from. Dr. Kumar, if you don't mind, maybe you can log in and log out and log back in. Maybe that will reset your computer audio.
Yes, let's try that. Kumar, you want to log in and out? In the meantime, we can start. I can start my presentation and then I stop when you're back, for example.
Fantastic. I think he did just that. So.
Okay. Okay. Let me then start the screen and maybe show. 1 second. So while Kumar comes on board and he talks about endonasal anatomy, maybe I can show part of my presentation. So as we said, approaches we're going to discuss, and all of our panelists are going to discuss in detail these approaches. I'm just going to give you a brief overview of some cases where I had to do one approach or the other. If we go into the anterior skull base, for example, here we have two pituitary adenomas, and they both look a bit ugly. At any point, Paul, if you want to make any comments, or any of the panelists, I think that would be welcome. But you see here these two pituitary adenomas. One is native, the other one is multiply recurrent and radiated. So these adenomas, you need to look where is the optic chasm in relation to the tumor, and you will see that the position of the chasm is different in these two cases, and therefore the approach I performed was also different. Also, when you see tumors that are going into the suprachiasmatic space between the anterior cerebral arteries and the optic chasm, I always worry, and I worry because of the perforating branches of the ACOM and the ACAs. In this case, the subcallosal artery, which can be a very relevant artery vascularizing the fornices and the mammillary bodies and anterior commissure. So we published about this because of
that second one also looks like it's subarachnoid, fully subarachnoid, which makes it much higher risk.
Exactly. So Paul made an excellent point in this case right here. A pituitary adenoma like this is subarachnoid. It doesn't respect the planes. You can see how it relates with the pituitary gland. So experienced pituitary surgeons like Paul, sees this immediately and thinks this is not an easy case. And this patient was, she's young, and she presented with mild elevation of prolactin levels in the 140, 150, placed on cabergoline with no response. And if you don't see a response, that makes me think that this is a resistant prolactinoma or an atypical prolactinoma, which are known to be more aggressive and more difficult to deal with. And actually, this case was in the middle of the peak of the pandemic, but I had to do her because her vision was getting worse and she had terrible headaches. So this is briefly the approach. You see, it's a very expanded approach. You can see the limbus of the sphenoid all the way to the planon. Even if I'm not going to open that anterior, I want to have that dura exposed. And then I'm working on exposing you saw the pituitary gland. This is working on one cavernous sinus that is wildly invaded, finding 6th nerve. That's the Doppler. And what I'm going to do here is I'm going to open the dura of the prechiasmatic sulcus. And the gland, I found the gland here is disconnected, but look at the perforating branch. It's a super hypophyseal artery here. And as Paul mentioned, this is subarachnoid invasion. It's not respecting any planes. It's relatively easy to remove the tumor because it's soft and suckable. But at the same time, you need to be very careful and very precise with your suction. And we use these teardrop suctions, right, that you can control very well, but you need to do it very carefully because the perforating vessels are all encased. You can see perhaps Hübner. This is an interesting variation. That's a meningeal branch that we sometimes see from the suprahypophyseal artery to the dura. And finally, we see the stalk. And this part also, is the part that is, always nerve-wracking about Hübner, around Hübner and subcallosal, and then peeling the last pieces of tumor of the optic apparatus. You can see how invasive this tumor becomes. But regardless, the endonasal approach gives us, excellent access to this area. I don't hesitate to recommend this approach for such a tumor. And now, at the same time, the versatility of the endonasal approach is such that I can now go into the cavernous sinus and then clean this cavernous sinus as thoroughly as I can. You see how the dura of the clinoidal space is being invaded, so I'm cutting it and coagulating it, and this is at the end of the resection. So not an easy case with not a complete resection. There is a little bit of residual tumor on the cavernous sinus that I left because the corroding was very tortuous, but a patient with a very good outcome, normalization of prolactin at this point, and the pathology confirmed this being an aggressive subtype of adenoma. And this is the post-op again. So at the same time, and I'm going to show this case, and then we'll see if Kumar is back with us. But just to pair it with the other one, this patient also I had trouble with this one. So this patient had 2004 transcranial approach for the tumor you see there. The MRI is very bad, but this was done actually in China, and that was the tumor. And they did that resection through a transcranial approach that I'll show you briefly. And then there is residual that is growing, and then they irradiate the residual, actually twice. In 2 years difference, and you see where the residual is, and now the patient comes to me with this MRI and with progressive visual loss. And I do probably 99% of pituitary adenomas through an endonasal approach, but this is the 1% that I decided not to do it endonasally. And it is because if you look at the optic apparatus, you see the optic chiasm is being displaced inferiorly. And the tumor is, occupying the interhemispheric fissure and, getting between, the third ventricle and the anterior cerebral arteries. And I very much worried that I was not going to be able to get access to that portion of the tumor. And also I would have to manipulate optic apparatus to get there. So you can see the approach they did in the past. She has a defect. They did a transfrontal approach. And you can see the relation of the tumor with the anterior cerebral arteries. And again, this patient has been radiated twice, and that always brings a concern. So this is a subfrontal approach. What I did was a cranioplasty because he had a cranial defect. So I started doing the interhemispheric fissure approach and opened the anterior interhemispheric fissure, which wasn't easy, but I could get A2 controls, and then I get to A1s on both sides. My concern was to surround the tumor and get all the vascular structures proximal and distal. And while I was dissecting, suddenly I started getting bleeding, and I didn't even see where it came from at that point. The vessels were so plastered against the tumor that were not purple, they were so pale. But that's there is probably a perforal avulsion right there that I had to solve with a clip and then continue. So that was an unfortunate event, but we were able to solve it. And now you can see the optic chiasm is clearly displaced down. And now I'm taking the tumor from the third ventricle, which is now widely open, and really terrible planes and stuck to the vessels. But finally, we were able to achieve a good resection. And the optic chiasm was all displaced down, as you can see in this picture. And I think it was a good idea to go endonasal. And what was unfortunate is that the perforated branch was wrapped anteriorly, which is so unusual. And this patient unfortunately got a stroke in the anterior commissure. But, as we said, better lucky than good, because this patient actually had no deficits. As we said, the subcallosal artery, which is probably the perforated branch that was a bulge, can vascularize the fornix, but in this case, it did only vascularize the anterior commissure. So the patient had no deficits whatsoever, and he had an excellent outcome. But if you are not lucky, or the patient is not lucky, you can have a significant deficit from this injury. So let's see, Kumar, are you with us?
He is not on yet.
He's not on yet. Okay.
Hey, Juan, can I make a comment?
Absolutely, Dan.
Those are two really nice cases and really demonstrate the importance of knowing, where the chiasm is, whether you go from above or below. Really tough cases. On this second case, on your subfrontal approach, did you do just a bicoronal incision? You use the old incision or what?
Yeah, I did use the old incision,
Yeah.
and I had to commit to a canaloplasty because, you know, as you saw here, you know, she had this defect in there. The frontal sinus was open. I found even wax inside. I mean, it was kind of a disaster.
Nice.
Yes.
You know, this is one that we may do. We might try an eyebrow on. It is a more lateral approach. The beauty of the subfrontal is you're coming straight down the midline, and you can get between the two nerves, and I think that's a good approach. But clearly, you need to come from above on this one with the chiasm pushed.
Yes, and funny enough, this patient had seen another neurosurgeon that recommended endonasal. One with less experience than me on doing endonasal had recommended endonasal, and I thought it was a mistake.
No, you're absolutely correct.
Dan, quick question. Do you modify your eyebrow, for example, ever sacrifice the supraorbital bundle to shift more medially to get a more subfrontal approach as opposed to the more classic lateral eyebrow?
That's a good question. We don't typically, but you know, you certainly could, as long as you tell the patient that you're going to have a numb forehead for the foreseeable future. It's not a huge deficit, and I think it's a reasonable thing to do, because actually getting another centimeter or so medial can make a significant difference. So it's a good thought.
Good.
I agree with you. Yeah.
Okay, let me move on, and then because related to that topic of eyebrow or frontal orbital approaches versus endonasal, I can share these two other cases. There was two other case examples. You know, tumor size is similar, location is a bit different. So again, what is the optic apparatus? What is the optic nerve in relation to the tumor? So when I look at tuberculum cell meningiomas, as many of you do, you know, I want to see what is the relation of the tumor with the optic apparatus and with the optic nerves. If the tumor behaves such as like this, that the optic nerve is behind or above, and the tumor is mostly medial to the optic nerve in the optic canals, for me, an endonasal approach is ideal. When the tumor starts going over and lateral, then, especially if it attaches to the dura above the clinoids, then I think about an open approach. But many tuberculum cell meningiomas stay within these boundaries. And I do believe endonasal is better because I can get better visualization, better access to the so-called infrachiasmatic region, even for large tumors like this. This patient, young patient, blind on the left eye, she let this go for too long, but you can see the beautiful video you can get from this endonasal approach. And we're again dissecting in the same area. You see all those perforating branches. What a unique view the endonasal approach provides you. We're again dissecting underneath the ACOM, and just for all attendees, remember again, between optic chiasm and pterocerebral arteries, always perforating branches to be preserved. Below, the perforating branches are the ones you are seeing here. These are superior hypophyseal arteries branches, and we want to preserve those too. You can see how that left optic nerve looks terrible because of the compression by the anterocerebral artery, but this is a very nice resection, complete resection done endonasally. However, this other case, you see, if you look at the coronal, it goes over towards the orbital apex more than I want. And also I need to do a large skull base access and defect to get into this tumor. So this I would do through a frontal orbital approach. You can use an eyebrow, or in this case, I prefer to use, you know, an incision behind the hairline. And I like to take the orbital ring for these cases because I do it usually on one piece. There are so many ways of doing it, but I like in one piece because it's easy to reconstruct. But the one piece allows me to avoid any manipulation of the frontal lobe. And the frontal lobe, where a significant amount of edema is not being touched or retracted. And I can get excellent access to the whole skull base. You see, I can peel the dura of the skull base. You can do extradural first to devascularize the tumor. And then you can preserve, you know, that's a frontal orbital artery. You can see nicely the olfactory tract and gently dissected. This is the contralateral one. and preserve olfaction in a case like this. And you see, you can even take the dura on top of the clinoid and peel all this laterally. Now here becomes the part that is more tricky for me for these cases as we go deeper into the infrachiasmatic space. So for this case, this is not difficult. I can deal with all this tumor very well, but a more involved tumor in this infrachiasmatic space, I think, is better than endonasally. I think you have better view, but it's still, you can drill the optic canals, you can take the dura of the falciform ligament, you can take the dura of the prechiasmatic sulcus, but there is always some degree of manipulation of the optic apparatus you have to do in that area. That's why endonasal, I think, is, in my opinion, superior for that area. But a tumor like this, I would rather do from above, because I can tailor the skull base defect. I minimize manipulation of the frontal lobes, and I'm not that worried about that optic canal invasion in a case like this. This is a case that probably you would have done with an eyebrow. I don't know about you, Paul, or James, or any of you guys. You want to make any comments?
Juan, that post-op scan is very interesting. You can see what's called the pneumosinus dilatans, which is very aerated, that you typically see with tuberculum sellae. And I think initially you're tempted to do endonasal because you think there's a big airspace. But in fact, I think the cribiform plate hangs lower and sometimes can be obstructive to your trajectory.
That is a very good point, James. And another point you're bringing up is that, yes, then you would have to go through some cribiform to get there, which would put the olfaction at risk, right?
Yeah, I would say on this one, would definitely do it from above through an eyebrow. The other thing is on your coronal image there, it's really out over the optic canal. So not only would you, from an endonasal route, would you make the patient anosmic, you would definitely leave tumor behind, probably lateral to the canal there. So, and this is really more of a posterior planum. It's kind of barely touching the tuberculum. It's almost partially an olfactory groove, because it's pretty far forward. So I think the approach.
How do you manage that most anterior olfactory sulcus, that dip down? Even when you drill down the orbital roof from an eyebrow, it's very difficult to really see that olfactory sulcus. You can put an endoscope and sort of burn it, but to get a more radical resection of that dura, I find very challenging through an eyebrow, although I think the rest of it's ideal for an eyebrow. Yeah,
I think with a 30 or 45 degree scope, you can get to that, and with angled bipolars. We've done a few of these, Garni, Barkadarian, and I, where we've preserved olfaction. We come from the side that the nerve looks the most compressed, and usually they're a little slightly off center. So if one of the olfactory nerves looks like it has a better cuff, we'll come from the contralateral side, and we typically will sacrifice the ipsilateral olfactory because it's very hard to save that one. But if you save the other one, they're good. So yeah, I mean, getting all the dura out is a challenge, I think. So you raise a good point.
The only other thing I would add, this case, I don't think it really applies, but for some of these that do extend down to infrachiasmatic space and present primarily with vision loss, I'll sometimes plan to do two approaches because I think I get a better and more reliable visual decompression from below, but a more radical removal from above. And so combining an endonasal and eyebrow in two different stages separated in time is sometimes a consideration, but I don't think that applies here. But I'm curious, Juan, Dan, and James, how often you would choose to combine approach for competing interests?
I've done a few. I don't know if you guys, and even I've done that at the same time, but it becomes a bit painful. Usually for tumors, as you said, that are very large and not ideal for either approach.
Yeah, I try to stick with one approach if possible. The rare occasion I do a simultaneously combine is sometimes you get these sinonasal recurrences from anterior skull-base meningiomas where I think combining both at the same time is very useful, especially if you need a solution for reconstruction.
Yeah, I would agree. We haven't done it with the meningioma in quite a while, but occasionally.
Kumar, are you with us? Can we hear you?
Can you hear me now?
Yes.
Can you hear me? Oh, great.
So let's have you do your endonasal anatomy talk, please. We're looking
Oh,
forward.
yeah. Great. All right. Okay, can you see the screen okay?
Yes.
You guys can hear me okay, right?
Yes.
Okay, great. So thanks for having me. And, you know, it's very humbling to be sitting with three of you guys and trying to present a talk on endoscopic anatomy. But anyway, I'll give it a go. So that's basically been my path. I did some, you know, a couple of years in the lab, and then I've spent almost 3 years with Juan in combination with the lab time and a clinical fellowship, and also did a vascular fellowship with Gary, and currently sort of trying to build a career in expanded endonasal work, pituitary and vascular work. So just going to cover the sort of key anatomical aspects and also add some illustrative cases, going back to a lot of the Pittsburgh papers that I was involved with, as well as, you know, what the group at UPMC produced over the years. And what I have found quite useful in my first year, really starting this practice, some of the basic concepts and covering, this is the sort of spectrum of stuff that I'll try and get through in this period of time. So anyone sort of starting out in endoscopic surgery, the two things you get told, you really want to appreciate and understand the endoscopic anatomy of the ICA, as well as understand the sixth nerve, because they always get in your way, or they're in your way, and you have to really know how to handle. So here, this is the Cavernous sinus paper that that came out of UPMC, and I was part of that manuscript. And really, we're looking at the segments of the ICA here. Often, this segment is often referred to as the paraclival ICA. We define the cavernous ICA starting here, going to your posterior genu, and then you have your horizontal parasellar ICA continuing on as your anterior genu. And very importantly, from an endoscopic perspective, you define what we used to think after clinoidectomy as the sort of clinoidal ICA or the carotid cave. From an endoscopic perspective, you're looking at the ICA between the carotico-clinoidal ring, which is your proximal ring, and your distal ring. And this is your paraclinoidal ICA. And it's quite important to understand the orientation of this ICA, particularly if you're trying to uncover it for endoscopic approaches, because it's not a straight vessel here. It loops medially, and there is a chance of injuring it if you're using kerosene or trying to expose it in the wrong way. So this is the sort of understanding about the ICA anatomy. We will talk about the cavernous sinus and each one of these individual nerves and the compartments. This is obviously our mid-clivus, and this is the basal sphenoid. So I looked back on this paper, which was in 2012 from Paul and Juan, really, you know, highly relevant. I started my practice and saw the number of adenomas which haven't gone into remission, because functional remission, because people haven't gone lateral enough with their exposure and done a proper middle clinoidectomy, and therefore get to the lateral aspect of the adenoma. So very much sort of going, you know, for the general audience listening into the talk, for most pituitary adenomas, you want to see the lower aspect here, where you're seeing just the beginning of the cavernous sinus. And then where there is potential invasion of the retrogenu or the medial compartment, you want to uncover or do the middle clinoidectomy, and that involves uncovering your paraclinoidal ICA. And the basic steps, as it were, which are really well outlined in the paper, and I learned from under Juan's mentorship, is really sort of going across inferiorly, finding a safe plane with the cavernous sinus, creating two fracture points, and then out fracturing after eggshelling, rather than try to kerosene it out and risk injury. And you can see the prominence here, which we refer to as the middle clinoid. So this is a case, very beginning of my time here. And this was a young woman who hadn't gone into biochemical remission after a previous excision of an acromegaly lesion. I think she even had a PET scan in Cambridge, and you can see a clear focus of the disease on the right side. And these are post-resection images. And you know, her 3-month hormonal panel is now normal. This is a short video. I don't know if it will play well, but I can try. So it was clear from the first sort of surgery that none of this part had been exposed. So we did a more of a expanded approach, going up to the parasellar ICA, Dopplering it out. This was a redo case, so took my time with it a little bit more. And just by extending the corridor here more laterally and doing a wide sort of a sphenoidotomy, there was all this tumor that was tucked in that we were able to remove. And you know, I didn't think there was true sort of a medial or a retrogenic compartment invasion, and you could see a fairly clear compartment there, and she went into remission on the latest test. So now sort of talking specifically about the cavernous sinus and the compartments, this was a paper that we did some time ago, and we presented this at the North American Skull-Based Society meeting in Florida. So starting with the commonest compartment where we work is our retrogenic compartment, or the medial compartment. And the important thing to understand, and this sort of also blends in with the concept of pituitary transposition, a transcavernous pituitary transposition, because it's again that appreciation of that ring, an appreciation of the fact that you have two layers of dura here, a periosteal layer that blends in with the floor, and then you have the meningeal layer, which is going on the medial side, and you're really finding the plane in between the two at the floor of the cellar, and then dividing the ring and sort of working your way back up to, and I'll show more specific pictures from posterior clinoidectomy aspect. And again, to access this compartment, you need a full middle clinoidectomy because you want to uncover this area, and then you're looking into the compartment. Here you see top of the posterior clinoid, and this is a really nice important landmark here. That's the interclinoidal ligament. That is a good landmark for working out. On the medial side, you have the clinoidal, triangle, and on the lateral side is the oculomotor nerve. And again, as in the paper, in the cavernous sinus paper, we think of third nerve more posteriorly in this compartment as being more robust, whereas as you get more anterior in that compartment, the nerve is more naked and perhaps more vulnerable to injury. So that's that's the compartment when we talk about the retrogenic compartment. And again, this is another one of the cases, I think sort of my first or second month in my job, where you see a chap presenting with full cavernous sinus syndrome, apoplexy, and post resection, we were able to get a nice clearance of the disease. I'll run this video very fast forward, again, trying to expand. Same thing around sort of doing a more expanded approach, and then trying to get into the right next to the carotid and try and clean this out fully rather than leaving any residual disease behind. Again, it goes down to the principle of doing a nice ICA exposure, doing middle clinoidectomy, and working in the compartment under direct vision. And this trick, obviously, with the gel foam is massively helpful while working in this compartment, and stops and makes things much more efficient. This is one of the other cases. Now here, for example, this chap presented with unstable, with visual dysfunction. And again, here, I did leave a fibrotic cuff on the third nerve more anteriorly, where I was more concerned about potential injury. And he had a good recovery from his visual issues. So what about other compartments? I'm talking about inferior compartment here now. So again, we really, when we are talking about the cavernous sinus compartments, we are talking about it in terms of the division is based on the ICA. So this is the compartment that's sitting below the horizontal ICA. And we are looking at, and it's bounded by the horizontal ICA above, the short vertical at the back. And the main nerve here that is at risk, or that we worry about, is obviously the sixth nerve, the distal cavernous segment of the sixth nerve. And the sympathetic chain is usually following a sort of a straight line here. So when we are thinking about this compartment, we are always thinking about this ICA loop, the horizontal ICA, and the sixth nerve. And again, sixth nerve keeps cropping up everywhere in endoscopic surgery. So now when we are thinking about the posterior compartment, we think about the boundaries of this posterior compartment of the cavernous sinus. More inferiorly is again the sixth nerve, more specifically the so-called Gulfar segment, or the suprapetrous segment, just above the Petrous apex. And you see that dural fold here, which is your Petrous sphenoidal, or the Grubus ligament. And in this compartment, as one would expect, you have branches of the meningohypophyseal trunk that vascularize this compartment. And here's an example of a tumor that has invaded or that has presence of disease both in the inferior compartment as well as in the posterior compartment. In terms of the individual nuances of approaching these compartments, I'll leave it to the more expert and experienced people in the group later on, but this is just sort of covering the anatomy. I haven't particularly gone into the lateral compartment. I think there the surgery is usually, there's a much higher risk of causing issues with the cranial nerve function, but there will be pictures further on in the presentation where we will be able to see that. So now sort of moving more to a suprasellar approach. When we are thinking about suprasellar approach, this was one of the papers that I did while I was in the lab at UPMC. And this was more specifically with respect to really tuberculum cellular meningiomas rather than anything else, but it really helped me massively in my practice later on and in understanding the difference between how to tailor your suprasellar exposure. So going through the osseous anatomy here, we are obviously thinking, this is looking at the sphenoid sinus side on. So here is our tuberculum, the medial ossia with optic strut, anterior root, and optic strut is basically your posterior root. And then this structure here is the limbus sphenoidale, with the space between the limbus and the tuberculum being referred to as the chiasmatic sulcus. So, and these, you know, here we've put in yellow sort of structures to denote optic nerve, V2, and the Vidian nerve, and this is maxillary strut. So the idea in this paper was to look at optic canal more specifically from the point of view of if one was doing tuberculum cellular meningioma, which is invading the optic canal, how could we safely address that? How could we safely open that? And what is the osseous and the dural correlate of the optic canal? So again, this is all the work in the lab at the UPMC, and we can see that this is a transcranial perspective. We're looking at the limbus dura, the falciform ligament, and the idea was to identify the point where, coming from an endonasal perspective, you can detach the falciform ligament and then cut along the optic sheath and lower aspect of the nerve, slightly upper aspect of the optic nerve in order to enter the optic canal. So in terms of landmarks, again, for the sort of more general audience, we have the clinoidal iscia here, lateral ossia. This is the limbus, an important dural fold that you see all the time when you're performing this sort of approach or resection, and chiasmatic sulcus, and then we are looking at the tuberculum and the superior intercavernous sinus there. And this was sort of definition of osseous optic canal, or what we considered optic canal, which was really defined by the lateral ossia, with this segment representing what transcranially we would consider the preforaminal segment, or the segment that is roofed by the falciform ligament. And if one was doing this approach for a tuberculum cellular meningioma, again, the idea was to start with opening the dura over the sella, working upwards, and this is the point you're detaching the falciform ligament and then going along. And this, the number 4 cut really is tailored based on how far or how extensive the invasion is into the canal. And the number 2 cut is posteriorly along the diaphragm, and 3 is more towards the distal ring, again, to mobilize the ICA. And these are sort of the dural cuts from there. One of the things that JFM Juan emphasized sort of while I was training with him, and again, subsequently that I have found in my practice, is approaching craniopharyngiomas versus tuberculum meningiomas and tailoring your exposure. So most times, as we all know, majority of the work for the craniopharyngioma is going to be through the chiasmatic sulcus and the area above the sella, with some exposure of the limbus dura. We don't necessarily need to, sorry, not limbus, planum dura. We don't necessarily need to open all that dura. Whereas for a tuberculum cellular meningioma, depending upon the anterior extent of your of the lesion, you have to tailor that opening in the planum dura. So in effect, there's no point sort of opening the dura up here while trying to do a cranial unless the lesion dictates that. And this is showing the versatility. This was one of my cases towards the end of my fellowship at Stanford, one of the so-called graduation cases. And this is sort of demonstrating the utility of doing that middle clinoidectomy, again, with a standard suprasellar exposure for a relatively small tuberculum cell meningioma. And that again is finding the plane with the cavernous sinus and then trying to outfracture the whole thing. Now this piece of bone, when it comes out, does have a nice, I'll just fast forward it, does have a nice bit of middle clinoid that comes out right there. And this bit of the exposure, again, from a technical perspective, we do it right at the end of the exposure when we've done the majority of the suprasellar drilling. In terms of the final exposure, just as a close-up, again, pausing that, this is for tuberculum cell meningioma, so you can see the exposure has been taken further along into the planum. And again, this is the level of the intercavernous sinus, and here's that nice fold, the dural fold, the limbus sphenoidale that is always present reassuringly. And this is a sort of end resection view. One of the important nuances, obviously, in these suprasellar approaches is to preserve the superior hypophyseal perforatus at all time, which comes off the medial aspect of your supraclinoidal ICA. Here, the optics are not as good. This was a bigger meningioma where obviously the exposure is taken much more forward. It was very, very stuck to the right optic nerve. And really all I did was to progressively thin that down on the right optic nerve, leaving a cuff. So one of the points that JFM and Paul and all of you have talked about in the past is preserving the perforatus. And this is a nice close-up shot of the superior hypophyseal perforatus, and it's vitally important in these operations, in the suprasellar exposures, to preserve them to optimize your visual outcomes. And this was another case within sort of starting in the first month, a young chap with suprasellar tumor who presented with this lesion with acute sort of visual dysfunction. And here are my sort of tentative attempts to try and preserve those perforators, but just trying to demonstrate that I learned something from the fellowship. Here is Dr. JFM now in another operation. Now we're doing a craniopharyngioma here and trying to maneuver that bit of craniopharyngioma along that perforator. So it's far too easy to try and think you can just coagulate that and take that, but it really is worth it and the effort to try and preserve that superior hypophyseal perforator that he does very well by using that plate dissector. So going on to next aspect of the talk, we talk a little bit about the upper clivus and the retroinfundibular area, sort of moving south. Here I've really focused on the transcavernous transposition rather than the various types of transposition, which I presume will be covered later on in the conference. But again, this is a big contribution from UPMC by Juan and Paul. And here we are, similar to what we discussed before. This is going in between the layer of the periosteal and meningeal dura and safely controlling the inferior hypophyseal and getting access to the dorsum sella and the posterior clinoids for removal. So this is from my lab dissection almost 4 or 5 years ago now. And again, demonstrating those steps. Here's your inferior hypophyseal artery that obviously you take in a more proximal location with this sort of transposition technique. Talking again about the carotico-clinoidal ring. So taking this ring, the proximal ring is the easiest way I find in terms of thinking about it. It's coming from the anterior clinoid, attaching to the medial wall of the gland, and removal of this ligament really does allow you, and sort of what I've adopted is the use, again, having watched JFM and Paul, use McElveen knives in order to detach this ring. You feel much safer, and then gives you the access, more rostral exposure. And I'll show a video. This is a video that we showed at the NSBS. That's JFM's work here and we published this in Neurosurgery Focus. This is a pediatric chordoma case where you see that incision being made with use of Doppler, finding that layer between the periosteal and meningeal layer, and then you get that gush of fluid from the blood from the cavernous sinus, and then you're working your way, that's the McElveen knife doing that cut, and then you're working your way backwards towards the inferior hypophyseal, taking it in a controlled fashion, And the beauty is that you don't have to do the same thing on both sides as demonstrated here. Then the other side, you can do a subsellar extradural approach rather than trying to do bilateral transcavernous transposition. So you can tailor it according to what you need. And that's the expected gush of, again, blood from the cavernous sinus, because we know the posterior clinoid is in the roof of the cavernous sinus. So
2 minutes.
Now, going to move down to the mid-clivus. 2 more minutes? Okay.
Yes.
I think what I'll do is I will go down. So I'll just show the pictures basically. So this is, just demonstrating, just working south towards mid-clival exposure. And we're all familiar with this anatomy. You have the basilar trunk. You're really opening up into the prepontine cistern. And again, you're looking at that back view along the sixth nerve. And this is where one sort of goes back to the sixth nerve again, in terms of the cisternal segment and then the interdural segment going on to the carotid and the cavernous segment. We can skip this because I'll just carry on with the foramen lacerum aspect about the foramen lacerum and the inferior clivus, and finish up with understanding the lacerum is important because it's the junction between your mid and the lower clivus, between the coronal and the sagittal work. And we define this as a confluence between these three fissure lines, as we can see, pterigosphenoidal, petrosphenoidal, and petroclival fissure. And the key thing that sort of is worth highlighting is when we are doing a sublacerum axis, so if we go down here, when we are trying to work towards the petroclival fissure in that inferior compartment, trying to widen that exposure inferior-laterally, it's the division of this fissure line that is important, finding that, following that backwards, using the Vidian as a landmark, and you have about 45 to a 30-degree angle, and that allows you to mobilize the eustachian tube down south so that you get access inferiorly and laterally towards the petroclival fissure. So that's when is that useful? Well, one of the things that I want to finish up with is
Well, is that British mode? Kumar is frozen, I think. Well, Kumar, that's a very nice overview. I mean, I know if they ask me to do Endonasal anatomy in 15 minutes, I won't be able to. It's a lot to cover. So I know it's a very difficult task, but he did a nice overview of some key aspects of the anatomy that we'll go over it again. So why don't we have Dr. Liu come up? And
one quick comment, Juan, about what Kumar showed there. I think it's a beautiful example of I think something that Rhoton taught you and then you've passed along, which is understanding the anatomy or trying to understand the anatomy better in the lab, and then taking that to the OR. Every single one of the things that Kumar that showed there was discovered through exactly that process. And this understanding and dramatically improves our ability to do the surgery safely. So I think that entire talk demonstrates that concept and the importance of anatomical study.
Absolutely. James, welcome. Looking forward to hear your talk.
Great, thank you.
So let me just say that this session is going to be a bit informal. We have a schedule, but we're going to be, being a bit more liberal with it. We have 30 minutes discussion block after each block, but we can eat some of that time as we are going delayed. So please, James, go ahead.
Okay, thank you, Juan. See if I can advance my slides here. Well, it's certainly an honor to be part of this Rhoton Society. I was not a formal fellow of Professor Rhoton, but I think as skull-based surgeons, we are all students of Rhoton. If you've ever picked up an atlas or picked up a Rhoton instrument, you are, automatically somewhat of a follower of Rhoton, and he's a hero to all of us. And I had the great pleasure of having Professor Rhoton as one of our guests for several years in our course in New Jersey. And I think this is 2013. You can see a picture of Juan here on the left side. And again, certainly an honor to be part of this spectacular conference. So I've been given the task about talking about the trans-basal approach and versus the EEA and when to choose which approach in which situation. And I think we can apply these to a lot of different corridors, primarily the transcribiform corridor pathologies. And on occasion, I have used them for transplanum corridor pathologies like craniopharyngiomas and tuberculum sellae. And traditionally, this has been used for the clivus corridor for chondrosarcomas, such as this lesion here. And with the transbasal, you can go into the nasal cavity and drill out the clivus. But I think this has largely been avoided because of the endonasal approaches. And so a lesion like this, chondrosarcoma, that invaded the anterior skull base, this can be readily accessed and removed quite well with the EEA. And this patient has been survived recurrence-free for about 6 years now. So the transbasal approach is considered one of the workhorses of transcranial access to anterior skull base lesions. This is a depiction of the traditional approach, and this really gets you down into the nasal cavities, down to the hard palate, as well as frontal, subfrontal pathologies. And the nomenclature can be a bit confusing. And this paper from the BNI group talks about the different levels of variations of how much bone removal. And we actually tried to review this in Dr. Harsh's recent Chordoma book. Here's a chapter we wrote on the different levels with the illustration. So basically, the basic level is just a bifrontal craniotomy. And you can see there's a big overhang of the supraorbital bar. And so if you add removal of the supraorbital bar, it's a level 1. If you add more nasal bone removal, it's a level 2. And if you add lateral orbit, it's a level 3. And the Rave approach, the subcranial, is basically the supraorbital bar working below the brain. So we've modified this, and I call it the modified one-piece extended transbasal approach, but basically it comes from the idea of the contour of the skull base, the anterior skull base that is, in the coronal plane. So if you look at it, it's not a flat surface. It's actually dips down, like we call it the valley that we mentioned before. And if you look at the frontal sinus, it really takes the shape of this valley. And this idea really originated from John Jane's work back in the early mid 80s. And if he would take an X-ray and make a tree find based on a sterile skull X-ray, but if you incorporate the frontal sinus with your tailored bifrontal craniotomy, this really gets you down low, down where you really need to go. And I believe you really don't need additional supraorbital bar removal or any nasal bone or lateral orbital bone removal. And we initially described this in this article on accessing this particular recurrent craniopharyngioma. And so you can find the reference there. And so we further published on this type of modified one piece in a variety of different video publications for sinonasal malignancies, craniopharyngiomas, and a tuberculum meningioma. So let me just go over some technical points. This is a standard transbasal bicoronal incision. And it's very important to harvest the pericranial flap by undermining the posterior margin of the incision. We take it in 2 layers, raising a galeocutaneous flap first, leaving the pericranium down, and then raising the pericranium as a separate layer. You have to be careful as you dissect more anteriorly not to injure the frontalis branch of the facial nerve. So I use a 15 blade and feather this layer out. And we like to make a single burr hole over the superior sagittal sinus, eggshelling it, and then turning the bone flap laterally. And then getting down on the nasion, you can use a C1 and then make your cut right along the outer table of the frontal sinus. And then you can connect these cuts with the burr hole laterally below the superior temporal line with a foot plated drill, and then connect the dots essentially. And sometimes you do need to use an osteotome to disarticulate the intersinus septum in the midline, and then sometimes laterally here if the bone is a little bit thick. And then you can outfracture this and you can get this bone flap off in one piece. And then when we make the dural incision, we make a U-shaped dural incision. So it's very low basal incision. where you avoid the superior sagittal sinus altogether. And this incision is quite close to the crista galli. And I really believe this avoids any bridging vein injury or venous infarction. This is an example. This is a case we actually did last week, 42-year-old male with this very large, wide, broad-based olfactory groove meningioma, losing vision with papilledema and anosmia, Foster-Kennedy syndrome. You can see it's a very large meningioma, and it's got a bilateral frontal edema existing already. This is the lion mane sign, and you can see the A2s draped over the back of this tumor. So I feel that this is a great approach to do transbasally. I think it's much safer, and you have really wide access to the tumor. Here's the incision, bicoronal incision, and we'll take the scalp in 2 layers using a galeocutaneous layer. Here we are raising the galea, leaving the pericranium on the skull, and then we'll harvest a very large vascularized pericranial flap. And again, elevating the flap after we've undermined it posteriorly behind the skin incision. And then here we are making a single burr hole over the superior sagittal sinus, eggshelling it, and then we'll make keyholes. We'll flap the temporalis muscle down just for a few centimeters and make a keyhole below the supratemporal line, and then run the foot-plated drill. And as we get down to the base, we're gonna, again, use the contour of the anterior skull base in the coronal plane and make a cut right down at the nasion. And here we're using a piezoelectric drill. My colleague PK Agarwal introduced me to this device. It's a little bit thinner than using a C1. And then after fracturing the inner sinus septum, we can elevate the elevate the bone flap in one piece. And then we'll make our U-shaped dural incision right down at the base. And I no longer need to tie off the sagittal sinus because there's no sagittal sinus. You could just buzz and then cut the falx down to the incisura. And then the advantage is you can go right down the middle and devascularize this tumor early. This is the later stage of the dissection where we're down by the planum sphenoidale, the limbus sphenoidale that is. And with these large tumors, you have to be careful because they do compress the optic nerves inferiorly, and the tumors can often creep into both optic canals. And so when these big tumors with the lion mane sign, they can be often subpial, but it's very important to get back into the extrapial plane, especially when you're dealing with the A2 vessels, because that's where the injury can happen. And then there'll be a little bit of rim of frontal lobe just over the optic nerves that you see here. And we inspected both optic canals, and there was microscopic tumor invasion into both. I didn't have to unroof the bony canal, but I could use just a ball tip Rhoton angled hook and just fish out the little microscopic tumor invasion. Here's the post-op scan. Immediately he had improved mental status. Vision went back to 20/20 in the immediate post-op period. And the advantage here is no CSF leak, no need for lumbar drain, intra or post-op. So for these olfactory groove, why do I choose the open approach? I think it gives you the widest exposure with a transbasal approach, especially when the dura attachment is lateral over the clinoids. You get better control of the A2 vessels, especially if there's encasement. You can use microdissection techniques. If there's a vascular injury, you have all the space in the world to do an anastomosis or a primary repair. There's lower risk of CSF leak. And if the tumor goes into the nasal cavity, you can address the sinonasal involvement from above. This is a tumor intra-op that you can see. There's no need for retractors because the tumor itself creates the corridor for you. And you can see you have excellent bilateral control of both optic canals, the ACAs, and the cribriform plate. And in this case, the tumor went through the cribriform plate into the ethmoid sinuses. And so you can achieve a Simpson grade 1, or even in this case, what Al-Mefti describes as a Simpson grade 0, where you get +2 centimeters of dural margin. So I think this is the advantage of doing a wide midline transbasal approach. Here's the patient 3 years post-op, no recurrence. Here's another example of a large meningioma. This was a grade 2 atypical. Look how it goes from one convexity to the other. Probably not a good idea for endonasal, and excellent cosmetic result. So I want to dispel some myths about the bifrontal approach. It's often criticized as having a big incision, big craniotomy, excessive bifrontal retraction, and venous infarction risk. That was described by Majid Sami, who then transitioned to a unilateral approach. But I want to dispel the myths. You can still get excellent cosmetic results if you do careful meticulous reconstruction and closure. You can still get great cosmesis. And here's a patient with a recurrent olfactory groove, 2 prior craniotomies, subtotal removal at a previous institution. And you can see the recurrence. And just like Juan's case, look at all the dents and divots in this patient's forehead, very unsightly. So we'll come back through the same incision, same exposure, and this time completely remove the tumor, decompress both optic nerves, and we can use bone cement and resurface and get a nice cosmetic result for this patient. How about excessive bifrontal retraction? Again, I said these big tumors can create the corridor for you. We want to avoid brain retracting with retractive forces, but as Dr. Fukushima has taught us, you use the retractors as brain holders. So we're holding the brain so it's not falling into our field, so you can be 2 hands, hands-free to do microdissection. How do I avoid the venous infarction and bridging veins? You need to make the dural incision low near the crista galli. So I use a U-shaped incision, and the bridging veins are often higher up. And so you avoid those bridging veins, and you can get, you can avoid venous infarction. I no longer tie off the frontal sagittal sinus. You can just coagulate and just divide it sharply into the falx. So I think the role for EEA for olfactory groove remains limited. This is a commentary I recently wrote. If you look at the review of the literature, the transcranial approaches have a higher rate of gross total resection, and there's a chance for olfaction preservation if the olfaction is preoperatively intact. And there is a lower rate of CSF leak ranging from 0 to 6% versus EEA reported literature 25 to 30%. This is the paper that we wrote looking at the open versus endonasal versus even combined approach in our own series. And of course, the transbasal and combined had a better gross total, or actually better rate of not having CSF leak compared to our EEA group. So here's an example of a patient with a large recurrent tumor in a young boy. This was a grade 2 operated elsewhere, invasive into the nasal cavity. Not uncommon for olfactory groove tumors to recur with a sinonasal invasion. Sergei Spector had a nice paper on that in the Red Journal some years ago. And in these cases, I think this is the role where EEA can complement the transbasal approach using a combined approach, because this patient has no pericranial flap available. So you need a reconstructive solution, and that's where the EEA can help with using a nasoseptal flap. These combined approaches are useful for sinonasal malignancies. Here's an example of a rare tumor. This is a teratocarcinosarcoma, very aggressive tumor with bifrontal invasion. So you have wide exposure here. We can dissect the tumor away from the brain in a subpial fashion. This has invaded the brain. So you go into the subpial space and separate the tumor from the frontal lobes bilaterally and debulk the tumor. This is quite friable, hemorrhagic. And then here's the optic nerves. We've removed all of the tumor intracranially. Now we have to go ahead and address the tumor in the nasal cavity. So what I like to do here is I like to cut out the dura of the ethmoidal plate, cribriform plate. And so I make a cuff right at the back at the posterior planum sphenoidalis, so you have a nice dural cuff. We want to make sure we get nice clean margins for this malignancy. This is cancer surgery. So I then sew in a primary graft in watertight fashion. And what this does is you've now isolated the brain. You've taken care of the brain. Now what you have left is the nasal cavity. So now you can go ahead and remove the rest of this. You have the option of continuing from above, or you can come from below, or you can do both. You can do a lot of this all from above, which is what we did here. And you can make your cuts. I make a little osteotomies. I drill off part of the orbital roof, follow the periorbita, and then you have to disarticulate this from the nasal septum. And I think this is faster than trying to debulk it piecemeal from below with an endoscope. But after you removed all this, you have this nice view of the hard palate. And the endoscope is helpful now because you can use the endoscope to inspect in the nasal cavity, which you can probably see better blind spots than from above. Here we're looking into the maxillary sinus. And the repair here, you can just stick with a single layer repair with a pericranial flap. But in this case, we decided to do a double flap repair for belts and suspenders, especially when you're dealing with a cancer and malignancy where you anticipate additional radiation therapy. We developed reported the double flap technique with a flap from above and a nasal septal flap from below. And we recently published our series of 9 patients in ACTA, where 7 patients had radiation therapy and there was no CSF leak or flap necrosis. So I think this double flap repair, like we did in this esthesioneuroblastoma, can be a useful tool. So when do we do EEA from below for sinonasal malignancies? I think when there's limited intracranial involvement, like this esthesio, this is very ideal for endonasal approach, transcribiform corridor. And what about this adenoid cystic carcinoma with orbital invasion? Some may argue that with this type of orbital invasion, if you talk to a head and neck cancer perspective, they may advocate, well, you need to do the more radical resection. Sometimes you may even need to resect the eye. So I think this is what we used to do early on in training, but I think now we've taken taken quality of life perspective, and I think we can still do a very nice resection oncologically and preserve the eye. So this is one we chose to do endonasally. Here we are going through a single nostril on the left side, taking out the tumor, debulking the tumor with a microdebrider in the left nostril. And then we'll go ahead and do a medial maxillectomy. And then we'll follow the tumor through the ethmoid into the frontal sinus, and then we'll do a superior septectomy. And this maneuver allows you to go binostril, two-handed approach. And as a neurosurgeon, this makes it easier to work into both nostrils where you have access of the cribriform plate. Here's the frontal sinus. We do a draft 3 or a modified Lothrop procedure. And this is important because identifying the posterior table of the frontal sinus allows you to have a margin of where the anterior margin of the tumor is. But this posterior table also serves as a shelf to allow you to put the nasal septal flap to rest on native bone. So here's the dura exposed. We'll make the dural incisions longitudinally on both sides and then transversely at the anterior margin. And then you transect the falx cerebri, and then you mobilize the cribriform dura from anterior to posterior so that the remaining cut now is a transverse cut posteriorly. After you ligate the olfactory tracts, you can then cut the dura transversely on the posterior side. I think doing it in this order is much easier. It's ergonomic. And then here's the repair. We'll do a fascia lata inlay followed by another big alloderm, the Cassiano plug, I call it. It's described by Roy Cassiano. It's a alloderm plug where you plug it much like a gasket with gel foam, and you get sort of an inlay and overlay approach. And before we put up the nasal septal flap, I like to do this repair first, so then we can address the orbital invasion. Because once you open up the orbit, you'll get fat herniating out into your field. So we'll go ahead and do two-handed dissection. This had a nice encapsulated plane on the tumor where we can use two-handed dissection to remove the orbital tumor. And then we'll go ahead and then put up the nasoseptal flap. And so this is the patient 5 years post-op after radiation therapy. So I think we can still save the eye in some of these cases and still get a nice oncological result. This is the schematic of the triple layer repair. And when we initially described it, we had a 0% leak. But of course, as you do more of these cases, you start to get leaks. And we thought, well, how can we make this flap better from below? It's such a difficult reach to get anteriorly. And so we developed this relaxing incision where you make an oblique cut so that it relaxes the tension across this sphenoidal segment where you can get more anterior reach, but then this redundant part can be rotated posteriorly to make very nice contact with the planum sphenoidale. And I'll show you this in this olfactory groove meningioma that we decided to do endonasally. This was a smaller tumor. Olfaction was already gone. And so these defects are a little bit smaller. So instead of using fascia lata, I'll just do a double layered alloderm repair, double layered inlay. And then you'll see the nasoseptal flap here. We're gonna pull it, see how it retracts posteriorly? It's under a lot of tension. So we make this little oblique incision just above the floor of the sphenoid. You do it in a very incremental fashion and you size it up, and you can see how there's no more tension, but I can put the flap all the way to the posterior table of the frontal sinus. And that redundant part posteriorly rotates upwards up against the planum. Now, some may argue, well, did you devascularize it? I guess we've been pretty lucky. I guess maybe if I had the Paul Gardner ICG scope, we can test to see if the vascular pedicle is there. I've tried Dopplering these pedicles. You don't, and I think the vessel's so small, you don't really hear an audible Doppler. Maybe some people have other experiences, but I think that technique has been very useful. Lastly, I just want to cover craniopharyngiomas. This is one approach you can consider. I think for the most part, the majority of these in my series, close to 85%, are all done endonasally. And that's because you have this great ability to visualize the undersurface of the optic nerves and the chiasm and those vascular perforators that Juan talked about from the hypophyseal, superior hypophyseal. That is really important to save vision. So here's an example. This is a craniopharyngioma in a young child. And we'll debulk the tumor with this Nico aspirator. And then there's the chiasm. And so again, we can work all in this infrachiasmatic space. We have great visualization of the hypothalamus, and you could do two-handed dissection off the hypothalamus under direct vision. So you, in my opinion, I think in theory, there's probably less injury to the hypothalamus when we're dealing with craniopharyngiomas. And it's important to resist the temptation to want to pull on the tumor until you inspect all of the tumor attachments, make sure it's completely released from all the neural structures, and then you can deliver it nicely, and you get this great view of the third ventricle and cerebral aqueduct. And with a 30-degree scope, we can see the pulsations of the membrane of Lilliquist and the top of the basilar and so forth. And so here's an example of an endonasal, but when do you choose the open approach, trans-basal? Here's a case I did trans-basally where you see how the tumor doesn't present itself to the sellar cavity. It's all above the diaphragm. And if you look at the window above the chiasm, the translamina terminalis window, it's slightly bigger than the infrachiasmatic window. So in this case, I chose a trans-basal approach. Here we are opening the lamina terminalis, and you can get great access to this tumor. What's nice about the trans-basal, as opposed to, say, a anterolateral Arterional approach, is that you get bilateral symmetric visualization of both walls of the third ventricle and the hypothalamus. It's not an oblique view. Here's the view of the basilar artery, and here's the post-op scan. So another example of the trans-basal approach is when you have this large tumor encasing the A2 vessels. So coming endonasally will be very difficult to get good vascular control. And if you have an injury, it's going to be hard to repair. But with an open approach, you can see you go interhemispheric. Here's the cystic tumor wrapped around these A2s and A3s. You can do careful microdissection. We follow the tumor into the lamina terminalis and remove that portion of the tumor. There was some tumor stuck to the chiasm I couldn't get off, but I removed about 95% of this tumor. And of course, at 3 months, she comes back to the ER and that cystic part in the retrochiasmatic region has recurred. But you have the option now of going endonasally, going into that retrochiasmatic region. This tumor we readily removed. There's a thick rim of calcium adherent to the chiasm I left behind. And we were able to repair this with a nasoseptal flap. And when I know there's microscopic residual, I like to do early postoperative radiation therapy. When I mean early, I'm talking about 3 to 6 months. And she's been about 6 years now, no recurrence. Lastly, I'll show this case. This is a case with this large cystic component and a solid component in the retrochiasmatic region. I debated for quite some time whether I should come at this transbasally or come at this endonasally or combine. But what I eventually decided was the vision was at threat and I could get a better visual outcome if I come from below. So we came from below and you'll see here, this tumor was quite invasive. Look at how the tumor has encased the ACOMs. It actually wraps over the right optic nerve and into that frontal lobe to create that frontal lobe cyst. So here, intraoperatively, I already know I'm not going to be able to get a complete removal. So I might as well try to get the maximal removal and save the pituitary gland because her pituitary function is normal pre-op. So there's no need to sacrifice. Here's the tumor wrapped around the optic. So we're gonna carefully divide that segment. So now we've isolated the right optic nerve. We'll come around the top of the tumor. How do we find there's the PCOM on the right. How do we find the pituitary gland? Here's the stalk. Here's the stalk. Look for the portal striations. And there's the basilar artery in the back. We preserve the membrane umbilicus so that you preserve those P1 perforators. There's no need to open up the membrane umbilicus. Most of these tumors will respect that. And so using sharp dissection, we'll disconnect the remainder of this tumor, peel it off of the basilar apex. And here's the pituitary gland. Here's the pituitary stalk. We'll preserve the stalk in this case because I know I'm not going to be able to remove all of the tumor. And then here's this cavity. You can see microinvasion over the ACOM, big frontal lobe cyst. And I'm not going to be able to resect that. So I initially watched it. Here's the cyst decompressed. And here's at 3 months. I know there's residual tumor and I have the option of coming back from above. But I decided, these things respond quite well to radiation. So I subjected her to radiation therapy and you could see the tumor has regressed quite a bit, almost to minimal enhancement. And we published this recently. So I'll conclude here with that my message is that the endoscope is just an important tool, a useful tool in our armamentarium. Patient selection is very important and we have to tailor our approach to each patient because it may not be appropriate for all pathologies. Like Bo Jackson, who was a 2-sport athlete, I think in the contemporary skull-based surgery field, we got to have expertise in both techniques. And sometimes you have to apply both using multi-corridor surgery. And I thank you for your attention.
Thanks, James. That was a great talk. I just, Danny, you're with us, right? So let's get ready and get you up. But I'm just gonna comment, James, that I actually love that modified transbasal subfrontal approach, as you saw at the beginning for olfactory with meningiomas that are giant or very large. And I think it makes it sort of defines who is a skull surgeon versus a general surgeon doing these olfactory group meningiomas, because some of them want to avoid, exposing the frontal sinus when, actually you just want to cranialize the frontal sinus. It gives you an excellent approach to the base of the skull, right, without having to do any retraction. So beautiful approach.
Thank you. I think you make a good point there, Juan, about the frontal sinus. I think in general, when we go through residency, there's always this fear of not getting into the frontal sinus. And I think as skull-based surgeons, we don't have that fear. We just know how to deal with it and how to, when to enter it.
But then you have general cranial surgeons that don't, have those techniques incorporated. They do this bifrontal craniotomies with frontal lobe retraction, and that's why this bifrontal approach is so stigmatized, because it's not done properly as a scopus approach, in my opinion. So thank you, James. That's great. Hey, Danny.
One quick question, James. I've also used this one-piece approach that you published on and like that. My question was, in the setting of a small frontal sinus, if I need to get to the nasofrontal suture, in the past I've just gone to the bar, and I was curious, do you still manage to do this one piece, or do you go to a bar if there's a small frontal sinus?
Yeah, that's a good question. I think I've had maybe one case with a small frontal sinus, but I was still able to manage. I think it was a little bit more work in terms of using an osteotome to kind of slowly get it off. But eventually you can still, but you can always do a bar if needed as an option.
Well, Danny, welcome. Thanks for joining us.
Yeah, thank you. Thanks so much.
He needs no introduction. You know, he's a longtime friend, and you know, someone that I trained with long ago, and you know, it's so good to have you.
Yeah. Well, thanks so much. Congratulations on this initiative. Looks great. A lot of people participating, and I'll try to let me share my screen here.
Yes, next speakers, all of you guys, including me, of course. Let's see if we can type the time. You know, 15, 20 minutes for the lectures, because otherwise we're going to run out of time.
Yeah, I'll try my best here. I tried to simplify it to keep it under 20 minutes, which was what was given to me. And I think this is it's a great sequence, because what I'm going to try to show here is really our philosophy when dealing with anterior skull base. I decided to focus on meningiomas exactly just because of the time. And I think that's the most important aspect in terms of the controversies related to the anterior skull base. And I heard, I was present as an attendee earlier when you guys were talking about some meningiomas of the anterior skull base. So I'll try to give my insight as well. So when we, as a principle, when we go endonasal, we do follow all the principles of skull base with less retraction, by manual resection, working as a team. And I really love this picture where we transform the skull base tumor, when come endonasal, we transform it into a convexy tumor. I think that's a great way to explain the advantage of endonasal with early devascularization. And for small tumors, we can get a Simpson 1. And of course, as the tumor gets bigger is when it gets more confusion or controversy in what to do. And as Jean Lou was presenting the vascularized reconstruction, it doesn't matter if you go open or endonasal, it's the way to do. So I decided to just start talking more of the tuberculum cellular meningiomas first, and that's why I started with endonasal, because I think for the tuberculum cellular meningiomas, it's really, for the most part, we will be indicating and performing an endoscopic endonasal transcellular transtuberculum and sometimes transplanum approach. And very important in terms of anatomy correlation here is to get a wide exposure. I think this was mentioned by Kumar in his talk as well, that the limited exposure ends up being the factor of leaving residual behind. And when we do these cases, we very often will expose the medial aspect of the optic canal, and we would remove the bone of the carotid arteries as the carotid arteries enter the suprasellar space, exposing the distal ring. And because that gives you a full control of the anterior skull base and the suprasellar space. And I'm not going to go much into this. Kumar mentioned beautifully the importance of the superior hypophyseal arteries. And that's exactly like the key here in these cases. And in my opinion, there's two aspects when comparing endonasal and open approaches. So when we do open approaches, like a frontal orbital approach to this region, to this, like a tuberculum cellular meningioma, the main limitation is the disease under the optic nerve, that ipsilateral optic nerve. It becomes in this region here a problem. And I'll tell you the other problem, not only by manipulation of the optic nerve is actually the visualization of the ipsilateral hypophyseal artery. If the tumor is large, it becomes difficult as well. And that's when there is a chance of damaging that superior hypophyseal artery coming with a craniotomy versus an endonasal that you have a more direct visualization and you see both aspects of the inferior aspect of the optic nerves, and you're able to see bilateral hypophyseal arteries. So for the most part, tumors like this, that really like a tuberculum cella or diaphragma cella pushing the structure superiorly, we will indicate endoscopic endonasal surgery. One of the questions that people ask, okay, how about a case where the tumor invades the optic canal? And like this one here, you can see the optic canal invasion. And that's very important to be complete here. Let me just go back here for a second. And by coming endonasal, it's possible to open the optic canal. So here you can see how we use two techniques. I design a blade that you can actually open this, and that works very well. And this is the example using the scissors there. Can you still hear me okay?
Very well. We can hear you very well.
Okay, and then here's the other technique that we've been using. It's utilization of this. That's all right. Just a second here. See what's going on here, the video. That's all right, I'll pass that. So for the most part, the main question that I have when I indicate surgery, endonasal or open approach is really the lateral extension of these tumors. And it's not as much as the lateral extension posteriorly, but really on top of the optic canals. I think that's what becomes the difficult area for this, because you cannot retract the optic canals laterally. Differently, when you're performing a resection of a tumor that is more anterior on the skull base, you can actually retract the orbits, and the periorbit you can retract the lateral. We just did that yesterday in a olfactory groove meningioma. But if the tumor is located on top of the clinoids and on top of the optic nerves, then that you cannot retract that laterally, and that becomes the limitation. So again, these are just some examples of tumors that we perform endonasal. The people ask about the vascular encasement. It's not a full limitation in my opinion, but of course it's easier to deal with vascular encasement with a craniotomy than endonasal for most people. So it becomes a relative indication. These are post-operative on these tuberculum cella meningiomas. We always look at the post-operative MRI, make sure the flap is alive there with the enhancement, and then the pituitary gland is enhancing as well. So then you start seeing tumors that are a little larger. So this is an interesting tumor because it has an anterior skull-base projection on the planum and has an extension in the sylvian fissure. But interestingly, it did not have an extension on top of the clinoids. It was more like located in the midline and going more posteriorly. It was even touching the basilar artery posteriorly there. But it was round in the front and actually didn't have implantation on the clinoid. So this is the first case that I decided to offer the patient a possibility of a two-stage surgery. I was thinking, you know, like it will be very difficult to remove this lateral extension around the sylvian fissure. I explained to the family, the patient was around 48 and almost basically functionally blind. I thought if I came in with a craniotomy, it will be very difficult to keep the vision as the same for the patient or to improve. So interestingly, we performed this, and we were able actually to rotate, as you can see here, the tumor away from the sylvian fissure. We dissected from the optic nerves, two-hand technique, and preserving the arachnoid behind. And by having a great exposure, we were actually able to mobilize the whole tumor out of there. You can see the anterior cerebral arteries You see the superior hypophyseal being preserved here on the patient's right and on the patient's left. So the vascular supply to the optic nerves, you see, were very compromised already. This patient was almost blind. But we were able actually to get a full resection with only one approach, endonasal. And that was one of the cases that taught me, you know, the importance of the lateral extension. Actually, the problem is anterior cline and not as much if it is posteriorly going into the direction of the sylvian fissure, because you can actually have an angle to go there and dissect. And this is the post-op of that patient. Again, we always look at the enhancement of the flap and the pituitary gland as well. This is a case that I got this year, actually, when COVID started. And there was all this question about endonasal, and I was debating, should I do endonasal in this case or open approach? Of course, the presence of the COVID and all that fear that was going on made me just don't think it twice. And we decided to go craniotomy for this case. We did a frontal orbital coming from the right. You see the optic nerve was really pushed here laterally. But the main aspect here, I think, even if it was not related to the COVID, I would still do open approaches because of this presentation here. You can see that on the left side, it gets to the medial aspect of the optic canal, but on the right side, there is like a few millimeters more lateral extension. This dark area here is the optic nerve. So all this is really inserted more laterally. And we did a frontal orbital that I call frontal orbital temporal coming from the right side, lateral approach. I like the lateral approach, Jim Liu, because I like to see, for all these anterior skull-based meningiomas, I like to see the optic nerve chiasm from lateral aspect. And I don't like much the frontal view. I'd like you to comment on that as well later, because I feel that if you come from the front, it becomes difficult to visualize the optics at the end. And plus, if there's encasement on the anterior circulation, when I come
I think we lost him.
lateral, I can actually free that up, and we were able to state the patient. And this is true. Like we don't do endonasal just because the tumor is small. This is a case that we carefully identified that the tumor was actually going on top of the optic canal. So because of that, we came with an eyebrow actually in this case, and we did a small subfrontal approach coming directly into that area and got a complete resection for the tumor for the patient, complete of the tumor resection and coming directly into that, because the tumor again was pushing the optic nerve inferiorly. So if you go endonasal, you see the optic nerve first, and that doesn't make any sense. So going more to the anterior skull base now, we have to consider when you go tumor on the plano and on top of the olfactory groove, we have to consider olfaction, like Jim Liu was mentioning. You know, if the olfaction is already gone, then we will consider endonasal. And if the olfaction is still present, usually we use some unilateral approaches to try to preserve olfaction. One of the advantages of endonasal is the fact that we get the anterior and posterior ethmoidal arteries very early in the case, and we can devascularize the tumor completely. I just did one case yesterday. It was beautiful. The entire tumor was basically vascular coming endonasal after this, after the devascularization. So we consider transplanal approach behind the posterior ethmoidal arteries and all the way to the optic apparatus, and cribiform when is more anteriorly there. So this is an example of a patient that had a normal smell, and we're still able to get endonasal in these cases because it got to the anterior limit here. The olfactory groove is normal. So I'm not going to go in much detail here. Like if you do an open frontal orbital approach, I think in this patient will be very appropriate because the patient is has normal smell. I definitely are going to be honest. I suffered in this case by doing the entire surgery with a 45-degree endoscope in order to preserve the anatomy below the olfactory groove without the innervation there. And here's just an example of that surgery. And we, this is the cella down here. We opened the cistern, the meningioma is there. And here where we are using the 45-degree endoscope, that olfactory nerve on the left was very compromised. Have to pay attention always with the frontopolars, they can travel the tumor. Here we're dissecting. It has to be the same surgeon when you come endonasal for these patients. And here we're dissecting that frontopolar, freeing up, going 360 around the tumor. And just based on the time here, what I want to show you is the importance that we were able to preserve here the olfactory nerve on the right side. So after the tumor came out, if you look at here, there was some PA invasion, but you can see right there, that's the olfactory nerve. And anteriorly here, the mucosa was out completely preserved. In this patient, we were able to do endonasal and preserve the smell. You can see the septum anteriorly we had to preserve, but again, it was difficult to do that, but you can see complete resection. This lady is already 8-9 years post-op and no recurrence. So these we were able to get a complete resection, preserve her smell. When the smell is not present, like cases like this, then I always look at that lateral extension. If the smell is gone and there's no encasement, no lateral, like on top of the optic canals, these we will prefer going endonasal. And this is an example here, post-op on that case. That's what we prefer. I think there is definitely less manipulation of the frontal lobes doing that. This is another example, particularly if there's a lot of edema. I think there is more, you end up fighting more with the brain when you come with a craniotomy. So that's what we prefer coming endonasal. This is a completely endonasal resection. The flare changes completely disappear after surgery in most cases, or end up with a very small footprint there. So this is a side view here with you can see the flap reconstruction on these cases. This is the case I just did yesterday. I put it here, I don't have the post-op MRI yet, but you can see that even with extension very lateral on the anterior skull base, as long as it doesn't go lateral to the meridian of the orbit, we still consider endonasal. Patient had 2 years history of no smell. So we came with an endonasal and resect that yesterday. This is the post-op CT just done yesterday. We got a complete resection, no problems. There was no involvement of the anterior circulation, just a small vessel that I had to sacrifice, but it was really very small arterial branch. We published on this, and other published as well, the fact that we were able to get these tumors out and really diminish or avoid cephalomalacia by removing them through the nose. So anytime that I feel we can remove through the nose, I think is an advantage for the patient. Sometimes we see situations like this, and that's when it start getting more complex. This is a patient that I actually did in 2 endonasal stages, and it had a lot of invasion and surrounding the anterior circulation. But that was not the problem for the surgery. The problem was really this implantation lateral to the clinoid here. And that's when, I'm not gonna go into the detail here, but the important aspect of really for these cases, if you do endonasal or open, is to get proximal control of the anterior circulation there. So let me just show you the aspect here. This is the moment where we were able to dissect and follow the A1s and encounter the ACOM by coming endonasal. And we're able actually to dissect carefully around those vessels. So that was not the problem. Here you can see the full dissection of the tumor. We were able to get everything we could see. And this is the aspect. So if you look at the anterior clinoid, I left a very, very small residual there. And he did great. He improved all his symptoms. Vision was great. But 5 years later, he comes with this recurrence there. I was watching every year, to be honest, like seeing that residual growing. And I recently did a craniotomy to resect. I think, Ahmed, I see you there. I think you were with me when we went back for this, this tumor. But again, this shows the fact that it's not ideal for tumors that is spilled on top of the optic canals, the endonasal, and the fact that the open approach complements for that region. So just quickly, just showing some examples here. This is a patient with normal smell with a very lateral extension of the tumor. So in this case, with edema on the patient's left, we decided to come with a right side frontal orbital craniotomy here. We use an eyebrow. We went subfrontal there, and we got a complete resection of that tumor. And we were able to preserve the smell for the patient coming in unilateral. So that shows as an example. This is a patient that I met 10 years after this MRI. This MRI was done when the patient came at Ohio State, was operated by another surgeon and who is not here at Ohio State anymore. And it did a good job. You see, there was some edema on this brain. And after the surgery, edema is there, a little bit of increase in cephalomalacia, but no major DWI. Yeah, it took a very good resection, but I want to call attention for this hyperostosis here that was left behind in the post-op MRI. And 10 years later, lost follow-up, and the patient came to me losing vision, now with a recurrence of the anterior skull base, completely out of that hyperostosis and with a component in the tuberculum sella as well. You can see the bicoronal that was done before. So in this case, there was no question. We came endonasal to complement the residue that was left and grew from the previous surgery. And this is the post-op for this patient. And the patient is doing very well, actually recovered vision to normalized after surgery. Here's one thing that we've been doing now for tumors that go very lateral with a lot of hyperostosis. Instead of, doing an endonasal that will leave residual or a craniotomy that will be very like a large approach, fighting with the edema and dealing with the vascularization of these tumors and a hyperostosis that goes all the way through the nose. So we've been doing this in 2 stages. I know you guys discussed a little bit earlier. The way I do, we will come endonasal, drill the entire hyperostosis, ligate the anterior and posterior ethmoidal arteries, and I perform a debulking of the center of the tumor without touching the interface between brain and tumor. The idea is to avoid scar formation in the area that you're going to leave for the second stage. So you're not doing the surgery like with an attempt to, let's see if I can take it out. I tell the patients, no, it's going to be in 2 stages. So we go 1 stage, do that, put the flap, and this is the way it looks like after that. So the tumor collapses. We have the flap covering it up. The tumor becomes less vascular. And then we come with a unilateral small craniotomy without the need for big resection to then take the tumor out. Here's an example, another example. So when we come with a frontolateral approach, now for resection of these tumors, I like to open a little bit of the Sylvian fissure. This is the taking the veins at the surface there. And the aspect that I like here is to encounter the optic nerve early, then debulk to get the weight of the tumor away. You see the optic nerve here. We will debulk with an ultrasonic aspirator, and then I go behind. This is what I want to see your opinion at, Jim, because I prefer much more roll from lateral with that lateral view after I debulk, because then I can see the posterior surface. I follow the chiasm, and I encounter back here as I follow the brain. I get to the midline, and then I'm able to encounter the anterior circulation, and I feel that that's a safe way. And this imaging here now, I'm exactly at the interhemispheric fissure, looking for the anterior circulation, the anterior cerebral arteries, and then I roll the tumor forward. Here I'm getting the tumor from the contralateral optic canal as well. And then in one point, you can see here the vessels, and I work from behind by rolling the tumor forward. And then with that maneuver, you can see I'm not using any retractor. The fact that we debulk the tumor, devascularize in the first surgery, really helpful. And then we are able to get the tumor through a frontal orbital craniotomy, complementing the resection. And then the beauty is that you see actually the flap from the top, the ventral aspect. And here you can see at the end of the surgery, the optic nerve here on the right side, the left side there, make sure that we got everything. And here, the full resection of the tumor with the patient improving visualization. So that's what I prefer for the large tumors. They're kind of compromise both areas. And this is another example of post-op by coming endonasal with the flap reconstruction and a small craniotomy resection of that tumor there. So this is what I had to say, Juan. I think hopefully we're able to give an overview for those interested. We have hopefully we'll be able to offer a course here in April of next year. We're started like getting worried about like the chronic problem of society now with COVID. And I just want to give one more message. As you know, we got postponed for our NASBS meeting. It will be now in 2022. And Saturday, I believe is Saturday, the 14th February, we will, or 13th, we will have a symposium, an ASBS symposium virtually this 2021. And again, the meeting, as we know, is going to be 2022 in Phoenix area. So thanks so much.
Wonderful, Danny. Great talk. Tremendous expertise on skull base meningiomas. So thank you for sharing. We have Dr. Garner next with us. Paul, are you up? He needs also no introduction. I'd rather not do the introduction.
All right, there we go.
There you go.
Thank you. I want to congratulate Dr. Fernandez-Miranda on this entire meeting. It's absolutely stunning what we put together, and I think for all of us, we learned from each day of this, and I encourage everyone to watch all of the sessions, both this weekend and next weekend, as I know I'm doing and will be doing. I've been given the task of talking about endoscopic endonasal and extended middle fossa approaches. I'm going to focus just a little bit on the Petrous, because I think there are aspects of each approach which aren't really a crossover area, but I think this meeting and today's especially has done a beautiful job of showing the complementarity between the different approaches, and I think that that's a very important aspect of it. Just brief disclosure is not relevant to this discussion. As Juan mentioned, endonasal and transcranial are not versus each other, but rather are two approaches that we should all have available to ourselves. The area of the Petrous bone and Petrous apex is a challenge for all skull-based surgeons, regardless of which approach you take, given its multiple neurovascular structures surrounding that area and the difficulty and depth in reaching it. This is the classic area that we're used to accessing through an open approach of the Petrous apex. And of course, this is an image by the great Rhoton. The Petrous apex, though, can be approached from many different approaches, not just an open transcranial approach. And I think it's important to understand the different ways in accessing that. The endonasal approach to the Petrous apex can be a very direct approach. I think most of us started using this for cholesterol granulomas as a very nice option to access it. But understanding how do you get to that area, how do we get to these so-called coronal plane areas is very important. And for the so-called trans-pterygoid approach, we're talking about accessing through an extended maxillary antrostomy. So the maxillary sinus really becomes your window. We can do everything in endoscopic medial maxillectomy to have very wide access. And the more of that anteriorly you come on the medial maxilla, the more lateral you can access in the infratemporal fossa and middle fossa. These are the steps of the trans-pterygoid approach. They include that maxillary antrostomy, and then you have to deal with the sphenopalatine and the pterygopalatine space, and then finally drilling the base of the pterygoid. Important to understand the contents of the pterygopalatine fossa. If you're not concerned about preserving vascular pedicles, we just have to make sure that we can control the IMAX, and many times perhaps a preoperative embolization is a good option. But it's really critical to understand the infraorbital nerve, which you see here coming, V2 coming into the infraorbital, and the descending palatine branch to avoid deficits for the patient. Here we can see initial access to the sphenoid and maxillary antrostomy, where the sphenopalatine, and here we see the palatovaginal artery extending inferiorly to the nasopharynx, which is a beautiful landmark to the Vidian. Once we open up widely the posterior wall of the maxilla, again, we're looking on the right side, the posterior wall of the maxilla here has been removed. We can then dissect through the pterygopalatine space and start to see here coming into view the infraorbital nerve. And then dissect out the pterygopalatine fossa. Here we see a large IMAX branch. This can be coagulated or dissected laterally. And here we see the infraorbital branch and then descending palatine, which will be critical to preserve if we want to preserve palatal sensation. This is a view more from a medial approach. Here we can see the sphenoidotomy and the so-called pterygoid wedge with the Vidian nerve at the base of the pterygoid wedge as a beautiful landmark for many of the critical aspects, including the horizontal Petrous carotid artery. Understanding the relationship of the pterygopalatine fossa and the pterygopalatine contents to the pterygoid base and the pterygoid plates is key to understanding the trans-pterygoid approach and also trans-Petrous approaches. Even perhaps more important is the Petrous internal carotid artery. Again, in this other beautiful view from the Rhoton collection, if you see the different segments of the Petrous carotid artery, they define our access to the Petrous and the parasagittal planes. Of course, the main segments are the parapharyngeal, the horizontal Petrous, the paraclival, and the paraclinoidal segments of the carotid artery. These are the different landmarks that I use. Of course, the paraclinoidal has a so-called medial OCR, which is the keyhole to the endonasal parasellar craniotomy. And then the anterior genu of the carotid at foramen lacerum, that medial pterygoid wedge really points directly back to that anterior genu. And then finally, the Vidian nerve crosses over the horizontal segment, and the eustachian tube attachment leads back to the ascending or parapharyngeal carotid artery. These landmarks are critical for understanding this area, but as we start to get comfortable working around the paraclival carotid artery, we can understand that immediately posterior to it lies the Petrous apex and the Petrous bone. This is really the key. It often is accompanied by a transclival approach, and you'll see in contrast to an open extended middle fossa approach, endonasal gives us the medial portal to the transclival and then transpetrous approach. Like with open approaches, there is a triangle that we can use to access the Petrous bone and the Petrous apex here. The boundaries of this triangle are the sixth nerve, anteriorly the paraclival carotid artery, and inferiorly the petroclival synchondrosis or fissure. And working in this area can give us really very wide access. Many tumors grow and expand this triangle to give us access into the Petrous bone. Here's an example of a chondrosarcoma we see on the scan there on the left. And we're using that triangle to access the Petrous apex and the Petrous body. And that's what really gives us access to resect completely this tumor. Here's an example of a recurrent cholesterol granuloma that Dr. Fernandez-Miranda actually did, and showing the beautiful access, again, behind foramen lacerum, between the petroclival junction, below the sixth nerve, and posterior to the horizontal or paraclival, vertical or paraclival carotid artery. Here he is removing a stent from that space. And this is a multiply recurrent cholesterol granuloma. But we can see here how this access through the triangle into the Petrous bone gives us a beautiful access to completely drain this cyst. So here's an example of a relatively simple access to the Petrous through endoscopic endonasal approach. By comparison, an anterior transpetrosal or an extension, again, I'm going to focus on the aspect of the middle fossa that relates to the anterior Petrous bone, because really an endonasal approach doesn't have good access to the IAC, doesn't have good access to the arcuate eminence, and so it doesn't become as relevant as those are areas that are clearly owned by an extended middle fossa approach. Of course, this starts with either we can use a more extended approach like this or the more minimalistic incision that Maria showed earlier. Interfascial dissection, understanding how to preserve the frontalis branch is, of course, a critical part of any approach here. If we want to come more anterior or anterior pretemporal, sacrificing the meningoorbital fold to have access to peel the cavernous sinus is a key extension of this. But in the end, the access we're looking at is by peeling Meckel's cave, having access to the middle fossa floor, all the way from the arcuate eminence to foramen ovale. This then gives us access to the classic triangles. And here we can see, of course, the rhomboid for the modified Dolan-Kawase rhomboid that gives us complete control of the Petrous apex from this extended middle fossa approach. And here's the drilling of that extended middle fossa, exposing the carotid artery, drilling just anterior to the IAC, and all the way back to the posterior fossa. Once the superior petrosal sinus is ligated and the tentorium cut, we can have access all the way from the posterior fossa, from the IAC anteriorly up to the porus trigeminus. And this really is the beauty of this approach, is this most lateral access, as well as access to the superior aspect of the Petrous apex. Here's an interesting case, a multiply recurrent meningitis, where this meningoencephalocele kept leaking endonasally into the nasopharynx and oropharynx. And she had undergone a standard temporal craniotomy because this was thought perhaps to be a tegment defect, but it's really not. She'd also undergone an endonasal repair of the lateral sphenoid, but it wasn't leaking there. And it turns out this was leaking through the posterior aspect of Meckel's cave from the Petrous bone, and then eventually percolating back into the eustachian tube. So I thought because she had failed multiple attempts, we really should do a middle fossa approach to give her a give me maximal access to the root of this meningocele in order to be able to pack it off. We're using this extended middle fossa approach. Drilling out, I think a nice trick here is to completely decompress V3. Here we're, of course, sacrificing the orbital band to start our peeling of the cavernous sinus. I think this gives us a little better ability to gently retract the temporal lobe if we do this initial dissection. It also gives me a nice view of the attachments of V2 and V3 so I can peel Meckel's cave. Here we are dividing the middle meningeal artery. You often want to do this in the most controlled fashion possible, but now we see foramen spinosum. We start to peel Meckel's cave. And this gives us complete access now to the middle fossa floor, Meckel's cave. Here we can identify GSPN with a cartouche dissector, sharply dissecting and disconnecting the dural attachment of the periosteal dura to V2 and V3. And oftentimes here, I'll just coagulate back the dura and let the dura do the retraction. You can see I don't use a static retractor in a case like this until I get to the point where I need to drill the anterior Petrous bone. Here we can see our landmarks for the Petrous rhomboid. We can see how actually this meningocele has worn away. Now the repair previously was simply done by placing a bit of tissue on top of this, but the true defect is actually deep and posterior. So by doing this kind of a dissection on the posterior aspect of V3 into this meningocele, which is really extending into the posterior fossa, and here I'm using endoscope assistance along with this basically Petrosectomy that's been performed by the meningocele. It allows me to visualize the porous trigeminus, and then I can pack this off completely with muscle and fat to ensure that I seal the leak. I chose relatively simple cases for both of these just to show conceptually the access. And hopefully if we have time, I can review some cases later to get the group's opinion as to different ways that they would approach different cases from open versus endonasal approaches. Approach selection really should vary, not just by the location, but by the pathology and the goal of surgery. So different pathology have different goals. A clusteral granuloma, I just want to drain it. Something like a chondrosarcoma, complete resection is critical. And then petroclival meningiomas, I think really require often subtotal resection to allow for neural preservation. The petroclival region also is impacted by this. Chondrosarcoma that classically arrive from the petroclival synchondrosis and extend into the petrous apex. Again, here we see this medial triangle, which has been dramatically expanded by this tumor all the way to the clival dura. And we can peel the tumor out completely. In the interest of time, I'll cut through and just show the final result of this. But here we can see the sixth nerve anteriorly, paraclival carotid artery, we've been dissected completely, and the petroclival synchondrosis inferiorly. And here we're using a sonopet to remove a portion of the involved petrous apex to ensure a radical resection, removing dura below the porus. And we'll see the fifth nerve come into view at the end. Here we see the fifth nerve going out into the porous trigeminus. So the exact same kind of view as we have from that open approach, but better access to the clival region as opposed to access to the IAC. Chondrosarcomas, of course, require every possible approach. And you see even in our series, a fair number of these require a craniotomy. Here we see the outcomes of that for petroclival. Now, where do we have residual with endoscopic endonasal approaches? Where larger tumors can be more challenging, but especially involvement of the middle cranial fossa, the lateral aspect of the cavernous sinus, and the CP angle, all of these sort of make sense and are clearly complementary to an extended middle fossa approach. Many of these, as I mentioned, require staging with a secondary or a primary craniotomy. As all of our friend Jacques Morcos reminds us, craniotomy is not a bad word and should be part of the armamentarium, as all the other speakers have mentioned. Here's a large petroclival meningioma that we managed endonasally. A relatively young man with progressive gait difficulty and some cognitive dysfunction from early hydrocephalus. Very large tumor blocking his third ventricle outflow and significant brainstem compression. I think I will skip this in the interest of time, but here you can see our goal here is not a radical resection, but rather perhaps a two-stage management where we initially decompress. This was done, decompress the endonasal portion and then do an open approach for a more radical removal. Here we can see a wide clivectomy. An inferior rhinopharyngeal or RP flap for the clival access. And here we see the wide clival resection. We can do an initial debulking of the tumor, identify the sixth nerve, and then debulk the tumor. Now to continue with the debulking of this, we have to do the pituitary transposition that Dr. Fernandez-Morena has so elegantly described. I would encourage everyone to look up this technique as well as his work on cavernous sinus, put a tremendous amount of effort into this, but it's a beautiful example how we learned from the lab and are able to transition this into patients. So performing clinoidectomies gives us access to the superior pole of this tumor as well as the perimesencephalic cisterns. We can then access now along the sixth nerve, we can access into this medial Petrous triangle, but also transcavernous above the sixth nerve between the third and sixth nerve. You can see that looking up with an angled endoscope between the third and sixth nerve to get a relatively complete resection, at least up to the posterior clinoid and the Petrous bone. Here's the final view. And I'll skip ahead to the imaging. Here we see obviously the portion left on the Petrous bone, and this could be managed from an extended middle fossa approach to get a near complete resection of this tumor.
That's an awesome resection, I must say.
Is mesial to all of these the neurovascular structures. It's a relatively simple concept, but important.
Did we lose you, Paul?
Extended middle fossa approach, ideal for that. We were able to accomplish this endonasally. Here you can see the post-operative view of exactly that. The infratemporal fossa extension can be done also through an anterior trans-basal sphenoid approach like you see done here, where we're extending through an anterior transmaxillary approach to decompress this V3 schwannoma. Again, I think I'll skip this in the interest of time with only the point that this is really only good for Meckel's cave and V3 schwannomas. If you extend back towards V1 or V2 or pure Meckel's cave, an open transcranial approach or an extended middle fossa approach really is a much better option for those particular tumors. Middle fossa can rarely be accessed also. Here's a patient with a multiply recurrent meningioma extending in the middle fossa. We did a Danker's extended maxillary antrostomy. Here you see sacrificing the vidian, drilling out the pterygoid, all the way out to foramen ovale. We can open lateral to foramen ovale, decompress the tumor in the posterior fossa as well as in Meckel's cave. Here's the, middle fossa as well as in Meckel's cave. And we're working on both sides of V3. Here's foramen ovale. And there's tumor all the way out to the temporal lobe and all the way into Meckel's cave. Reconstruction is important when we're looking at transpterygoid approach. You have to have the flap on the opposite side or you really can't do the transpterygoid because the flap mobilization can kill the flap. Leak rates, of course, are critically important. And the nasal septal flap has been a key part of that. Anytime we extend laterally, you have to be aware of a carotid injury. Here's a case of here's the paraclival carotid artery working on a chordoma. And trying to extend, this is very early work where we didn't understand this Petrous anatomy well. I was also, I wasn't oriented in the field and ended up cutting right into the carotid artery here. You can see a paraclival carotid. I had to sacrifice this. We did have proximal control in the neck and good back bleeding, so I was able to safely sacrifice this, but I had no other good option other than packing it off and hoping for an endovascular salvage. Fortunately, this child did very well because of her persistent trigeminal as well as ACOM collaterals. Again, can't emphasize enough as we extend out into the Petrous bone, an understanding of the carotid anatomy and the key landmarks for accessing and safely dissecting out this anatomy. We can also try to avoid carotid injury by avoiding manipulation of the carotid. This is a recent development. Dr. Snyderman came up with a contralateral transmaxillary approach, where rather than just a transnasal corridor, if you look at the CTM axis behind the horizontal Petrous carotid, we have beautiful parallel access to the Petrous carotid, and this allows us dramatically to increase our corridor for tumors like a chondrosarcoma. And this gets us much more lateral into the Petrous apex. So here, where we would normally go through a transclival approach, we would completely unroof the carotid artery and work through that triangle I mentioned earlier. Here's opening that triangle, mobilizing foramen lacerum. We have a certain amount of access from an endonasal approach. So here I'm working with a suction, but without dramatic carotid lateralization, I really can't access it. But as soon as I start working through the CTM approach, through the anterior maxillary antrostomy, now my suction can work all the way out. Here we see the horizontal Petrous carotid. Our 45-degree scope is turned laterally and working all the way from Meckel's cave in the middle fossa, all the way down to the jugular tubercle, clearing out the entire Petrous body, even all the way out to the IAC. So beautiful example of how this, how these corridors and multi-corridor surgery can really allow us better access. Here you can see all the way out to the IAC and all the way down to the jugular tubercle and jugular fossa. I won't belabor this, but looking at using the CTM, we were actually able to get GTR in 75% of cases where the Petrous portion for chordomas and chondrosarcomas. Again, endonasal and transcranial really are very complementary. This is a study done by Vanessa Hernandez at when she was with us. A beautiful study comparing the access to the middle fossa and the Petrous apex by these various approaches: endoscopic endonasal, CTM, and an extended middle fossa, or Hakuba Dolenk Kawase approach. We did 3D reconstructions using CT scan. And looking at the amount of Petrous apex evaluated, you can see the Petrous apex from a Hakuba Dolenk, we have beautiful access to the Petrous apex. But if we do use CTM, we have almost the same access to the Petrous apex as we would from a Hakuba Dolenk. So if you look at the percentage accessed, it really is the same between a Hakuba Dolenk and a CTM, especially with carotid mobilization. If we look at the Petrous body, the main bottom part of the Petrous bone, though we really have superior access through the CTM, the Hakuba Dolenk can only reach so far inferiorly and lacks access to the clival portion. So when we look at the Petrous body, really the CTM, especially with carotid mobilization, provided superior access. So when we look at this, if you're looking at the Petrous apex, you really should consider an extended middle fossa approach, whereas if you're looking at lower down in the Petrous body, a CTM plus ICA seems superior. But this really shows the complementarity of the two approaches and understanding, just like Danny showed beautifully with endonasal versus anterior cranial approaches for the anterior cranial fossa, the same thing is true for the middle fossa. These two approaches really are complementary. It depends on their location relative to the neurovascular structures, but very importantly, depends on the surgeon experience. If I'm more comfortable with a certain approach, farther along in my learning curve, I'm more likely and should be more likely to choose that approach. Again, different pathologies also have different goals, and that should help determine our approach as well. Here's the neurovascular limitation for endonasal approach, and here's the learning curve. This is our own institution very early on. You can see these level 5 approaches at the bottom were never even attempted very early on, and that's a very important lesson. You can destroy your practice by trying to jump too far ahead in your own learning curve. In the end, if we look at this purely anatomically, an endonasal approach has advantages where we can come in medial to cranial nerves. We have access to the entire clivus, the medial cavernous sinus, and the Petrous body, but it's limited. You can't access the CP angle. You have trouble getting up to the Petrous apex, and the 6th nerve is inevitably between you and the Petrous bone, and you have to work around that limitation. Conversely, an extended middle fossa or anterior trans-Petrous approach has a clear advantage that we're lateral to cranial nerves. So meningiomas would be better accessed this way with the entire temporal fossa, Meckel's cave, and IAC, but we're limited below the IAC. We don't have great access to the Petrous base, and the fourth nerve is inevitably in our way. I do have some examples of cases, Juan, if you want to have a little bit of discussion, but I know we're running a little late on time and I don't want to run into the other sessions.
Thank you, Paul. That was great. Great cases, and I like your Petrous apex research in the lab. Nice paper. So in the CTM advantage, that's excellent. So thanks. Dan, Dan Kelly, are you with us? Would you like to go ahead and jump and show us a couple cases? We need to move quicker, guys, all of us. Not to rush it, but just because I'm gonna be running out of time. I think we can extend, this session for all attendees is supposed to finish by 12 p.m. But the next one starts at 1 p.m. So we had a 1 hour lunch break, but I think we can eat into our lunch break, speaking of lunch. So we can extend it beyond 12 p.m. if we have to. That being said, let's keep it simple. Dan,
okay,
thank you.
Can you hear me okay? Can you see my screen?
Yeah, Dan is my neighbor down south. And someone I, really like, admire, and enjoy. So please, Dan.
Thanks, Juan. This is a great program, and the talks preceding have been amazing. So much talent and innovation here. So Juan asked me to talk a little bit about tuberculum cell meningiomas, and I will try to be brief and just show two cases. So I'm just going to start with this case. This is and we've seen a number of tuberculum meningiomas, and we're going to talk about, basically going from above or below. And I think that's the big question, and that's our option now. So this is a 39-year-old man with progressive left eye vision loss, about 20/200 in the left eye. And as you can see here, the challenge in this guy is that he's got a fairly shallow sella. It extends pretty far forward. But over here, you can see he's got bilateral optic canal invasion medially, and his vision is the main issue. Obviously, the other challenging thing is the calcification. This is not going to be a soft tumor. So, but given the issue of vision and given our ability to decompress the optic canals medially more effectively from below, as you've heard, this was the approach that we chose. So I'm going to just go through the video here and let it play. We obviously raised a nasal septal flap. This is the initial exposure, and doing the cellular exposure here, lots of irrigation as we start to decompress the optic canals. And you can see here that the meningioma has actually eroded through the tuberculum here to some degree, and we're starting to get to this calcified portion of the tumor using the Doppler here and completing our bilateral optic canal exposure. And here you can see this calcified component of the tumor just rock hard coming through the dura here. And so peeling this away. And then here's the full exposure of the posterior planum, the tuberculum. And then we start here with a blade here and just cutting right into this calcified portion. And what I like to do for these is detach the tumor from the diaphragm and from the top of the pituitary gland to get a clear view. And you can see here how this whole mass moves as one. We also like to make a little relaxing incision in the top of the gland, which the gland tolerates very well. You can see here we're starting to see a little bit of CSF come through, and this whole thing moves as one piece. It's really rock solid. And this, you have to be really careful manipulating this. And ultimately, you'll see we go to the ultrasonic aspirator. You can start to see the top of the gland and the infundibulum here, and cutting these attachments, and then being very mindful, as you heard from the other speakers, about the superior hypophyseal vessels. We like to put gel foam in the subarachnoid space to prevent a lot of blood going into that. And here you can see this tumor was really a bear. This internal core was just so hard. But as you get more to the lateral edge, it became softer. So the key is really to internally debulk it, and we could only do it with the ultrasonic aspirator. Here, a really nice view of the infundibulum, very carefully trying trying to expose that. And here we're getting more lateral. You can see the posterior communicating and the superior apophyseals right here. And we're just gently exposing those on both sides bilaterally, essential for gland function and for vision. And so the goal here initially was to take this bottom part out to really find the inferior aspect of the chiasm and separate this away. And so you can see we've almost done that. And this piece comes out nicely. And then we have this big rind above, again, very calcified. And so this also took a little bit of time to decompress. And again, just piecemeal fashion, working it down, thinning it out with the ultrasonic aspirator and going very anterior. I didn't show some of that, but there's a component that the most anterior extension, obviously. And then finally is to try and take the tumor out of both optic canals medially here. And I'll show part of that dissection on the left. And you can see here, this is taking some of that anterolateral component on the right that goes up to the right optic canal. And ultimately, this came out quite cleanly. And the optic canal decompression, as you've seen from some of the other speakers, you really need to open the dura here. Here we're using a 45-degree scope and a ring curette. Unfortunately, this tumor was relatively soft, and we were able to get all of that out, it looked like, in a gross total fashion. And here's the final look. You can see the chiasm well decompressed. You can see both optic nerves well decompressed, and the infundibulum. You can see the supraapophyseals and all those structures intact. Reconstruction with fat, a septal bone graft. We like to use that, harvested. This is with Dr. Griffiths, Chester Griffiths, my partner here, and then the nasal septal flap. And we place these Maricel tampons under direct visualization. 2 of them, leave them in for 5 days. No lumbar drain. We don't use lumbar drains for these cases anymore. We leave them on Diamox for 48 hours. And this is his post-op scan. This is a relatively recent case, but you can see here the bone flap and the fat graft in his CT scan. You can see the pituitary gland here, a gross total resection from what we can tell. And you can see the optic canals here. We're not seeing that enhancement anymore. So we'll see how he does. But I think this just goes to show you how far we've come collectively, I think, in doing these cases. I'm going to show you this next case. This is a
great case, Dan. That was a very nice case. Difficult to do, no question. That was a difficult case. So calcified.
Yeah, I wasn't sure if it was a good maneuver at first. We thought long and hard about it, and then ultimately, it's really because of his vision we decided to go from below. So here's another one. This is a bigger case that I did with Garney. And you can see here that this tumor is a larger tumor. It's over 4 centimeters. It's a little bit wider, but again, bilateral optic canal invasion. And we just thought this was really large. I don't know what you guys would have done, or Danny, if you would have done this from below or above, but we just thought this was a little too wide. And so we decided to do this from an eyebrow. And I'll let this play here. So you've heard a little bit about this is, you can consider this a frontolateral approach here. Let me just move this along. This is the approach.
It's funny. I don't know if Paul or Danny or Jim would agree with me, but I think this is more an endonasal case for me than the other one.
Really?
But that's the beauty of this, that the disagreement, the
yeah,
differences.
I think you could, and as I'll show in a moment, this is coming again from the left. This is coming from the left eyebrow here. That was the supraorbital nerve that we're preserving here. This is the pericranial cut. Very important to try to save the nerve. This nerve was a little bit more lateral. As you can see, we struggled to save it, but we did save it. I'm going to just move this along though. So we start all these cases with the microscope, and we're coming again. Did I say this is coming from the right side? I'm sorry.
Mm-hmm.
Yeah, this is the right, not the left. Sorry to confuse you all. And you can see we're starting to devascularize the tumor. We obviously open the cisterns, devascularizing the base of the tumor. And this is a very lateral approach. And I think that's the challenge. And from the traditional approaches, I think it is difficult to get a look at the medial optic canals. And that's, I think, the potential danger. In this case, we actually got lucky because of the tumor texture. And I'll show you what we were able to do with the endoscope in a second. But you know, now we're working medial to the right optic nerve and just cutting the arachnoid, debulking the tumor, and then pulling the tumor down, as you've seen in a number of the other videos. That's actually the infundibulum there, pulling the most posterior part of the tumor out. That's the contralateral optic nerve. And you'll see here in a moment when we bring in the endoscope that this the tumor, this is just looking lateral to the right optic nerve. And there you can see both optic nerves there. So now we come in with the endoscope and you can see the chiasm here very nicely. And this is using this chameleon endoscope. And fortunately, the tumor going into the medial optic canals was very soft, and we're able to take, even without opening the falciform ligament, able to take that meningioma out of both optic canals and with a really pretty good view. And I think this is part just being more lucky than good. The tumor was soft and was easily accessible bilaterally. And I think, but to do this without the endoscope, at least at that part of the procedure, is very tough to do. So I think that's
Dan, would you agree though that your Simpson grade resection for that is lower than perhaps you could achieve endonasally with the ability to resect mesial dura, which you know, does have tumor contact and therefore ideally would be resected?
Yeah. I would agree. You know, I'm not sure that, you know, in terms of long term, I guess we'll see. I think that's a good point. There's her post-op there. I mean, you know, it's a gross total removal, but I think your point is well taken. How would you have done this, Paul? What would you?
That particular one, I agree with Juan. I've done it endonasally largely because of that extension into the canals. That to me is a real fighting point that, because that to me is one of the main goals of this, is deepening the canals. But obviously it's a beautiful approach, and I think it demonstrates how wide access you get through an eyebrow. And I think until you start doing it, you can't appreciate that. You can, you know, do everything from clinoidectomy to, you know, even drilling the plenum if you had to through that approach.
Yeah, well, we've certainly, so I guess the point of my talk is that over time, we've been doing more and more of these through the nose. And this is some unpublished data, but we went and looked back at over about 12 years, 33 patients, and we did about 60% through the nose and 40% through the eyebrow. But the rate of going through the nose has gone up significantly. And when we look at the differences in the volumetrics and the location of the tumors, you can see that with the endonasal cases, the amount of optic canal invasion was higher. It was about the same, but more recently, again, we've transitioned more to the endonasal approach. But the tumor volume, the maximal diameter was smaller. The extension laterally was less with the endonasal. The percent above the plenum was less going through the nose. So these deeper tumors are more easily accessed, obviously. The depth of the sella is deeper in the ones we went from below. And this, what we call the mean tuberculum angle, which is something which is really this angle of the tuberculum. So the more acute the angle, generally the deeper the tumor is. And again, those are more favorable for the endonasal approach.
Dan, this is great work. I have a question for you. When would you do not an eyebrow, but a, you know, incision behind the hairline and a frontal orbital approach with the orbital rim or without the rim? What makes you decide one versus the other?
Well, I think, you know, James showed some really large tuberculum and, posterior planum meningiomas. I think for some of those, and then as you go more forward toward the olfactory groove, those are cases where we would do a more traditional approach. But we have found that even with some of these large tumors with the eyebrow, you can do well. Now, maybe, we're not getting a Simpson grade 1 resection, and you could be criticized for that, but we can get, quote, a gross total removal for many of these tumors. And I think that's the debate here of how aggressive do you need to be. But we've gotten more and more comfortable doing these large tumors through the eyebrow. And, I guess time will tell whether that's a bad decision. I mean, how many of these people are going to have recurrences down the road? How many are going to need radiation? I think I'm not sure. So, but I can tell you that in the short term, I think the patients do very well, with this minimalistic approach. They recover well. Most of the patients are in the hospital for 2 days. I think there's something to be said for less brain exposure, less bone removal. All that stuff, I think, is an additive benefit in the short term. The long term, we may be criticized a decade from now. I don't know.
Well, we'll see. But sometimes it seems that to me that maybe a bigger approach allows you to manipulate the brain less. But maybe you don't agree because you think you can relax it really well when you open the systems and the brain there is less manipulation. Sometimes it seems to me that taking the orbital bar really helps decreasing the amount of manipulation on the frontal lobe.
Yeah, I mean, we don't use retractors for any of the eyebrow cases. I think it's really critical to have good anesthesia. The positioning is important, and you've got to open the cisterns right away. You definitely need to do all that. I don't think that's been a big issue, but these are great points. I don't know what the right answer is.
Can I add a point? I just have a dissenting opinion on that particular case. I would have done it open through an orbitoterional, or what Juan calls it, a frontal orbital.
This one.
Yeah, because I think what I'm looking at is not so much the inferomedial extension, but the supralateral extension over the optic roof and towards the little dural tail going over the clinoid. I think from an open approach, you can resect that part of the dura more effectively. But through an open approach, you can still access both optic canals with a bigger opening. Of course, looking cross court, you have good access to the contralateral optic canal quite nicely. And from the ipsilateral, it's more difficult with a smaller eyebrow, but with a bigger opening, you have more angles of attack and viewing angles to look from medial to lateral on that ipsilateral optic canal.
Yeah, well, in looking at the literature, I think that with the approach that you use, this trans-basal approach, I think is an excellent approach. But if you look at the literature, the big series of tuberculum cell meningiomas through conventional craniotomies, the rate of visual decline is definitely higher than the endonasal approach. And I think it's because they don't get low enough, and there's this need to manipulate the nerves more that winds up just costing people vision. And the literature also suggests that there's more harm to the brain. There's more retraction injuries. I mean, that data is out there, and I think what you all have been showing predominantly, this is a somewhat different approach. Is this sort of the new age of skull-based surgery? And I think getting low is key, as you showed. So as long as you do that, that really helps. I think, the beauty of the eyebrow approach is you start on the floor of the frontal fossa. And by positioning the patient correctly and opening the cisterns, the brain falls away, and you don't need a retraction. But you still have limits with visualizing both optic canals, I think.
Dan, can I make a comment?
I also think Dan actually forces you to not use retractor. You can't get one in there if you wanted to, and so where you might be tempted to, normally the eyebrow forces you to work within the sweet spot of that opening, and I don't think it's that much different than a terional at all.
Yeah, I agree with that.
I would encourage people to try it.
Say that again, Paul.
I was saying, I think the fact that you cannot put a retractor in, it doesn't add anything to it, because the limitation is the opening and the brain relaxation access to that opening. And so there's no addition of a retractor. So you can't have that temptation to even put one in there. So it really forces you to work in a retractorless fascia is a sweet spot for an arterional to this area.
Right.
Dan, if you allow me to make a comment about the, there's one thing that we never talk much, but that case, the large one that you showed, I would probably have done endonasal as well. And one of the reasons that what I look is the shape of the tumor. That tumor has a round shape, is a smaller base actually, versus one that I showed that I also did an eyebrow that had more like a volcano, Fuji, with a lateral implantation. I think those that have a lateral implantation in the imaging, those are the ones that end up leaving disease, like Jim Lu was mentioning. But if I see a more round base, I actually take that in consideration as well, because I think it's just touching those areas. You can actually go endonasal, and I agree with Paul on this one, that for me is easier and more direct to open bilateral optic canals, even with a large tumor, and it's not encasing any vessel, so I would probably have done this endonasal.
Yeah. Well, on that one, that's this case here. The concern to us was this lateral extension here, but as you showed, and we've seen as well, that I think if they're a true tuberculum or diaphragmocele meningioma, they tend to, their attachments are really along the tuberculum, and they're just pushing things laterally. So those lateral extents, I mean, aside from the dural tail here, they do pull in away nicely from the brain and the vessels, and I think that's a good.
Yeah, which is not the case if you see the lateral implantation that goes triangular all the way lateral. Those go all the way and you leave disease.
Well done. Those were great cases. I think there is no wrong answer. You know, both are great approaches as long as you do it well and you do it carefully as you did. It is a beautiful outcome. So Pablo, please, you are next.
I'll just make one last point here. Our resection rates were similar on these two approaches, but just and we just showed essentially no flare changes going through either approach except in one patient. So I think, again, these indicate sort of the minimally invasive nature. But this is over time, and we added in some of our old tuberculum patients from an older paper showing the progression going. The dark green is endonasal endoscopic. And you can see, and this is optic canal decompression. So you can see over these 5-year epochs, this is really the way we're doing them now. Majority through the nose with bilateral or unilateral optic canal decompression as needed. And we're using the supraorbital less and less. So I'll stop sharing my screen.
That's very interesting.
Thanks, guys.
Thank you. So we have with us Pablo Recinos from Cleveland Clinic. Please, Pablo, go ahead. Share with us the case you wanna present.
Thanks so much. Thank you so much for the kind invitation, Juan, and that's the Rhoton Society. I'm gonna start out here. All right, this is my disclosures, which is not relevant for this presentation. So this is going to be a case of a 68-year-old male presented with headaches and some subjective double vision. He actually had normal, grossly normal extraocular movements on our exam. The neuro-ophthalmologist thought maybe a little bit of fourth nerve dysfunction, but was not sure. So this is the imaging. This is T1 with contrast axial. And we can start seeing the tumor involving what appears to be posterior aspect of cavernous sinus on the left side, extending and putting pressure on the midbrain, as you can see here. This is the same axial views, KISS sequences, showing a slightly different perspective here of the tumor. And so Paul brought up something very important in his, the differential diagnosis, because this actually may be an important part of how we're going to treat this. So the radiologist thought meningioma, in which case I would say, did this arise from the cavernous sinus or from the tentorium? Schwannoma was also something that we are considering, and in that neighborhood, trigeminal, oculomotor, or even trochlear origin. With this in mind, I just want to ask briefly, Paul, you had talked about diagnoses. Would this affect at all how you view this case? You had talked about approaches to the cavernous sinus, Petrous apex region.
Yeah, I mean, for me, it definitely would, because I think the different relationship to the nerves and a different, whether or not it's a bony tumor or a meningioma or a schwannoma, all have different relationships to the nerves and also different goals for resection. So I would say it would dramatically affect it. A schwannoma, I'd be much more likely posterior location to do it through an open approach, even a lateral orbitotomy, but something like chondrosarcoma would push me towards perhaps endonasal because of its origin in the bone.
Okay, and so this is that KISS sequence, just showing the location of what we thought was the third nerve right here being pushed medial. Now, interesting, just from a strict trajectory standpoint, we thought that a third nerve schwannoma was possible, although his clinical exam didn't really reflect that, but it seemed to be distinct here. Is this, would there be any role for an endonasal approach here? Danny, Paul mentioned, some of these anatomic considerations, perhaps for...
Yeah, I agree 100% with Paul. If looking at the images, if it's more like a schwannoma, I would do a peeling of the middle fossa and follow this tumor from Eccles cave posteriorly with an open approach. But if it is, I would look at better like a CT scan, for instance, and see if there's bone erosion and the source being the petroclivus enchondrosis, then I would definitely go endonasal and follow this tumor up. I think that was exactly what Paul's idea as well. So I agree. Okay,
thank you. So we, there was no apparent bony involvement, and one of the other things besides the bones that I think that is important to note is if where are the carotid arteries in the in relation to the angle that you might get. But I think clearly this is one which even though we talk about endonasal approaches, directness, the location of where the third nerve is going here, the location here in the posterior cavernous sinus area, and the contents being displaced forward, superior to Meckel's cave, we chose an open approach as well.
Pablo, can you show did you show a coronal view?
I did not, no.
Okay.
Sorry, that may have been helpful.
We'll try to imagine one.
So we kind of talked about some different surgical options, which I had surveyed some of our panelists. Of course, the endonasal approach is one of the ways to get there, in particular for bony tumors, or for example for this retroinfundibular craniopharyngioma that was shown. But we ended up, and here are some of the transcranial approaches. So we actually did a Arterional and just took off the orbital rim, for this. One of the things that we felt was pretty important, and that we sometimes do, it's a small detail, but was just cranial nerve monitoring. Apologize, as I'm on call today, so I'll answer.
Pablo, a quick question. How do you do monitoring in the situation where you do an OZ? Do you place the lead sterilely after you do the orbitotomy, or that's always a practical issue with that?
Great question, Paul. That precise issue came up for us. So as I mentioned, we just removed the orbital rim here, and Paul is exactly right. We cannot put these superior leads. So in this case, we just used the lateral rectus for 6 and inferior oblique for 3. So that's what we did. We did not monitor 4 in this case.
That's smart.
So here are some of the details of that case. We actually did an extradural anterior clinoidectomy to gain us a little bit more space. This is a video that our fellow Prane Sony put together, who did the case with me. We subsequently opened the dura and split the sylvian fissure. And I'm curious to know, you know, one of the things that we ended up doing here, we visualized, you know, the bulge of where the tumor was going to be. You know, we found, we did stimulation for cranial nerve 3, but here you can see the bulge in the dura, and we actually just went transdural to get where the tumor was. This tumor ended up being a reasonably soft schwannoma of the 4th nerve. But I'm curious, would any of in the group would have gone purely extradural here? You know, we did extradural clinoidectomy, but anybody would have gone back or just
Pablo.
I think I
would have done extradural.
Yeah, and then open the dura just above the tentorium, about the petroclinoidal ligament.
Yeah, Pablo, I would have done more of an extended middle fossa Kawasi's approach, more of a posterior backdoor to the Meckel's cave trajectory.
Yeah, me too. I would do a peeling of the middle fossa, elevating the lateral, keeping the dura on the temporal lobe, and exposing the lateral aspect of Meckel's, the trigeminal, all the way to the tentorium, like dissecting all the way there. Mm-hmm. And then would attack the tumor from that extradural perspective.
I would have done it through an eyebrow, transsylvian. Well, we actually just did a tentorial meningioma this week, and we had a beautiful
But Dan, isn't the middle fossa really very limited through an eyebrow? I mean, that's the area I always struggle, is coming lateral to the
right, but there's very little of this in the middle fossa. This is popping up. That's why I wanted to see the coronal, because it's really popping up from the cavernous sinus. And you can go down into the middle fossa a little bit. Nice resection. But I think what you could do through this frontolateral approach that you did, Pablo, you could probably do it through an eyebrow. Sweet spot.
Beautiful results, Pablo.
Really nice.
Wonderful.
Good result and very interesting case, actually.
We felt a bit uncomfortable. I just felt like more comfortable maybe doing having a wider view to split the sylvian fissure, Dan. I just haven't done personally enough eyebrows where one would get that approach. But I do think that I knew I was going to get some alternative approaches here. But one of the things that was brought up by our panelists here is when you do the peeling of the middle fossa, you have a straight view, or a pretemporal peeling, I should say. You have a other view straight back to where it was compressing on the midbrain. Sorry, go ahead.
No, I was going to say the other advantage of coming subtemporal combined is that you have the ability to open across the tent, and you can see the 3rd and 4th nerve as they enter the cavernous sinus posteriorly, and then you also see the whole lateral wall of the cavernous sinus as you showed. And it's hard enough to tell where they are. I always struggle with that relationship, and maybe that's my own lack of experience there, but I find it useful to see them in the cistern as well as a cerebral fissure and try to trace them in that fashion. But I don't think it would have changed the outcome in this case.
I think one of the things that for at least in orienting ourselves to the cavernous sinus in this case was identifying the 3rd nerve early, having seen it being displaced superior and medially, and stimulating it and then following it in, Paul. But you're right, if you come subtemporal, that certainly is another familiar view to that.
Wonderful. So yeah, sorry.
No, go ahead.
No, please.
That's really all I had to show for that case. I had this one, but Juan, I know we're running short on time. I'm happy to show it briefly and just show a couple points.
Let's stop it there, just because
sure.
If you had changed the order, I wouldn't mind. But you finishing with that case is perfect to transition to the next block of our
sure.
session, which is about more posterior skull base. Beautiful background. Is that real?
That's my backyard. Yeah. This is Cleveland. For all you people who think that the sun only shines in the West Coast. I know Paul, Danny, and I know that the sun shines very brightly in the Midwest here.
All right, that's great. So thanks, Pablo. That was very nice. And I'm gonna start introducing this next panel on posterior skull-based tumors. We have the lower panelists with us together today, and we are honored to have you all with us. I'm gonna start showing a few cases to introduce this session. You see 3 tumors right here. And I'm gonna show you how for these 3 tumors, we do different approaches. This first one was sent to me as a petroclaudal meningioma after progression with radiosurgery ×2. But it really didn't look at petroclaudal meningioma. If you look back at it, let me just, so this actually looks like a schwannoma. And how many trochlear schwannomas can you see in a presentation, right? So this happened to actually be a trochlear schwannoma. And if you look at the axis of the tumor, I decided to do this from posterior, different than your case, Pablo, that was actually compressing the peduncle from anterior. So it was great to go from anterior. This was going along the incisura, so I decided to go from the back, suprasellar transtentorial, and actually worked beautifully. You can see the 4th nerve right there. You can see the area of the tumor, which I'm cutting right now, the 4th nerve. And now I'm trying to separate this from the brainstem, and the plane is really bad. You just saw a vein there, and that vein is a very important landmark. It's the lateral mesencephalic vein. And what you see there is the 3rd nerve and the PCA as they go towards, the 3rd nerve goes on top of the, towards the cavernous sinus. And that's at the end of the resection. So you want to work along the long axis of the tumor anytime it's possible. And this case was actually ideal for this supracerebellar route as opposed to, let's say, an endonasal route or a middle fossa. This other case had a retrosigmoid approach somewhere else. And they did that, relatively, resection, the left-hand tumor. Patient had severe trigeminal neuropathy. I followed the patient for some time, and in 6 months, the tumor was already growing and showing increasing edema in the brainstem and ataxia. So then here I thought, how should we approach this tumor? Should we do retrosigmoid again, or should we try something different? So we do endonasal, so we do, what do we do? So for this one, I decided to do a combined transpetrosal, which I don't do very often, but this is a middle fossa approach. You can see the GSPN is being dissected all the way to V3. You see V3 being skeletonized. And now we're drilling the mastoid and the semicircular canals all the way to the internal acoustic canal, then going on top of the canal to drill. And this is the key drilling right here on top of between the canal towards the V3. I love using that ultrasonic aspirator for that drilling. I believe is so much safer. And then the beautiful thing of this approach is put you right on the spot, right on the attachment of the tumor. We're cutting the tent and dissecting that vein attached to the tentorium, and then we're cutting the tentorium towards the incisura. We find the 4th nerve, as you see right there, and then we finishing cutting the tent, and we see 5, and the tumor just underneath. I can see actually Meckel's cave, and open Meckel's cave with this knife, and take the tumor from within Meckel's cave and the dura around it. And then I can work medial to the 5th nerve, lateral to the 5th nerve, and right on the tumor, and it's impressive how with this approach, you can get right to the attachment. So I can detach the tumor from the Petrous apex and petroclival junction, and then I start rolling it, dissecting it from 5. I found 6 anteriorly, and I protected it. And then, getting a very nice resection of this tumor. And just the last attachments here in the petroclival region. And then just closure of the dura, and then we bring this pericranial flap that is pedicle posteriorly to the occipital artery to prevent the CSF leak. And a nice complete resection and very good outcome. And I'm just gonna show you, just to introduce, we also have the option of doing endonasal cases. This had a combined transpetrosal years before, beautiful case in the past, but this tumor had, very, it's coming from anteriorly compressing the peduncle or the brainstem, better say, the pons actually. And there is edema, seems to be calcification, really difficult case. So I decided to go from anterior Of course, it's been radiated, it's been on Avastin, you know, it really is a bad case. So I go trans-cavernous and take the posterior clinoid, and you saw that we did a contralateral transmaxillary approach also to get a more lateral reach. And actually worked really well. It gives me access right into the tumor, right at the attachment source of the tumor. And I was worried about the interface with the brainstem. And this gave me the best, in my opinion, access to that interface to identify that plane and the perforating vessels. It was impossible to detach the tumor from the brainstem without injuring those vessels. So I had to leave a thin rim of tumor. But I think this worked really, really well for this case. So those are the few cases I want to show to introduce this next part of the session. We have with us first, we have time, we can show this later, but we have with us San Raza from MD Anderson. San, it's great to have you with us.
Thank you.
If you guys have any comments about any of the cases, please feel free, but Sam, please come up with your slides.
I think my screen sharing is disabled right now.
One second, let me check that.
Okay.
I think you should be good now.
There we go.
Pablo, what do you think about that trochlear schwannoma?
All right.
Pablo's gone. Anyway, that was my only trochlear schwannoma ever, and I'm supposed the only schwannoma that Pablo has done, also because those are so rare. But anyway, so I asked Dr. Raza to talk about, you know, trans-petrosal versus endonasal approaches, and I think this is a very interesting topic. So please, Sam, go ahead.
Well, Juan, thank you very much for including me in this session. It truly is an honor. It's also an honor to be included with all the other speakers from, you know, I've learned so much from you guys over the years with regards to surgical decision making. So, you know, I was asked to sort of tackle the discussion of endoscopic versus trans-petrosal approaches. And there's going to be some overlap with Paul's talk earlier, but I'm mainly going to focus on posterior petrosal and combined petrosal approaches. And I think this discussion is really relevant to the management of petroclival pathology. And, you know, this is certainly an interesting area, not only with regards to surgical technique and anatomy, but also the wide variety of pathology that you see in this area. You know, on one hand, you can see extradural benign pathologies such as cholesterol granulomas and cholesteatomas, but also malignancies such as chordomas and chondrosarcomas. And to the point that was made earlier is that understanding the diagnosis is really a key factor in terms of designing a surgical strategy. For example, for a cholesterol granuloma, where the goal is really to marsupialize the cyst, you really don't need an extensive and wide skull-based approach, really something that's tailored. On the other hand, for a chordoma and chondrosarcoma, the goals are very different. And just given the nature and focus of my practice, I was mainly going to use these bony sarcomas as an example in terms of selecting a surgical strategy. Really, the goals of surgery here are very clear, is to perform a wide and anatomic resection of the primary bony compartment of the tumor, and then secondarily resect any additional extensions of the tumor into adjacent bony and soft tissue compartments in an anatomic fashion. So for example, for a petroclival chondrosarcoma like this, really what should be resected is the mid and low clivus, in addition to the Petrous portion of the temporal bone, all up to anatomic landmarks, skeletonizing the carotid artery, exposing the posterior fossa dura, and then resecting the dura widely, any subdural disease extension. So surgery consists of much more than an intralesional curettage, but really a wide resection of all the bone. And certainly we know that this has a significant impact on progression-free survival and overall survival when we look at chondrosarcs, chordomas, and high-grade osteosarcomas in our practice. And certainly the higher grade malignancy, the stakes are much higher. And so that really sets the stage in terms of what is the goal of surgery. Now, from the anatomic perspective in this area, you know, the petroclival synchondrosis, of course, represents that anatomic boundary between the mid-clivus and the Petrous portion of the temporal bone, which has, of course, an apex and a base. And the synchondrosis extends from the inferior aspect of foramen lacerum down to the medial aspect of the jugular foramen. And I think this cadaver illustration on the right side here really highlights some of the surgical challenges of accessing this region with the spectrum of open and endoscopic approaches. With a posterior trans-petrosal approach, you have to deal with the facial nerve. And despite transposing that, you still have the jugular foramen and the lower cranial nerves that limit your access to the inferior aspect of the synchondrosis and the low clivus. With an anterior petrosal approach, you have great access to the Petrous apex and the upper 2/3 of the synchondrosis, but again, limited access to disease medial to the jugular foramen and the low clivus. With a midline endoscopic transclival approach, you can certainly access this area with angled instruments and angled endoscopes to do an intralesional curettage, but the ability to drill out all this bone is rather limited, and also to safely dissect these lower cranial nerves out. And I think, you know, in addition to the deep center location, the synchondrosis within the skull base, there are also some other anatomic factors to consider. As I mentioned, a lot of these tumors can spread into adjacent compartments. So when we looked at, for example, our petroclival chondrosarcomas, you know, 1/3 of these patients have disease extension into the infratemporal fossa. Despite their extradural origin, half of these patients have disease extension into the subdural space, and half of these patients have disease extension into the cavernous sinus. And it's important to understand this because with whatever surgical strategy you pick, each one of these compartments has to be accessed ideally with that surgical strategy to perform a meaningful resection. And, you know, the highlight, again, the challenges of managing pathology in this area, when we looked at our experience with chondrosarcomas at all skull-based sites, and you look at outcomes by site of origin, primarily with the use of open approaches, those chondrosarcomas arising at the petroclival synchondrosis have traditionally had the poorest outcomes with regards to extent of resection, neurologic function, and surgical complications. And this is with the use of either anterior petrosal, posterior transpetrosal, or combined petrosal approaches. And I think this is consistent with what has been reported in the literature with the use of open approaches. And so clearly this is an area where there's been need for improvement. And I think this is where adding the endoscopic transpterygoid approach, as was described by Paul earlier, has really helped improve outcomes when you include this as part of your toolbox. And the philosophy here is really by resecting the medial and lateral pterygoid plates, performing a medial infratemporal fossa dissection, skeletonizing the carotid, and dissecting the eustachian tube, you really have direct access to this area to really drill out this bone, drill out and resect any tissue, tumor extending ventrally, superiorly, and laterally. And so this is an example of a 36-year-old male with a conventional grade 3 chondrosarcoma I treated several years ago. And you can see in the imaging here, you know, certainly involvement of the petrous portion of the temporal bone, involvement of the mid and low clivus, and also disease extension to the hypoglossal canal, into the longus capitis muscle and the rectus anterior muscle, capitis anterior muscle. And so in this case, I elected to do an endoscopic approach. And what that looks like, you know, there's several sort of key steps to really maximizing exposure, especially when you get out to the jugular foramen and the vertical Petrous segment of the carotid artery. And some of the key steps, even to understand from the neurosurgical perspective, is really the medial maxillectomy that should be done. And I include this figure from Casanuevo's group in Italy, and they did a great job in terms of categorizing the different types of medial maxillary windows that can be created depending on where you want to get into the skull base. And for a petroclival chondrosarc, when you want to get really lateral, the medial maxillectomy that needs to be performed is somewhere between what's illustrated in C and D, where an anterior posterior ethmoidectomy, middle turbinate resection, the back half of the inferior turbinate, and the nasolacrimal duct to some degree skeletonized. And that really allows ultimately lateral and low exposure. The next key step is really dissecting out the pterygopalatine fossa contents. Certainly the distal branches of V2, the infraorbital nerve, and the descending palatine nerve you want to preserve throughout the dissection. The vascular compartment of the PPF is dissected where the distal branches of IMAX are identified, and I typically clip the sphenopalatine artery. And then working through the posterior periosteal sheath of the PPF, you gain access to the infratemporal fossa. And part of the dissection here really focuses on dissecting the inferior head of the lateral pterygoid muscle and detaching it in a subperiosteal fashion from the lateral pterygoid plate. And then ultimately V2 exiting foramen rotundum is identified to really then isolate the medial and lateral pterygoid plates, which then can be resected in their entirety, going anterior to posterior while skeletonizing V2, going back to Meckel's cave and following the Vidian all the way back to the carotid artery. And the rationale for doing this for a petroclival lesion is that this really allows you to gently laterally mobilize the contents of the infratemporal fossa so that once you get back to the skull base, you can have access not only to the midline, but all the way out to the parapharyngeal space, the jugular foramen, and the lower cranial nerves as they exit the jugular foramen. Now, within the skull base, the next steps here really are focused on the carotid artery. And so at this point in the operation, V2 has been skeletonized going all the way back to Meckel's cave. The horizontal, paraclival, and cavernous segments of the carotid artery completely skeletonized. Given that there was disease here, I did a mid and low clivectomy. And at this point, basically, I'm resecting bone around foramen lacerum such that you're only left with the fibrocartilaginous tissue along the inferior half of foramen lacerum. And this is then sharply transected. And the rationale for doing this, one is that when you do this maneuver, in addition to resecting the lingual process superior to the ICA, this allows the ICA to be mobilized up superiorly. And then in addition, by transecting this fibrocartilaginous tissue, this really helps with the eustachian tube dissection. There we go. And so the next steps really are focused on dissecting out the cartilaginous portion of the eustachian tube. The muscular attachments of the eustachian tube are then dissected so that you can skeletonize the cartilaginous portion, and the cartilaginous portion of the eustachian tube is then sharply transected at its junction with the bony eustachian tube. And of course, when you're doing this maneuver, you want to be cognizant of where the parapharyngeal carotid artery is relative to this cut here. And then once you do that, your access to not only the bony skull base, but any tissue, tumor extension ventrally into the parapharyngeal space, the longest musculature, and the rectus muscle is readily accessible. And all of this bone can then be drilled out. And on this image on the right here, you can see the hypoglossal canal skeletonized. The sucker tip is on the medial aspect of the jugular foramen, and then the disease extending ventrally was all sort of resected. And here are the postoperative scans for that patient. And what you can see on the MRI scan on the top left here is how far lateral you can get with the vertical Petrous carotid artery skeletonized here. Now, certainly a key point in the discussion here is really regarding the eustachian tube and the risk of conductive hearing loss after an operation like this. Certainly when you resect the cartilaginous portion of the eustachian tube, a significant majority of these patients do develop conductive hearing loss that requires a tympanostomy tube. Now, to put that in perspective, for some of the higher grade cancers where they definitely will go on to get radiation therapy, whether you do an open or endoscopic approach, save or resect the eustachian tube, they ultimately all go on and develop conductive hearing loss and need a tympanostomy tube anyways. For the lower grade tumors like a low grade chondrous sarc where they don't need radiation therapy, much more thought is put into simply either just mobilizing the eustachian tube or using the contralateral transmaxillary approach that Paul discussed earlier. Now, as I mentioned, there are additional compartments that you need to resect with these petroclival tumors. So this is an example of a petroclival chondrous sarc with involving the lateral cavernous sinus. And here, the carotid artery is displaced anteriorly and completely skeletonized. V2 going back to Meckel's cave. And for a case like this, what I do is dural incisions on both sides of the carotid artery so that you have good proximal and distal control and allows you to mobilize it. And then here working within the lateral cavernous sinus with the sixth nerve going into the supraorbital fissure. This is an example of a patient that was referred to me after an endoscopic transclival and an anterior petrosectomy for a large petroclival chondrous sarc. And they had significant subdural disease against the brainstem, in addition disease laterally at the petroclival junction. And so what I did is I started out here with revision endoscopic approach, adding on a transpterygoid approach. And I include this in terms of highlighting that you can manage subdural disease extension relatively easily. And so the key points here is that with the endoscopic approach, you want good cranial caudal exposure of the vertebrobasilar system so that you're able to identify that arachnoid plane even with a reoperation so that you can sharply dissect the posterior capsule of the tumor off the vertebrobasilar system so that you're left with a view of the entire arterial tree in the brainstem. Now, of course, with an operation like this, you're left with a wide dural defect. And especially with these petroclival resections, they're not midline defects. They extend out laterally towards the jugular foramen. And admittedly, at least in my practice, I tend not to rely on the intranasal flaps as much because there are often reoperations or extended defects. And so for these cases, I do have a lower threshold to use a regional flap, such as a temporoparietal fascial flap or a pericranial flap. And so in this case here, I did a bicoronal incision. And you can tunnel that pericranial flap through a slot at the nasopharyngeal suture. And here the video is showing a reconstruction at the end of a transclival left-sided transpterygoid resection. And you can see the pericranial flap's not only relatively easy to harvest, it's robust and long enough so you can get down to the craniocervical junction and it's wide enough so you can get out laterally towards the jugular foramen to cover any exposed skull base and dural defect. So as I mentioned earlier, when we looked at our outcomes, there's a lot of room for improvement with petroclival pathology. And when we look with the use of an endoscopic transpterygoid approach, what we find is that using that as the workhorse, and then for selective extensions, adding on a lateral skull-based approach has significantly improved our resection outcomes and also significantly decreased our neurologic complication rate. And so this really has become sort of one of the workhorses in our toolbox for managing pathology in this area. But, you know, as I think the point of this seminar, this session is supposed to highlight is that you can't be too dogmatic about when to use a single approach. And so there are particular patterns of either skull base or subdural extension that I look for where I start thinking about doing either a posterior petrosal or combined petrosal approach. And so this is an example of a giant cell tumor that I treated recently. And here, because of the tumor extension lateral to the vertical Petrous carotid artery, I felt that this is one that I would not be able to tackle completely endoscopically. And so here, what I did is I combined petrosal with the retrolabyrinthine extension to really resect this tumor. Then there are some higher grade malignancies that involve the Petrous apex, but also involve the lateral temporal bone structures. And fortunately, you don't see that with some of the lower grade tumors, but with high grade osteosarcs and high grade chondrosarcomas, you can see that. This is an example of high grade osteosarcoma involving the cochlea, the temporomandibular joint, the mandible, and the infratemporal fossa. And so in a case like this, this is an open approach. And so, you know, I did a variation of a fish approach here, but with the preauricular incision where the ear canal sacrificed deep and the pinna is rotated posteriorly, and that provides sufficient access to the temporal bone and the entire infratemporal fossa. And here are the views intraoperatively from that total temporal bone resection. You can see where my pointer is, the facial nerve skeletonized going into the parotid gland. At this point, the infratemporal fossa, the middle fossa, the temporal bone's been resected. Images on the right here show the parapharyngeal vertical Petrous. The forceps are on the junction of the vertical Petrous and horizontal Petrous carotid artery. Hard to sort of appreciate here, but the suture line here is on the eustachian tube, which I closed up at the end. And then the suture line here is on the stylopharyngeal fascia, which is a good sort of fascial barrier to preserve throughout the dissection, just so you can preserve the lower cranial nerves exiting the jugular foramen. Now, there are also some patterns of subdural disease extension I look for where I start thinking about doing a combined petrosal. You know, whenever there's disease extension lateral to the sixth nerve, I think about adding a lateral approach, and similar if there's disease extension lateral to the third nerve. But there are also some in-between cases. And so this is an example of a clival chordoma I treated a couple of years ago, where there was a small point of origin at the lateral aspect of the mid-clivus, and most of the disease was really in the subdural space, you know, with the fifth nerves and the sixth nerve on both sides of the tumor, and a little eccentricity towards the left jugular foramen, and with some internal calcification. And so when I was planning for this case, this is a case where I thought that I should be able to achieve it endoscopically and with a transclival approach. And you certainly hope that when you're doing the transclival approach and working in the subdural space, that you could hopefully bring that lateral edge of the tumor into your field if it's a little bit of a softer tumor. And so here I am intraoperatively during that resection. At the edges of the field, you see the carotids both skeletonized, a wide clivectomy, a wide dural resection. And at this point in the operation, I had cleared disease away from the left vertebral artery, the right vertebral artery, the basilar, and all the perforators, and was working on this knuckle of tumor along the left lateral edge of the tumor using the sonopet. And basically I hit that wall of calcification. And whenever I tried to debulk it, the sonopet wasn't touching it. And then I tried sort of finding a plane of dissection where I could sharply dissect the back end of the tumor in a medial to lateral fashion. But ultimately the back end of the tumor more medially was all calcified. So after sort of persisting at this for some while, I realized that I wasn't going to move anywhere. So I stopped the operation at this point, did my reconstruction, and then I did a left-sided combined petrosal approach. And so here, the image on the left, you can see the retractor on the petrosal surface of the cerebellum, the lower cranial nerves, the prostoprobe on the vestibulofacial complex, tumor in that interval. You know, I dissected the pores trigeminus and the trigeminal nerve all the way out anteriorly. The superior pole of the tumor up against the basilar apex. And then it's hard to appreciate here in the image on the right, but basically the tumor completely resected with the ipsilateral vertebral artery in view. And here are the pre and post-operative scans. You can see on the left, the preoperative scans. And on the right, a complete resection. This patient did have a partial sixth nerve that got better about 3 months after surgery. So I included this case, but to highlight that while there are cases where you hope to hit the home run endoscopically, knowing that you have the backup of a lateral combined petrosal approach is helpful, so that perhaps you don't push surgery too far, but still hit the home run for the patient. So to wrap up, in terms of deciding between an endoscopic and a posterior petrosal or combined petrosal approach, I think understanding the disease, understanding the goals of surgery are critical. Each tumor has its own particular pattern of extension and relationship to the nerves and the neurovascular structures. For most of the bony tumors in this area, I tend to prefer an endoscopic transpterygoid approach, recognizing that it comes with the morbidity of a conductive hearing loss. But also recognizing that there's a clear role for the open approaches for particular patterns of tumor extension and subarachnoid extension. And then this figure on the right here I include because, certainly while the radiation therapists and the medical oncologists have a whole toolbox of options to offer patients, it's important that the goals of surgery is still the same and not sacrificed. And I think having the open and endoscopic approaches and being able to combine them can help sort of, redefine expectations for surgery for seemingly difficult tumors. So once again, thank you very much for including me in this session.
Thanks, San. So that's a great talk, with your great experience with chordomas, chondrosarcomas. I wonder if, Paul, you want to make any quick comment while we have Nate Swagman coming up next. Nate, are you with us?
Shauna, that was a really nice talk. That's an incredibly difficult area. And I think that the job you did of outlining your criteria for it is, I think, useful for everybody. I think the one thing that's changed a lot for us is that CTM approach for these bony tumors, but still the criteria that you have applied there, I think is one of the most clear-cut paradigms I've seen. So I think I think there's a lot to wrap our heads around there. Good job on a tough topic.
I appreciate that. I have a quick question for you, Paul. With that CTM approach, I've tried it over the last couple of months. So I find it very helpful for sort of tumors located more superiorly along the Petrous apex, like at the level of the IAC. Trying it more inferiorly, like towards the jugular tubercle, I find it a little bit of a challenge. I just want to see sort of what your experience has been with sort of like the lower pole of tumors in that area. Because I think it's great. You avoid a lot of that eustachian tube and dissection and the need to really sort of mobilize the carotid artery. It's a very elegant approach.
Yeah, I think there are two keys to that. One is really maximizing the inferior aspect of the medial maxillectomy. So you have to take it down almost to the hard palate. So you really have to even drill that down because that limits you. And then sometimes we've had to mobilize the flap a little bit, open up the posterior maxillary wall and drill down as much of the pterygoid wedge. Those are the two things that limit your posterior and inferior access, but you're absolutely correct. That does become the limitation as reaching inferiorly, but I think that those two little tricks at least help that part of it, but you've nailed it. The sweet spot is right at the IAC. You're absolutely correct.
Also, I would add, the anatomy of the foramen lacerum is so important to understand well. And it took a while. There are so many different names for that cartilage, fibrous tissue that attaches to the carotid. But the right name, and this for all the attendees, is the Petrosectomy, the pterygo-sphenoidal fissure between the pterygoid bone and the floor of the sphenoid sinus. And the name is the least important part. The name includes the concept. It's between the pterygoid bone and the floor of the sphenoid. If you drill both, you're going to follow that fissure all the way to the carotid in the foramen lacerum, which is so difficult to expose. And by this quick anatomy trick, you actually can make it easy. And it works all the time. Okay, Nate, you're up.
How are you?
It's great to see you. For those that you don't know, Nate, he did residency with us in UPMC, and he did a 2-year fellowship in Foley with us. He did a phenomenal job, and I know he's doing great things in Wisconsin, whatever that is, Nate. And we're very glad to have you.
I would put a picture up what it's like outside, but it's too miserable right now. So you guys certainly have better weather where you are. But anyway, thank you very much for the opportunity to talk about a topic that I'm very interested in. I appreciate to be with all these great panelists as well, and we'll get to it. Juan had asked me to talk about the extended retrosigmoid approach versus the endonasal approach, and this is a really good topic because I think these two approaches are really complementary. And it's not one versus the other, but a lot of times they can work together. And I'll show you some examples of that as we go forward. Oops. First of all, I have nothing to disclose, not yet anyway. From our standpoint, these are the topics we're talking about. These are the tumors that we're trying to address that are complex. They involve parts of the posterior fossa and extend down. And when it comes down to these topics, what the initial approach is really kind of determines how this case is going to go and what we need to accomplish with the resections here. As one of my mentors in Pittsburgh like to say, a fool with a tool is still a fool. And even though we can do these things through different kinds of approaches, it's really important to understand when to use them and when your team is best to use these kind of things. And so even though we talk about different ways to get there, the most important thing that we talk about is understanding your comfort level with these approaches and what you're trying to accomplish. When I'm looking at approaches and trying to figure out how to deal with these tumors, one of the things I like to tell my residents is the tumor determines how we get there, not necessarily what we have. And so based on what the tumor looks like and what the tumor is doing really determines in how we approach these types of problems. And so when I'm thinking about approach, I'm looking at maximum symptom improvement. What are they presenting with? How do they come to me? And what can I help them with? Obviously, you want to get as much tumor out as you can safely by minimizing patient morbidity, but also improving the patient's experience through this process. A lot of times, and we've all been there, the patient comes to you, they have a brain tumor, they're scared, they're nervous, and appropriately so. And our job is to help manage those expectations with what we have to accomplish. And so beginning right off, I want to know what the patient's presenting with. Are they presenting with hearing loss or visual decline or facial pain? All these things that oftentimes bring patients to our clinics. And then having a discussion with the patient to try to determine what does the patient want to accomplish? Now, obviously, a lot of times they come, they want it out. But at the same time, having a discussion what that really means sometimes may change that goal. Understanding what the approaches your team is comfortable with. So if you're not comfortable with a contralateral transmaxillary approach, pulling that out in a patient experience without practicing in the lab can oftentimes lead to disastrous results. And understanding what the risks are associated with it. So cranial nerve injury, vascular injury, things like that pop up. Reconstruction considerations are very important. And is the patient prepared for a multiple stage approach, or do they want it all over in one setting? A lot of times those kind of things need to be weighed in and help us plan what happens next. And so the extended Richard sigmoid approach is a workhorse for neurosurgery. We've all done this before, where we try to accomplish a wider opening. Exposure of the transverse sinuses and sigmoid sinus allows us to get more of an angle to accomplish our goals. A lot of times we remove the suprameatal tubercle, which allows us to get higher by cranial nerve 3 into the Meckel's cave further. Oftentimes we do a partial mastoidectomy anterior to the sigmoid to allow us again to retract that sigmoid more out of the way to get a better visualization of our target. The combination of these things allows us to get access to the medial structures of the CPA and superior into the Meckel's cave, which we talked about. And the risks are the risks of things that are around this area. So the risks of the vascular structures, the sigmoid sinus, the vessels that are in that area, the cranial nerves, as you get deeper, are going to be limitations and cause potential risks. And then other things, CSF, leak, wound healing, and postoperative pain comes into effect of these as well. So important things to consider when you're talking about the retrosigmoid approach. At the same time, the endoscopic nasal approach has been used for approaching these kind of things. It can also be modified to include further reach. And so the contralateral transmaxillary approach, transpterygoid approach can obviously extend your reach laterally. And then finally, some of these interesting ideas with a transconjunctival approach will get you more access as well. So modifying these approaches, just like if you modified a traditional approach, can get you more access. Again, the combination which approves you to, allows you to get to different areas to access pathologies in these locations. Finally, the risks are limited again by vascular structures. If you're coming from the front, you've got to deal with the carotids. A lot of times the basilar artery is going to be right in your way, along with the perforating branches off that. CSF leak has been a historical problem with the ventral approaches to the intradural pathology. And so knowing how you're going to address that is an important aspect of things. But other things come up, specifically the things that Dr. Raza talked about and others. Cranial nerve 6 is going to be in play a lot of times when you do these more extensions laterally. Cranial nerve 3 comes into play. If you're trying to access to Meckel's cave, cranial nerve 5 becomes a risk. So all the same kind of things happen, only in a little bit different of order. Wound healing is an issue, cranial nerve injury, and then postoperative pain that may be associated with this as well. And so I like this slide a lot because it shows the residents a lot of the traditional approaches for how we approach pathology in the posterior fossa. And it really kind of highlights some of the bigger things that I'm worried about when I think about the approaches, specifically nerves and arteries. Those are essentially my defining lines about where and how I can get to different pathologies. And so when it comes to the approach from the endoscopic and endonasal approach, you're really looking at the lateral aspects of cranial nerve 5, cranial nerve 6, are really as far out as you can get intradurally. Again, Dr. Raza talked about the bony anatomy, which allows things to do a little bit better resections from an endonasal perspective. But the nerves and the blood vessels are what limits us. Same thing when it comes to the extended retrosigmoid approach. So you're going to have to deal with the limitations of dealing with the sigmoid and the transverse sinus. And then the lower cranial nerves are going to be ventral. And a lot of times you're going to be working between the lower cranial nerves and cranial nerve 7 and 8 and 5 as you do these more midline approaches. So you can see that the two approaches are very much a complementary hybrid and can really work well with each other to attack pretty complex pathology. This study here, again, looking at the vantage point you can get with the extended middle fossa and the bony anatomy that you can see there, and allows you to get a better viewing angle, especially for some of those deeper pathologies or more superior pathologies that may be ventral to some of the lower cranial nerves. Another study looking at the bony stuff from the endonasal endoscopic perspective. A lot of this has been touched on before, but you can really tackle most of the clivus. And as you get inferiorly, you can actually extend your exposure more widely because you're below the level of the carotid being the limiting factor as you get to that mid-clival region. But as has been described earlier, we're finding ways to work around that. And so here's a pro section that we did that really looks at some of the anatomy here. I'll buzz through this fairly quickly. Here you can see you can get ventrally pretty well, but really what happens is our lateral extension is limited because of the artery. Now, obviously this is a cadaver, so I can be a little bit more aggressive through this. But as we look up and around, you can start to see that because of the anatomy that's there, the endoscopic and approach is really going to be limited as you look more laterally. Again, into the third ventricle, you can see the third nerve there, the tip of the basilar artery into the third ventricle. And again, some of these lateral pathologies here dissecting out the third nerve further. And now really trying to look lateral to see what we can see. You see the sixth nerve inferiorly there, dissecting the arachnoid plane. There's the sixth nerve. You can see 5 in the depths there. And even further out, you'll see that you can see 7 and 8. Unfortunately, one of the risks of doing this is sometimes you can cause an injury to the sixth nerve, which is going to happen right here. As we dissect further out, again, why getting out there is so difficult. But eventually you'll see there's 7 and 8 down the depths. And so here's a patient that we did a resection of a clival chordoma. The carotids are exposed. We're removing the dura because there was dural involvement here. And again, this is a real life application of what you can see. You can resect more of this dural laterally. Here we're looking out to the side, exposure of the basilar artery there. Again, getting a good resection and good visualization to make sure there's no further intradural disease. There's cranial nerve 6 down there. And that's really the limiting factor when you come in from just this approach, as 6 becomes a big player in which you can and can't accomplish. Here we are stimulating that. And so when we talk about the approaches, really the question is what approach to use, and that's what we've been harping on the whole time. And again, they're very complementary, where the limitations of the extended retrosigmoid approach is really where you're starting to get more into the prime time, so to speak, for the endonasal approach, and vice versa. The things that are more difficult endonasally are going to be easier from an extended retrosigmoid approach. And so as we harped again earlier, and I think it's important, what are they presenting with? If they're presenting with more visual complaints or facial numbness or brainstem compression from gait, I tend to favor an endonasal approach for those kind of things, especially depending on the anatomy and where the tumor is, because I can decompress and resect that tumor much more easily when it's more of a midline type pathology. If they're having more of a lateral type problem, where they're having hearing problems or facial nerve issues or swallowing, again, with brainstem compression, I tend to favor a more retrosigmoid approach. Again, every tumor is going to be different. I'm going to approach each one from a different perspective, depending on what's going on and what my goals are to accomplish. Again, re-emphasizing here, the approaches are highly complementary, and many times are used in combination with the staged approach, which I'll describe a little bit later. And so here's another example. I think Dr. Gardner talked about this earlier. This is a trigeminal schwannoma, and there's a lot of ways to get to this pathology. Certainly some people would approach this retrosigmoid, although it'd be tough because there's a large Meckel's cave component. Middle fossa is a classic approach for this, which is a very, very good approach as well. But given the large amount that's in Meckel's cave, we actually decided to approach this endonasally because we were able to get the access between the carotid artery and follow V2 back, which allowed us to get right to where we have to go. Here we have the carotid artery exposed. You can see we're starting to get in the tumor at this level here. And then we just switch back to our typical microsurgical dissections, getting more exposure, working through this window using ultrasonic aspiration, as well as other techniques to help debulk this tumor. Eventually, by taking out the inside, you make the tumor softer, you're able to dissect the nerves away from it, working in that corridor. Eventually, we were able to get a pretty decent resection here, again, mobilizing the component. Eventually, we get all the way back to the cisternal segment, and that allows us to make sure that we have the whole thing. We can drive the endoscope in there to look around when we're all done to get a good visualization, but this patient did very well. So even though this tumor is lateral to the carotid artery, we're able to work in it because it's in Meckel's cave. Now, if it had a larger posterior fossa component, I don't think I would have been able to approach it that way, because as you get further back, working through the narrow corridor, it's really hard to see. And as you start to extend that approach up and down, you start to run into the vessels and nerves of the superior superior orbital fissure, sorry. And so here you can see the postoperative pictures. We got a good resection, and she did fairly well with this approach. Again, a young woman who preferred to have it done through a minimal access approach if possible. Here's another tumor. So this is a tumor in a patient who presented with hearing loss and severe gait instability. It's a tumor that goes fairly wide up to the tentorium. You can see there down to the lower cranial nerves. And so a pretty large tumor with the guys significantly symptomatic. From our approach for this, we decided to take him for an extended retrosigmoid approach for this lesion with the goal of decompressing as much as we could safely. Here we left some on the brainstem. I could not get that off, and you can see we're up to the basilar artery here. But what we noticed with this approach is that over time, as the tumor condensed, it actually allows us to get a much more manageable approach down the road. So now this is a patient who we could consider going through an endoscopic and endonasal approach to finish the rest of the tumor versus debulk it as we go forward. And here's a good example of that. This is a patient who presented initially with a 6 nerve palsy. We ended up taking her first for endonasal approach and then doing a retrosigmoid to complete the job with a really good resection. She still has some tumor left in her cavernous sinus, which we'll keep an eye on. And from my perspective, I'll keep it short and sweet. Once again, thank you guys for the opportunity to discuss some interesting cases. Thank you to my mentors who taught me how to do these kind of things and help us to learn the anatomy, which allows us to proceed with further surgical resection and to essentially get better. So thanks again, Juan and Paul. I appreciate it. And I'll turn it back over to you.
Thanks, Nate. That was great. I actually am, very proud and happy with the work you're doing. I'm sure Paul is too. I don't know. I can let him do. You're gonna make any comments, Paul? But Sebastian, are you with us?
Yeah, I think before Sebastian hops on, I think both that endonasal and the retrosigmoid are two standard workhorses that we all use in skull-based surgery. And I think if you have, only choose the 2 or 3 approaches, those have got to be a part of it. So congratulations, Nate. Nice job and some beautiful cases.
Absolutely.
Thanks,
Sebastian. Great to have you with us. Thank you for joining us. Sebastian needs, again, no introduction. He's probably the most prominent European skull-based surgeon with a tremendous experience with the far lateral, extreme lateral approach and endonasal surgery for multiple lesions, but in particular chordomas, chondrosarcomas, etc. So Sebastian, please share with us what you got.
Thank you, Juan. Thank you very much for this invitation. It's very nice to see you all. So I will talk about far lateral, extreme lateral versus extended endoscopic endonasal approach. Do you see me? Yes. Do you see my slides?
Mm-hmm.
Okay. So as you all know, there is multiple options for those lesions in the craniocervical junction, because what we are talking about now, talking about far lateral versus endoscopic endonasal, it's mostly for craniocervical junction tumor. So options are multiple. We have endoscopic endonasal, we have anterolateral approach or extreme lateral, we have far lateral, and transcondylar addition to it. What the pathology we are talking about, at least in my hands, it's mostly chordoma. We sometimes have meningioma. I personally don't do foramen magnum meningioma using endoscopic endonasal approach. I do clival meningioma, but not foramen magnum meningioma. And schwannoma is definitely a tumor, I believe, that is reached with transcranial approach and not endoscopic approach. So our experience with chordoma started with Bernard Georges, my mentor. We have significant experience with chordoma at the level of craniocervical junction. I will start with endonasal approach, which definitely is an extremely important option for those midline lesions. And we have done a lot of those cases endoscopic endonasally. When you go midline, when the tumor is midline, it's not extending too far laterally. In fact, it's a very straightforward approach, and you don't have much to do to reach the tumor. It's definitely the best option for chordoma located on the midline. Whenever it's going more laterally, you have shown some beautiful example of cases before. Still, the technique you need, the approach is much more complicated, and the risk for the cranial nerve, for the vascular structures, the ICA, is significant. So here is a case of midline chordoma. It's not extending very far laterally. It's a perfect case for endoscopic endonasal. You don't have to resect anything, in fact, just you flap back and you push this down and you expose the tumor. And with angle instruments, specific instruments, you can reach everything. You can drill and you can achieve a complete resection with almost zero morbidity related to the approach for the patient. The outcome in cases like this is excellent. You can drill infiltrated bone quite easily and really make a nice tumor resection in a case like this. We have tumor of this type which are more extensive, and this could require very extensive approach endoscopically, trying to expose the different corridors. There is tumor in the cavernous sinus, it's going down in front of C2. But for those cases, we used in the past the classic endoscopic endonasal approach with all the tools that you have described before. I have to say that for chordoma like this, where achieving a complete resection in terms of microscopy is very difficult. So we try to limit the aggressiveness of the approach, and I am using this technique using one nostril approach, using angle endoscope, 30 degrees, 45 degrees, 70 degrees endoscope, but also those endoscope where you can change the angle with the same endoscope. Angle instruments also. I just make an incision here on the rostral mucosa. It's a one nostril approach. Then you enlarge the corridor, and using those angle endoscope, in fact, you find here the true meaning of the endoscopy, which is to use the cavities that you have and then to really take advantage of the endoscope, which means looking in corners, different corners. Here we can see the back of the C2 segment of the ICA. We reach laterally the jugular foramen, the condyle hypoglossal canal. And at the end of the surgery, we close the cavity with a big piece of fat after cranializing the sphenoid sinus, and we stitch this mucosa of the rostrum, which is quite thick. So in those cases, question is, should we resect the dura mater? I've seen cases before where there is dura mater resection for chordoma like this. I personally not a strong advocate of this because I think that for chordoma, you have other location where tumor is infiltrative, and it's not because you resect this dura that you achieve a complete resection either. But it's something that that it's still controversial, and we don't have the answer yet. This is a postoperative MRI. For chordoma like this that I used to do endoscopically, it's a very extensive tumor. It's inviting both condyle, jugular foramen. It's going posteriorly up to the level of the vertebral artery. You have a little bit of tumor infiltration intradurally here. And the approach is significant. You need here space to work. We resected here the eustachian tube on one side. It's a very extensive approach. It's needed to resect a tumor like this, so extensive. But at the end of the surgery, surgeon is happy, but the next day for the patient and the weeks after, it's not necessarily a very easy recovery for patient like this. And I have to say that over the years, I have moved more towards transcranial approach. And the journey is not over for this patient because endoscopic endonasal approach here created some additional instability, and the patient needed to be fixed rapidly after. So the surgical footprint for those extensive tumor of the craniocervical junction is, in my opinion, significant, and trying to find other options for those tumors to make the postoperative course and the approach-related morbidity lower, I think is really the true meaning of skull-based surgery and approach selection. So far lateral transcondylar is a great tool for some of those tumors, definitely not all of them, but here is an example of quite huge chordoma. This patient was already severely impaired. He had a right complete 12. It was partial on the other side. And he was not in such a good condition. So here, question is, can I achieve a nice resection endoscopically? I could, but my goal here was really to try to keep what was remaining of the left 12. And I thought that closing this big hole here after resecting this intradural extension would be probably difficult. So I chose here, and another criteria to choose the posterolateral was that I wanted to go as fast as possible to proton beam therapy and not to need an additional surgery for fixation. So here is some other view. We decided to go posterolateral, far lateral. The condyle was already gone, so we have a corridor here to get into the tumor from behind. And we do exactly the same with the endoscope, angle endoscope that we would have done through the nose, putting 0 degree, 30 degrees, 70 degrees to take the tumor away from the other side. If the vertebral artery on the other side is encased, and if there is difficulty, you can do exactly the same from the other condyle. So this is what we did, and here is the video of this case. So with a far lateral transcondylar hockey incision ending at the tip of the mastoid. Here is exposure of the vertebral artery, opening C1 transverse foramen, mobilizing the vertebral artery to have access to the condyle, but also to the lateral mass of C1 to drill it a little bit to have a better access to the tumor. And very rapidly, we are into the tumor. And because the condyle is already gone. So there is not much drilling to do here in a case like this. And once we are into the condyle, tumor resection, it's like for any kind of chordoma. Most of the chordoma, it's not so difficult by itself because the tumor is soft and you can take it out with suction or rongeur quite easily. And when we start to be limited with the microscope, because the tumor is going very, very far away on the other side, then we put inside the endoscope to look on the opposite side, to look up into the clivus also, and also to look down. And again, it's not very different from the skill we need for endoscopic endonasal approach. It's just another keyhole we go through instead of the nostril. Here is a drilling upward towards the clivus. Here is the beginning of the resection on the opposite side. Definitely you need angled ENT instruments to do that. You cannot do it with the classic neurosurgery instruments. There was a little bit of dura infiltration and resection in this case. The arachnoid was intact, so there was not a significant leak. And here we are resecting the tumor on the opposite condyle, exposing also the contralateral vertebral artery, for which it's the tricky part. And for this, we did some anatomical work in the lab to try to have a vision of how it would look to look at the vertebral artery from this angle of view. The nice things with this surgery is that at the end, we are able to fix this patient. We put some cement between C1 and what was remaining of the condyle on the bone above it, and we fixed the patient. So we did a kind of all-in-one surgery. Recovery was not so easy because we put a track before the case because of the risk of issues post-op. But the track was removed 44 days after the surgery, and he was able to start his proton beam therapy, which is absolutely necessary in a case like this. This is our work in the lab to try to get ready with those new angle of view. Here is the exposure of the contralateral vertebral artery, looking at it with an endoscope from the opposite condyle. Finding the vertebral artery, you need to drill the bone to open the transverse foramen of C1 and C2, staying into the bone. That's the only way to safely expose the contralateral vertebral artery. Here is another case of a patient with a chordoma of the craniocervical junction. You see that there is some lateral extension. There is also intradural extension. And there is a little bit of contrast enhancement here on the back of the tumor. I was not confident with this because I thought it would be fed by posterior circulation branches. And I thought that the relationship with the brainstem, with the vessels, with the tiny branches of the pica would be tough to control with an endoscopic endonasal approach. So here is the same. Decided to do a posterolateral, far lateral transcondylar approach, putting the endoscope inside to get the extradural part of the tumor out from this keyhole. Here is the surgery. It's quite similar than before, except that I did some drilling also of the lower aspect of the mastoid to have some control of the jugular foramen. Here is a tumor bulging. You saw at the beginning of the video, which was quite interesting, there was a pathological fracture already of the condyle in this patient. He presented with neck pain only. This is a control of the prevertebral space. And once this is done with the microscope, we resect everything we could. Then we put the endoscope to go up towards the Petrous apex. We are looking here at the Petrous ICA from below, the paraclival ICA, and we are here looking at the mucosa of the sphenoid sinus from below. And the nice things now, because the nice aspect of this approach comes now, we can open the dura, we can have a nice control of the intradural part of the tumor, with the microscope and our usual tools, and I can quite safely make a complete resection of the dura that I think is involved. The more you resect the dura with an endoscopic endonasal approach, the more you increase the risk of CSF leak. So here I'm not limited by the dural resection. I resect everything I believe is infiltrated. The only thing you need to do is to close carefully the mastoid process to avoid a leak. Postoperative MRI was nice. A little stroke here you see in the amygdala, and it was probably because I sacrificed tiny vessels from the pica. Here is another case. This patient was operated 2 times with a retrosig in another institution, 1 time with endoscopic endonasal approach. And this is what remained. We have here a piece of tumor going into the brainstem from the side. It doesn't look very good. Here, definitely, I don't think that the endoscopic endonasal will be enough for me to resect this tumor. So we do a combined strategy. We resect everything we can from anterior, trying not to cross the dura mater, and we will resect the rest of it with a posterolateral far lateral. So here is the endoscopic endonasal approach, nasoseptal flap. We do a transpterygoid approach on the right side here to have a better control of the ICA on tumor. Tumor resection was not so difficult, but you see that you need to resect some mucosa, pharyngeal muscle. We could nicely find a plan between the tumor, around the tumor, which was quite nice in this patient. So we could do some kind of en bloc resection of some part of the tumor. At the end, we drill the condyle, and when I feel that I reach the dura, the limit, then we decided to stop. We put fat on the nasoseptal flap. I wait maybe for 2-3 weeks, I don't remember exactly, but few weeks before going from the back with an MRI that was showing me the exact pieces of tumor I had to look for from the posterolateral corridor. So you need a plan before to do not forget pieces of tumor. So same than before, I will go fast on this. But it's going fast anyway, the video. So here is after transposition of the vertebral artery, I put the endoscope inside, and you see the fat that I put from anterior. Here is drilling of the jugular tubercle. Here is a resection of this piece of tumor here encased into the brainstem. And the resection was nice. Saying that it's a complete resection is probably not the case, but at least the post-op MRI looked nice. The only thing I left was a little bit of tumor along the endotoid process. Hopefully, she already had some radiation therapy, but not the full protocol. So she had some additional radiation after this surgery. I will now move from extreme lateral approach, showing 2 cases. It's another option for those tumors. The advantage is that you can go lower whenever the tumor is going below C2. It's difficult endoscopically, endonasally. So here we can go down to C7. And when the long axis is from one side to the other, I have to say that I like the anterolateral approach when the vertebral artery is surrounded by the tumor. Transposition of the vertebral artery, exposed condyle, exposed lateral mass of C1, and you can go obviously lower until C7 without much difficulty with a fantastic control of the anterior aspect of the tumor. I see James is laughing because of my French accent, I believe, no? But you can also go upward to the jugular foramen quite easily if the tumor is going inside. So this is a case of a chordoma. You see that the axis is from one side to the other. It's going quite low, but not so low. So it's not the reason why I used the anterolateral approach. And there is some intradural extension with some vessel encasement I'm not very happy with in this young lady. The goal here is really to get a complete resection because she's young. So I want to resect the dura on being free to resect it. So here is the approach. Incision in front of the sterno resection, transposition of digastric, Here is the exposure. I tried to keep the cervical branches to keep to do not have too much of hypoesthesia of the skin post-op. Here is a transposition of the vertebral artery to get access to the condyle lateral mass of C1. The issue here is that I will create some instability. So this lady need a fixation after. This is a disadvantage of this approach when the condyle is not completely drilled, is not destroyed completely by the tumor. You finish to destroy it. And so this has to be balanced in the decision-making process. I did a mastoidectomy here, opening of the jugular foramen also. In this case, a little retrosic craniotomy, and then open the dura to take out the pieces of tumor that were intradural. It was multiple ball of tumors, not so difficult. In fact, maybe I could have resected it easily from endonasally. It's not always easy to predict how tight it will be, the relationship with the neurovascular structure. At the end, I put an endoscope inside. You see the cervical spinal cord from above. And I find on the opposite side this little ball of tumor, which is really on the corner. I probably would have found it if I would have gone endoscopically, endonasally, but not completely sure. Here, I have no restriction with the resection of the dura. I can take everything I want with a low risk of leakage. Closure, usual way with a little pericranial piece of tissue fat. And I put this cement because I don't want to fix this young lady before proton beam. So I put cement between what was remaining of C1 lateral mass and the mastoidectomy cavity. And it was stable until she could receive proton beam therapy and with a collar, and I did the fixation afterward. I finished with this case. Here is a chordoma of the craniocervical junction. There is two spots. It's not so usual, but there is also tumor here at the C5, C6 level. So here it's the beauty of the anterolateral approach is that I can take everything in the same surgery. So anterolateral approach, exposing the lower part of the tumor first. This patient was operated before a long time ago. It was a recurrence. The lower part of the tumor was not radiated before. The upper part of the tumor was radiated, and it was a recurrence. But it was a kind of slow growing recurrence. This is why I wanted to be aggressive with this patient. Here is a resection of the lower part of the tumor, working between C5, C6, around the vertebral artery, drilling the pathological bone. There is no sense to try to make an en-bloc resection because there is multiple location. And here is the upper part of the tumor, transposition of the vertebral artery like before, getting into the tumor, taking the tumor out. It's exactly the same, complete transposition of the vertebral artery from C3 to C0. It's a little bit more difficult than just C2, C1 segment. Here, drilling the bone, there was a fracture also here. There was a brainstem compression because of the fracture. I am drilling everything here. It's a very nice corridor because you can drill everything and you can take everything out without much risk. It's really a free way towards the opposite side. The only issue on the opposite side is to be careful with the vertebral artery. This is a vertebral artery, and now I am drilling up. This is the limitation of anterolateral approach. You cannot go so far up, but with an endoscope between both hypoglossal canal, I was able to drill the clivus up to the mid clivus, I would say, to achieve a nice resection. The same than for the previous case, I put some cement because I don't want to fix this patient right away. I want her to have proton beam therapy in proper conditions. This is work from one of our research fellows studying how we could go higher up with the anterolateral approach using the corridor between jugular foramen and hypoglossal canal putting the endoscope inside. And this is the cement, and then after the fixation. So I'm done now. Thank you very much for the invitation. Thank you for those beautiful presentations. I learned a lot. I was following it silently, but I had a very nice time listening to you guys.
Thanks, Sebastian. That was very impressive. Really, really excellent. I do have a couple of questions, if I may. I don't know, we don't have much time, but I do have two questions. One is, when Sebastian, when you do your far lateral, not extreme, but the far lateral, do you use, I saw you put the patient on prone position, not lateral, or 3/4?
It depends. To tell you the truth, it depends. I prefer the 3/4 because but it depends of the target. And I position according to the position I will have, in fact. This depends on the location of the tumor.
I see. Now,
most often it's the 3/4.
Okay. Using the cement, you haven't seen any complications with that in terms of infection or rejection or things like that?
With the cement?
Yeah. Not
yet.
Complications with that?
Not yet. I cross finger, but not yet.
Okay. That's a good idea. I like it. Do you guys have any other comments?
The issue with cement is that it's absolutely not stable long term because it's cement. So there is no, it doesn't create bone, it's just cement. So you need a good fixation after with fusion. It's only transient. In few patients, I was able not to fix, but it was only, you know, because a little bit of bone was missing, not the full condyle.
Okay. Excellent.
I had one question. Going back to the point regarding resecting the dura. So, you know, you mentioned the point about sort of leak, particularly doing cases endonasally. And when you're resecting these chordomas by the jugular tubercle, as you're working deeper, going more inferior and lateral, and the tumor hasn't clearly gone through the meningeal dura, and you're doing it endoscopically. I mean, for the rest of the panel as well, you know, when you're resecting that bit of dura just under the bulbar nerves, are there any special tricks? Or, I mean, because it induces a certain amount of anxiety about leak and the repair. Versus, I presume, when you're doing that transcranially, you're a bit more confident about taking that bit of dura on the jugular shelf coming from below, from behind rather. So just wanted to get some thoughts on that. Because I had a very similar patient recently.
Dura is what we call in French pastry a millefeuille. So it's a multi-layer of you know, of connective tissue. So what we do with those patients is that we peel the dura with a ronger. You know, you peel, you tract on it. It's like when you do a chiari malformation and you don't completely open the dura, you just take some layers of dura for the dura to expand. And this is what we try to do. We peel to take part of the dura, layers of the dura, and then coagulation away from the nerve to try to control. But is it worth taking it out widely with a significant risk of leak? I know that, Paul, you are, I believe, a strong advocate of it. Me, I am a little bit afraid of doing it, but I don't have your experience with endoscopic endonasal in chordoma also.
I think you have to look at the tumor individually. I think most of them are interdural between those two layers of dura.
That's right.
They always involve the periosteal layer, but sometimes you peel that periosteal layer and you see there's really very little interdural tumor, or the meningeal layer is completely uninvolved. In those cases, I wouldn't remove it, but if there's any tumor even remotely adherent to that meningeal layer, I believe it needs to be removed, just as anything that you resect. And I think, or that's involved. And I think one of the important things about your concept of anterolateral is the extensive bony resection. And I think regardless of which approach you take, that extensive resection of both bone and dura, if necessary, is key for most chordomas.
It's a good point what you are raising. I think now we have the imaging studies sequences in MRI with which we can really study how infiltrated is the dura. With cis sequences or fiesta sequences, you can see if there is some interdural infiltration, or if it's going low between dura and bone. And in those cases, yes, resection of the dura, I agree, is necessary. But we can study this very carefully before the surgery now.
Sebastian, first of all, I was not laughing at your French accent. I enjoy hearing your French accent. Actually, I was laughing at my puppy. She was doing something very funny. But in any event, I liked your principle about your choice of approach based on the timing of when you need to perform radiation therapy. I think that's an important concept because the endonasal, you have to take into time how long that will heal, or if it doesn't heal, having to take the patient back. And I, in fact, had a patient with a recurrent cystic craniopharyngioma, an 80-year-old female, that I chose an eyebrow instead of endonasal for that reason of anticipating earlier radiation therapy.
Yeah, I think it's important to consider there is a waiting list for proton beam therapy centers usually. So it's not something that, at least in Paris, we can do rapidly after the surgery. But we usually do it between 6 weeks to 8 weeks after the surgery. This is the timing of proton beam. But if the patient needs additional surgery for fixation, I mean, it takes longer. And yes, endoscopic endonasal may heal for a longer time. So yes, this has to be considered. At least the fact to have a single surgery or 2 surgery, I think is something significant for the patient. If you can avoid a second surgery for fixation, you reduce the risk of the complete scenario.
Excellent. Well, I think that was a great discussion. Thank you, guys. We have to finish our session, which we're already late. We have Varun and Georgios who they're gonna share with us a couple cases, one each, I believe. Varun, you gonna go first?
Yes, thank you. Here, let me share my screen and I will go quickly here.
So as we mentioned at the beginning, I like to invite not just very experienced students like Sebastian and many others, but also like Varun and Georgios who are starting or have been doing this for just a few years, to see what they've learned from people like us, what they're doing better, if they're learning from our mistakes. So please, Varun, go ahead.
Wonderful. You can see my slides?
Yep.
Okay, yeah, so I have a case that I hope will spur some discussion among our more recent panelists. I just wanted to acknowledge Professor Rhoton. When I was actually an intern at CNS, I was at one of the 3D talks, actually waited till they gave out, everyone showed their tickets, went 10 minutes late because I didn't want to pay for the course and went to the talk. And that was what spurred my initial interest in skull base, and reading obviously his red book here spurred a lot of my later anatomical work. So the case I wanted to present is a 57-year-old man. He had headaches, especially post-tussive, mild swallowing difficulties, mild imbalance. Some relevant history: he had cervical stenosis and a remote ACDF. In fact, when we look back on his MRI C-spine report from 22 years ago, they did actually comment about a meningioma arising from the clivus, but he never reported that he actually heard about that. He was on an Ohio diet all his life, and he's 401 pounds, BMI of 49, 6'4", so very big guy, and also a sleep apnea on CPAP. And so here is his MRI. I'm going to show a couple different sequences and then get some feedback from our group here. Here's the T2. And I'll show some specific relevant slices here. So this is a sagittal view. Here's the contrasted part showing the extent from top to bottom, just coming up to about C1 there, below the sella. Here is the relationship with the jugular bulb and also the relationship with the condyle. Here's, I picked some slices looking at the different nerves. So from fifth nerve, 7 and 8 complex, lower cranial nerves. And in fact, the hypoglossal nerve, he actually had some tongue weakness, but I couldn't find that on this T2 or on KISS imaging. And so I wasn't sure if it was presumably pushed lateral or happened to be encased, but the hypoglossal canal you can see right there. This is his CT sinus, just looking at his pneumatization pattern. And then just some axial slices, a little bit just to highlight that his eustachian tubes and kind of what the space is in between there. So I want to open that. How about we start with Professor Froelich, thoughts on this case and how you would approach this?
It's well, it's a petroclival meningioma, but with a big part on the lower clivus. So it's not exactly petroclival, but it's a tough one. I would definitely not use endoscopic endonasal for several reasons. First, it's going a little bit laterally. Secondly, there is edema of the brainstem, not so much, but there is slight edema. It's not a pure clival. It's not a pure clival meningioma. And because of BMI and also obstructive apnea, on the very high risk, I think, of CSF leak. So me, for petroclival, I am a strong advocate of the combined petrosal. I like it. It's very nice because of the multiple angles of view you have to look at all the cranial nerve involved. Posterior petrosal is nice for this. Do you need an anterior petrosal? Not necessarily to reach the tumor base, but anterior petrosal give you also this line of sight, additional line of sight to look at other area of the tumor. So you don't need it to devascularize the tumor, but it's not much to add anterior petrosectomy to a posterior petrosal approach. It's like taking out a clinoid process when you do an FTOZ. So I think I would do a combined petrosal in a case like this. Other option is to do a far lateral transcondylar going up, but you have the lower cranial nerve between you and the tumor, and you need to go very high. And it's very nice for foramen magnum, but the tumor is going, I think, too high to just rely on a posterior petrosal approach. I love it for foramen magnum, but for those mid-lower clivus, you will have difficulties coming from below. I think the vertebral artery is not an issue, but it's a little bit too high for just far lateral transcondylar. So combine is nice. Retrosig only, it's too big for me. The goal is to keep the cranial nerve intact as much as possible, and the corridor you have with combine give you, I think, a better cranial nerve outcome. And the literature goes a little bit in this direction for large or giant tumor. I'm not talking about mid-sized tumor for which retrosig is very nice.
Excellent. Thank you for that discussion. And one of our other panelists, Sean Raza, I don't know if he's still on, if you would comment, any thoughts?
One just last things I would say is that, sorry, I would do an angio. I always do an angio before. On here, controlling the ascending pharyngeal, I think, do a lot of a job, because most of the feeders come from the ascending pharyngeal. It's not so difficult for the endovascular to control, not with particle, but very low morbidity, and it can be extremely helpful in a case like this. I always do angio to understand the feeders.
I would say you have more brave angiographers than we, because most of them won't want to go anywhere near the ascending pharyngeal for embolization.
Depends of what you use as a coiling agent. But I never had a complications in the last 10 years with those.
All right, and Sean?
Yeah, I agree with everything Sebastian said. I think in terms of open versus endoscopic, we have a lot of people in the Texas diet here with really high BMI. And I don't think doing this endoscopically would provide tremendous advantage over an open approach. And given the elevated BMI, sort of that risk. In terms of strategy of open approach, given the brainstem edema, I would worry about doing this purely retrosig because of dissecting that tumor brainstem interface. And I would favor a combined petrosal approach also.
And for the lower aspect, you would, how would you attack that, the foramen magnum part?
Yeah, so I think certainly you can extend your exposure down inferiorly, like a retrosigmoid exposure going down to the foramen magnum. And that would provide that lower pole access, and you could pick up the vertebral artery earlier on and identify that arachnoid plane too early.
Okay.
I definitely would start, in addition to devascularizing the tumor of the skull base, my dissection, I would start initially inferiorly so that you identify the arterial structure early, and that really expedites the operation then.
Mm-hmm. So yeah, just to keep moving, I went back and forth multiple times. I think if I just had these lower two slices, I would have gone far lateral. My main concern was this part that's really where you see kind of the pons and MCP knuckling around the tumor and trying to work past 7 and 8. He had intact hearing, was one potential advantage I felt of maybe coming endonasal, but then the main downside, as you guys point out, is around the hypoglossal, that this goes out a little bit too far lateral. Now, I think putting someone who's 400 pounds in far lateral position or, lateral is not without potential risk as well. So to keep moving, I ended up doing endonasal approach. I think one, in the interest of time, I'm actually gonna skip the video here. Mm-hmm. But I did want to just highlight one little complication that, of course, you guys talk about with the leak. But essentially what we did is we did a U flap here. We opened up the sphenoid. We did a right transpterygoid approach to detach this eustachian tube here and be able to go and do a kind of far medial approach. And you can just kind of see, I actually did this on a Monday and then Wednesday just to make it a nice 2 comfortable days rather than 1 long day. But we did the full clival exposure, went laterally. And I think we achieved our goals, which was a good decompression. But just as you guys point out, we did well with the pontine aspect. But then even though we tried to stimulate and find the hypoglossal, I never actually visualized it, but we were getting free running EMG irritation, and I ended up leaving some, and particularly where Sebastian, you mentioned there was edema at the brainstem. I couldn't fully access that. But on the flip side, he had no neurological deficits. His swallowing improved, his gait improved, and from a neurological perspective, he did great. I just wanted to highlight one little thing, is that this is always the challenge when we have, so we did a left-sided flap, and this is the flap coming in here, and that combines with the U-shaped flap, which we kind of see retracted down. And this is where this area of leak occurred. And we tried to kind of, getting that junction to heal is challenging. We tried to kind of swing the U-flap one way and the nasoseptal flap the other way, but ended up leaking here. And in the end, we took him back once and applied a pressure or whatnot, and didn't work. And then we ended up having to suture the flap to the eustachian tube. And that was what finally got that area to seal off and heal. So that was one little complication tidbit there. But all right, in the interest of time, I'll turn it over to George here.
George, go ahead. We can comment after your case. Certainly doing pituitary meningiomas endonasally is a challenge and it's controversial, and you need to deal with risks like CSF leak as we just saw. I think the debate is still there. I think the concept sometimes of a stage surgery where you do part of it with an endonasal approach and the other part with a simpler retrosigmoid approach is also another option. So let's move on, George. Show us what you got.
All right. Well, again, I want to thank you as well.
so much for inviting me. It's so humbling to be with the all-star crew here. And just one small word that although I never trained directly under Dr. Rhoton, I feel that I trained under you, and you are the best conduit, I think, to everything that he had to offer. So thank you very much again for everything. Very similar, kind of on the same tone with Varun's presentation. And this is a case that first of all, can you see everything okay?
Yes.
Okay, excellent. This is a patient which, at least in my opinion, didn't have like none of the options were perfect. But this is a patient that I had met after operation that she had. She was a 37-year-old. She originally presented with a 6-nerve palsy and had a lateral approach, more like a Arterional approach at another institution. It sounded from the op reports the tumor was very bloody and very fibrous, and she had a left MCA stroke or an inferior M2 division stroke, and she had a little bit of a complicated hospitalization there. And for this reason, they were very reluctant to do anything else. She was watched for approximately 5 years. It was slowly enlarging. They talked about radiation, but she was refusing radiation. She started developing long track signs, trigeminal neuropathy, vision loss. Her left cranial nerve 6 palsy became complete, and she had intact hearing. This is some additional imaging here. Of note, she had a left more than right optic neuropathy and bitemporal hemianopsia, and she did have some pituitary dysfunction as well. These are some of the key images. Of note, her left carotid artery was significantly constricted, and she did have a persistent trigeminal artery that was supplying the posterior fossa that was also going through the tumor. And you see the significant blush there. And we did a balloon test occlusion as well, which she was found to be moderate risk. So I wanted to turn it to the group real quick. I don't know did you want me to ask people to have some opinions now, or you said you wanted to do it later?
Go ahead. I mean, maybe we can ask James, see what he thinks.
Yeah.
We're gonna go back to the film. Just show us the images.
Difficult case, Georgios. Is the visual loss from optic canal invasion anteriorly, or from the chiasmatic compression, or both?
Both. It was mostly the optic. She already had a clinoidectomy on the left side where the tumor was it seemed to be invading anteriorly, but it was more bitemporal hemianopsia, more like a chiasma compression. She was evaluated by our neuro-ophthalmologist here, and it was more the temporal fields.
Yeah. I mean, this is a difficult case. This is a sphenopetroclival meningioma. You can see it's occupying cavernous sinus, sphenoid sinus, and CP angle petroclival region with brainstem compression. She's already had a prior approach done. Generally, for a petroclival meningioma like this with cavernous sinus invasion, I try to resect what's extra cavernous, and I leave the remaining intracavernous component intact, usually later for radiotherapy. I think in this case, I would favor combined Petrosal to come for the upper CP angle portion. I prefer that approach. It just, you don't get brainstem compression, and you have excellent access to that region. But I think you also need to consider coming in endonasal as well, and that would help you get the sphenoid sinus component in the nasal cavity and then decompress the optic chiasm anteriorly. Hopefully you don't need to unroof the optic canal because that was already done from the prior Arterional approach, but I would consider a two-staged approach for this one.
I don't know, Pablo wanted to comment on this as well. I don't know if he's still around.
Maybe Dan. Dan, do you have a comment about this case?
you know, to me, this is a case that's kind of letting you know it's you obviously can't take the whole thing out. She needs a generous decompression, and she's going to need radiotherapy. We would do this through the nose. We would do a clivectomy, decompress the sella, decompress the left optic canal, take as much out as we can. It's probably very fibrous. Try to decompress her chiasm, and then, you know, give her three to 6 months, and then do radiation, do SRT. You know, because it's very much kind of in the midline. I'm not sure you'd accomplish much with the lateral approach. You know, there's a huge amount in the cavernous sinus that you're just not going to be able to do much with. But if you decompress, you know, the whole cavernous sinus and down to Meckel's cave, and then do a left optic canal decompression and decompress the sella, that would probably be sufficient.
Excellent. George, show us what you did.
Yeah, so obviously I thought long and hard about both of this. Having Paul around obviously tends to tip the scale many times in what I decide to do. But because of the optic nerve compression, mainly it was, again, a bitemporal hemianopsia picture. It did look like the, as Dr. Kelly was saying, that most of the tumor, actually what we saw as the lateral border of the tumor was the lateral, essentially cavernous sinus. There was not much there to be resected, and most of her issues were because of brainstem compression. So we ended up doing an endonasal approach and decompressed the brainstem and her optic nerves, at least on a sagittal plane here, and you can see here the optic nerves. There was still a significant amount left. I didn't want to go in the cavernous sinus close to the carotid artery because of her balloon test occlusion that was moderate. I did not want to be close to that, or very close to that persistent trigeminal artery that was supplying the superior part of the posterior circulation. But thankfully, she didn't leak. I was really worried that she would. I had placed an EVD and kept it for 72 hours. Much of her symptoms improved. Her sixth palsy never improved, or her trigeminal neuropathy for that matter. So
I think that's a great result, a beautiful resection, yours. I think the sixth pulse is a problem in these cases. You know, is probably regardless of the approach, but Endonasal even higher probably risk because it's in your way very often.
A great result. Nicely done.
Yeah. Well, it's good. I mean, we are only 45 minutes late, which is not that bad considering we are skull visions wanting to show our videos. So
basically on time.
What is that?
That's basically on time.
There you go. There you go. So I really want to thank you all guys for joining us. I think it's been fun. We've learned a lot. I've learned a lot. And for the rest of you, the attendees especially, we have the next session starting in 15 minutes. This is the session we're going to make in honor of Evandro Oliveira, where many of his mentees are going to be speaking. And actually, I highlighted they're going to be showing some of his best operative videos commented by Dr. Wen and Dr. Neto, his associate. So join us in 15 minutes. I'm going to grab a quick bite, and I'll see you back. Thanks, guys.
Thank you.
Thank you. Thank you. Great job.
Everyone, take care.
Bye-bye, all of you.
Bye-bye. Au revoir.
Bye.
Thank you, Juan.
Wow.
Thanks, Juan.
Thanks, Scott.
Go sleep now, man.
Dr.
I'm here, Ruth.
Will you put up the slides?
Yeah, I'm going to put the slides. I know we're still live, right?
Yes.
So let me see. You're seeing them, are you?
Yes, perfect.
And now how do I play music, we said?
Do you have music set to it already?
No, but I can play music in my computer, I think.
Yeah, so you can turn on the audio on your computer with the music that you want. And then, but I actually think that if the current slide deck doesn't have the audio, you can only either share music or share pictures. Those are your options.
Oh, okay, then we'll share the pictures.
Okay, perfect, thank you.
Okay, I'll leave it there, and I'm
Great.
gonna go and grab a snack. You guys good without me, right?
Yes, perfect. Thank
All
you.
right.
Puta, como é que escreve wall aqui? Você viu esse teclado?
Oh, that's when. I mean,
Oh.
Oh, Mateus.
Hey.
Mateus.
How, Professor? Everything okay? I'm at Wayne here, huh?
Hello.
There you are. How are you guys?
Yeah.
You
We are in Professor Oliveira house. Yeah?
Oh, really?
Yeah, yeah.
Eu preciso conectar a internet.
Wonderful.
We are preparing some videos in his computer.
Mas por que o teclado dele tá...
Hello.
Hello.
Hello. I'm Antonio.
Hi, Dr.
I would like to know if we have to do a test to see if we can share the screen.
Yes, we can do that. So the screen, if you want to go ahead and try and share your slides right now.
Okay. Share screen. Is it okay?
Yes, we can see it. Do you want to try advancing? Perfect.
Perfect. Okay. And what about if I want to point something? Can you see the?
Yes, I can see your cursor.
Okay, perfect. Okay, thank you.
Thank you.
Hello, everyone. Can I try mine? My
Absolutely.
audio and slides?
Absolutely.
Thank you.
We can hear you just fine, so that's great.
Okay. I will share screen.
Perfect. Do you want to try advancing? Great.
Okay. Thank you so much.
Thank you.
Hi there. Are you listening to me?
Hi, Dr. Yes, we can hear you.
Okay, great. Thank you.
Thank you.
Hey, Capel, how are you? This one.
Hi, how are you?
Good to see you.
Good to see you too.
I see we have Pablo also. And of course, Carolina. Do we have Mateo and when?
Hello, Juan. How are you?
Hola, Pablo.
¿Cómo estás?
Todo bien.
We have Dr. Neto. Is that who you're referring to?
Yes.
Yes, he is there, I believe.
Oh, there they are. When and Mateo, can we talk?
Hello.
Mateo, good to see you.
Yeah, good to see you too. We have some problems with the connection here. The computer of Professor Oliveira, but it's already, we are preparing it now. It's okay.
So just for awareness, the attendees do hear you and can see you right now.
That's okay.
You have to put Dr. Wayne in the chat too.
No, I need link for the panelists.
The link for the panelists to Professor Wayne is not entering.
Okay. We will resend that to you shortly.
Okay. So talk to email. Wayne is with his email, but they cannot enter in the panelist.
I'm using the vendor's computer, that's why.
But we're seeing you. I don't know what problem you have because we can see you. You cannot.
No, not me, Wayne, because Wayne is with Professor Oliveira computer, just my side here.
I see.
But you see?
I see. Okay. Okay.
I'm using a vendor's computer.
Okay.
But and at the Zoom as attendee, not that panelist. So that's why video is not showing.
We have just promoted
okay.
Dr.
I got it.
Yeah. I think you got it now.
So when do you want me to start? How long you want me to speak is importantly. How long do you want to speak? Because I don't want to take any time from you guys at all.
No.
5 minutes. I can do 20 minutes. You tell me.
20 minutes. 20 minutes.
Okay, we'll do
20 minutes and then we start. Thank you.
Can you guys hear me?
Yes.
Can you guys hear me?
Yeah.
Hear you.
Yeah. Okay. All right.
Now it's done. I'll continue.
Well, welcome again to our next session of the meeting. This is our third session, and this is a very special one because this is a session dedicated. Please, Mateo, mute yourself, and so we can continue. This is a session dedicated to Professor Evandro de Oliveira on mastery, legacy, and philosophy. I believe Dr. Mateus Neto and Dr. Wen are at his home address. So this makes this event, very special because Evandro is very special for all of us. So they've asked me to do an introduction first, and that's what I'm going to do for the next few minutes. I titled my lecture about Evandro, The Supreme Art of Microneurosurgery, because that is what he represents. He represents the supreme art of microneurosurgery, and he's a master, a mentor, and a hero for many and for all of us, and for several generations of neurosurgeons in Brazil, in South America, in Europe, in America, everywhere in the world. He has a deep influence in all of us. Evandro has a unique mix of the microsurgical technique from Professor Jassenhill and the microsurgical neuroanatomy of Professor Rhoton, and he merges both as nobody has done before. And actually, he did fellowship with both of them, and I think that is the ground that made him the surgeon he is. For those of you that don't know about him, when he was 37 years old is when he started going to Professor Rhoton's lab. I know he had tried to be in his lab for a few years preparing, and it was the dream of his career, and he accomplished that. But it was very difficult for him to get there. A lot of insistency and resilience. And you may know that a few days before he was going to join Dr. Rhoton in his lab in Gainesville, he got a letter from him saying that they didn't have a spot for him any longer. I don't know if funding was run out or what happened, but didn't have a spot for him. And Evandro actually, I know he told me confidentially, he actually broke that letter and didn't pay attention to it and just continued as planned and went to Gainesville to work with Professor Rhoton. So that was a unique time, I believe, in the history of Rhoton's lab, a unique time because three fellows came together, Matusima, Timur Kayak, and Evandro. And that was a very important era for Dr. Rhoton's lab, where it was going to another level. You know, don't forget that Evandro went there when he was already experienced neurosurgeon, 37 years old. He had done hundreds of operations already. So he went there, I think, knowing very well what he wanted to accomplish, becoming a better surgeon, knowing the anatomy to perform complex operations. And he did so going back to Sao Paulo to create what I believe is one of the most important cerebrovascular practices ever in the history of neurosurgery, with this amazing ABM series, bypass and aneurysms, and also skull-based tumors and brain tumors. And not only his practice, but his legacy in training the next generation of neurosurgeons. That's the lab where he trained hundreds and hundreds of neurosurgeons from all over the world, and he made it so easy for them to go there and visit. I believe Rhoton represents in the school of Evandro represents in the school of Rhoton the example we all want to follow. We all wanted to follow his example of becoming such a skillful neurosurgeon and so talented. As you know, Professor Rhoton used to say that he was always trying to search or create the new Michelangelos of neurosurgery. And I would say more than that, we were all looking to be the new Evandro in neurosurgery. Because Evandro, like Michelangelo, in my perspective, is the greatest artist of his time. Art is defined as the expression or application of human creativity, typically in a visual form, like painting or sculpture or surgery, producing works that can be appreciated primarily because of their beauty or their emotional power. And when I saw for the first time Evandro's operations, I was shocked by the beauty of those operations, the emotional power that it transmitted, the perfection of those operations, just like Professor Rhoton always taught us. And not only that, I think Evandro was also a genius approaching surgery. He is a genius like Salvador Dali, because he has to face tremendous challenges that are bizarre, like these ABMs that he approached like nobody else. And he's also like an amazing chef. And I love when he says microsurgery is like cooking. It's like a recipe. You have to go step by step following it so you can get the best result. For example, like a case like this of his, that you go step by step to actually get into this cavernoma in the brainstem. And something that is so important about Evandro is his courage and his determination. Like the explorers 5 centuries ago that crossed the ocean to come to America, for example, his courage, his determination to face the most challenging cases that nobody else would touch, or that other people would think you are crazy dealing with, like this cavernoma that I believe is probably the best ever done in the cerebral peduncle of the brainstem, more about 20 years ago, with an excellent outcome. So this courage and determination is something that we all learn from Professor Evandro. Evandro elevators were microneurosurgery and art merge inseparably. I came to meet Professor de Oliveira when I was just a very young resident. I was just in my intern year, and he was honored guest to the Spanish Congress of Neurosurgery. And I was so deeply impacted by his mastery, the way he was doing surgery, but also the way he exemplified the use of working in the lab to then translate to the OR and perform perfect operations. From him, I learned that Professor Rhoton, along with him, thought that the anatomy is the most important knowledge we need to have as neurosurgeons. Like Professor Jassagers also, they believed in the need to spend at least 1 year or more, if possible, in the laboratory to train in anatomy and in microdissection techniques. And that message for me, as for many of you, was so impactful. I went, during my residency to the lab as often as I could to do dissections with whichever specimens I could get, all heads, all brains, cerebellums, anything with an all microscope. And I would get Rhoton's book, page 1, and I start reading and doing dissections and trying to learn anatomy that I could not learn in any different way. And I was, really fascinated by Evandro's work. And I learned that he was coming to Alicante, a nice, city in the coast of Spain, Mediterranean coast, and he was coming to do a meeting, a hands-on course. I thought to myself, I need to be there. I need to be close to Evandro. And he would say that anytime he came to Spain, I was going after him, and he's right. Just because I wanted to be next to him, I wanted to get some of that amazing energy that he had, see if I could learn something from that. And I did learn so many things. So I went to this lab, and I went to the lab, and I didn't have the resources to pay for a hands-on course at that time. So I asked this Professor Juret, who was organizing the course. I told him, look, I can go there and I can do anything. I can clean the lab. I can, do anything to prepare for the course. And he was very kind, and he told, you just come here, help me, mounting the stages and do this and that, and you'll be part of the course. So I was part of the course, and I got very close to Evandro doing that course. And he was there when I was talking with him and asking him about his work with Professor Rhoton and how to prepare the specimens and how to get, if I could visit Rhoton's lab. And he asked me if I wanted to go with Rhoton for a year. That was something completely unexpected to me. The truth is, I wanted to go with Evandro to Sao Paulo and learn from him, watch him operating, go to his lab. But he said, no, you have to go with Rhoton. And that changed my life. That generosity, that him believing in me and my ability to go to Rhoton's lab and work with him like he did 20 years before, that, changed my life and means so much to me for all my life. That same night that he offered me that opportunity, we actually had dinner together in this beautiful hotel in the coast with nice views of the Mediterranean, and enjoying what I think is Evandro's favorite food, which is Iberico ham. And we had such a good time and memory. But it wasn't easy for Evandro to actually bring me to Rhoton's lab. The same as it happened with him, that Rhoton sent him a letter saying, no, I have no spot. When Evandro told Professor Rhoton, hey, I have a fellow for you, I want you to get this fellow, he told him again, I have no spots in the lab. And Evandro had to really insist on accepting me, and he finally got it, because Evandro is like that. He insists and he gets what he wants, and he did get me into Rhoton's lab. I know about this because Professor Ture was in the conversation that happened when all this happened. So Professor Evandro never told me that it was this difficult, but it was, and here we are. So to me, going with Rhoton, it was following the example of previous fellows that are here with us today, like Dr. Wen and Dr. Rubino. Dr. Wen, an amazing academic example for his impressive work with Professor Rhoton, papers that I always followed. And Dr. Rubino, Pablo, also the personal example on the sacrifice that you are required to do if you want to accomplish what your dreams and what you are looking for. I know Pablo, to go with Rhoton, had to, basically make a huge effort financially to make it possible. Because when you go to work in Rhoton's lab, you were not paid. So we were going to 1 or 2 years there, and you had no salaries. You had to have your own savings. So what I did is I had a small apartment, a small flat in Madrid, in a nice area. I was lucky, and then I have a small car, so I sold everything I had just to go 1 year with Professor Rhoton. At that time, all my colleagues in Spain, or most of them, were saying, "You're crazy, you're making a mistake, you're leaving everything without knowing what's going to happen." And I was just going for a year. And it was a phenomenal year. I went there to follow Evandro's example, and I went there for a year, but I wanted to stay a second year. And I spent, like most of the fellows, 2 years just doing dissections for the most part, dissections that we wanted to be as perfect as possible. And we spent some time writing papers, but most of the time was doing dissection, full time in the lab. But that paid off, and paid off greatly. And it still pays off. Things that I did in the lab, I know many of the fellows feel the same way. I did them 15 years ago. I'm still able to apply that knowledge in the surgeries I do, even if it's a rare case that I don't do very often. I still have that anatomy in me. And that opportunity that Evandro gave me, that Professor Rhoton gave me to train with them, to learn from them, has tremendously impacted my whole life and my whole career, and that of many of my patients. From Evandro also comes my love for the temporal lobe region. I know Evandro is a phenomenal surgeon in the temporal lobe area, and he loves this anatomy, perhaps because of its complexity. So we did this paper together on the microvascular anatomy of the medial temporal lobe. And we are now often talking about minimally invasive brain surgery, but when you see Evandro surgery, minimally invasive means minimally invasive to the brain. For example, you can have a case like this in the uncus, medial temporal lobe, and some people advocate going through the temporal lobe to get to the brain, and maybe you do to the tumor, and maybe you do a small opening in the skull, but that's not minimally invasive. You are disrupting the brain. That is maximally invasive, in my opinion. However, doing it this way, trying to do like Evandro would do it, is a bigger opening, bigger craniotomy, but that really is not important. What is important is how you carefully do microdissection, and you don't have to cross any of the brain to go into the tumor. And that is really minimally invasive. It's about preserving the brain, not the size of the incision, not the size of the bone opening. Is actually the brain, the vessels, the nerves, all those areas. So here we are applying, careful technique, just trying to imitate what Evandro would do in a case like this. And I'm just going to move it all the way to the end. But medial temporal lobe surgery is a beautiful area to do operations where anatomy becomes extremely important. And you can do an operation like this where you're selectively taking the tumor without disrupting surrounding normal brain. Innovations come also from the lab, and Evandro, as an expert of the cavernous sinus, I was always really impressed by his ability to visualize the cavernous sinus, how he always taught us the cavernous sinus is like this room. It has a roof, it has a medial wall, it has a lateral wall, it has a floor. And that concept of visually being able to be inside the cavernous sinus also deeply impacted me and influenced me on better understanding the anatomy of the cavernous sinus and studying it now from the endonasal perspective. And just like Evandro described, in the 90s, the pretemporal transcavernous approach, going to the posterior clinoid dorsum sella to get to the vascular artery, lower vascular artery. We applied same principles to describe the same approach from an endonasal perspective. Go transcavernous into the posterior clinoid to then go behind and get into the interpeduncular system and upper basilar. Approaches that can really help patients like this one that has tumor left, this kid in the upper clivus. And, you know, taking the posterior clivus is always a difficult thing to do, but we learn how to do this through the cavernous sinus. And we can open the cavernous sinus and directly get access into the posterior clinoid and remove it completely, as you see there. And then you can also go into the brainstem from the front. Evandro has a tremendous experience removing brainstem compartments. And this endonasal approach gives you an extra corridor to get to tumors that are in the front aspect of the brainstem that would be difficult to come from lateral approaches. I would also say that Evandro has been extremely supportive for all these years of, for example, my progression into endoscopic endonasal surgery. Different to other surgeons that are critic with some of these approaches, Evandro was always extremely supportive and always encouraging to keep, you know, pushing the field and taking it to another level. Something for which I'm also very, very thankful to him for his encouragement. Just to finish, also this last case, of course, Evandro is one of the most experienced vascular surgeons ever. I had this lesion recently. It's not an aneurysm, but it looks like a basilar aneurysm, but it's not. So this young patient presented with amenorrhea and significant visual decline, and then also some personality changes because of edema in the hypothalamus. Again, going back to the lab and understanding the anatomy, the vascular anatomy in this area, and you look at the vascular study, this is a very vascular lesion, and I suspected this was a hemangioblastoma, vascularized by the superior hypophyseal artery branches, as you can see here. This is a very difficult case that I did through an endonasal approach. And as I told the patient, that the pituitary gland function will be very likely to be preserved. It was partially impaired already, but I think it will be very difficult to preserve it. So here you can see this hemangioblastoma that is being vascularized by these very large superior hypophyseal artery branches. I tried, but it was impossible to preserve. So at the end, I decided I'm going to cut the stalk and I'm going to remove actually the pituitary gland so I get extra space. So sometimes you need to make these decisions and be courageous about the exposure you need for this case. So I could then drill the posterior clivus, dorsum sella, posterior clinoids, and then get access to the lower aspect of the tumor. Again, this is a hemangioblastoma, and you can see the basilar artery behind the basilar bifurcation and the third nerves. But because of the strategy we took, we were able to surround it, get the vascular supply directly. And after we took the vascular supply, then the tumor will become much easier. We are using ICG to identify the vascularization of the tumor. And now once the tumor is devascularized, we can end up with a complete tumor resection. This is the ICG after the operation. And you can see the hypothalamus all nicely decompressed. So I want to conclude saying that Evandro, you are not only my master, my mentor, my hero, the hero of many. We love you. We hope you are with us. Thank you very much. I believe at this point, Dr. Wen and Dr. Mateo are going to be sharing with us some of Professor de Oliveira cases that, as you will see, are true masterpieces.
Let me remove my mask just for a second. Hello, everyone. Good afternoon here in South America. Good morning in Asia. And it's an honor for us, all of us here today, to honor our master, Dr. Evandro de Oliveira, for some reason, our fate, we were lucky to cross with Evandro along our life, our fate, and he somehow influenced the lives of all of us. Juan Carlos, myself, Musi, Mateus, Vicente. So what when I would like to thank Juan Carlos and also the board members of the Rhoton Society for allowing us to do this special session for Dr. Evandro. And how we did it. And I visited Evandro, and then we sat down and I asked him, and how do you like to, to this session to be? And he suggested me, maybe we can pick some ex-fellows, ex-residents, but we have to distribute, share along many countries, because he had students all over, Europe, South America, Central America, and United States. So, but there were so many, so we cannot fit everybody. It's only limited time. So he did selection. So we have Jorge Mura from Chile today with us, and we have Vicente Quilis from Spain, from Valencia, with us today. We have Juan Carlos from Madrid, Spain. We have Carolina. Brazil is a big country, so it's like a continent. So we have to divide. Somebody from São Paulo, we chose Alberto Capel, okay? And somebody from the Northeast, we chose Carolina Martins. She's the secretary of Rhoton Society. And we also chose Antonio Musi from his hometown, Florianopolis. It's in the southern part of Brazil. And representing Argentina, we have Pablo Rubino. So we're gathering today to honor Evandro. So what we like to do is to introduce Mateus. He's gonna be presenting the first video. Actually, why? Because I said, I asked Jorge to present his cases, Pablo, and I said, well, why can't Evandro present his cases? His videos are amazing. So at least 1 hour for him. His right now he cannot speak very well. So I'm gonna narrate the videos. But the first video, who's gonna narrate is Mateus. His specialty is the anterior petrosectomy. So can you get started? The last thing, we are broadcasting live from Dr. Evandro's apartment. That's why I'm wearing masks, this kind of things. So be careful, boss is listening. He's actually listening to all of us. Be careful.
Thank you, Professor Juan. Thank you, Professor Wayne. It's an honor for all of us to be here. Special session from using our words, Juan, our master, our mentor, and our hero, Professor de Oliveira. I will show a case that he performed. Let me share my screen. Okay, this case is a pontine cavernoma performed by Professor de Oliveira in 2015. Is a GVMA, 12-year-old, a male, Brazilian, right-handed, that arrived in Professor Oliveira's office with 1 month of dizziness, diplopia, paresthesias on the left side, gait disturbance, and falls. Have no previous medical history, and on the physical examination have a mild 6 nerve paralysis and a mild left side paresthesia. On the MRI, we can see this cavernous malformation that bleeds and the protuberance region on the left side. This lesion touched the surface around the peritrigeminal safe entry zone, and professor decided to enter it in an anterolateral view with an approach that we call extended pretemporal approach. That is a pretemporal craniotomy described by him with a peeling of the middle fossa and anterior petrosectomy. And you have a straight view from the lesion, as we will see. The way he teach for all of us from the lab to the OR. This is my dissection Rhoton lab. The way we perform the incision to a pretemporal craniotomy, starting anterior to the tragus and running to the contralateral hemipupillar line. Again, from the lab to the OR. The same way we train, the same way we apply in the OR. We always take care of the head of the patient. And after doing the incision, we perform an interfacial dissection. And then a pretemporal craniotomy, as described by Professor de Oliveira. A pretemporal craniotomy, as described by him, is a extended of a Arterional approach that will release all the temporal pole, letting us to have the Arterional, the temporal polar, and the subtemporal view and corridors to work. Same from the lab to the OR. Same as we train in the lab, we apply in the OR. After the pretemporal craniotomy, we perform a peeling of the middle fossa. Professor always like to open the dura over the sylvian fissure to drain the CSF, and then make the peeling of the lateral of the cavernous sinus. Here we can see V1, V2, V3, the Petrous apex, GSPN, and the middle meningeal artery. After this step, we perform an anterior petrosectomy. Here we can see the limits. We study in the lab, we don't need to use it in the surgery. We need to drill as far as we need. But here you can see the limits, the inferior limits, the inferior petrosal sinus, the lateral limit, the Petrous carotid under the GSPN. Here you can see the dura covering the internal auditory meatus. And here the dura of the posterior fossa. After making it, we start to open the dura. You see, we open the dura. We continue from the sylvian fissure, go under the temporal lobe. Then we have to see the fourth nerve to open the tentorium, and then open the dura of the posterior fossa, letting us this beautiful straight view from the protuberance region around the apparent roof of the fifth nerve, the peritrigeminal safe entry zone. We see this approach is really beautiful because, as Professor Juan said in the words of Professor Oliveira, we have a beautiful approach, not minimal in the skin or in the bone, but minimal to the brain. We just retract the temporal lobe, drill the bone, and open the dura, and have this beautiful view of the protuberance region, the fifth nerve. We can see, if you continue our dissection, the Petrous carotid, the Cavernous carotid, the fourth nerve, all the anatomy of this region. But as Professor said, in the surgery, you have to use the approach you need for the patient. As you see in this case, he don't need to see the Petrous carotid or the other structures. He'll drill the Petrous apex as far as we need. Here again, from the lab to the OR. Our dissection in the lab and exactly what you reproduce in the OR. V1, V2, V3, Petrous apex. V1, V2, V3, Petrous apex. After opening the dura, cutting the tentorium and the dura of the posterior fossa, we can see the protuberance region and the fifth nerve. In our case, the protuberance region and the fifth nerve, and here, this lesion touching the surface. Now you see the art of Professor Oliveira performing this case. After the craniotomy, you just open the dura here to drain CSF and start to making the peeling of the middle fossa. You see how gentle his movements. You see in V1, V2, V3. Now he continues to open the dura, running from the Sylvian fissure under the temporal lobe. To open the tentorium, have to find the fourth nerve. Now he's looking for the fourth nerve and cutting now the tentorium. Looking for the fifth nerve. Continue cutting the tentorium. Now you see that he needs a little more space. Then he starts to drill the Petrous apex as much as he needs. Now he drill until the dura of the posterior fossa. He cuts the dura, and as we planned, you can see the lesion touching the surface, and he can deal with the lesion without even touching the brain and the brainstem. You see, he just retracted the temporal lobe, and now he's gently section this lesion and gently taking it out. You see how this approach lets us to see all the cavity of the lesion without retracting nothing of the brainstem. See how beautiful? And the final view of the cavity without any lesion and without any damage to the brainstem. Is the post-operative MRI. The patient had discharged 4 days after the surgery without any deficits. This is our first case. Again, thank you all, especially thank you, Professor Oliveira, to teach all of us here how to use the knowledge, the anatomical knowledge, and again, from the lab to the OR. Thank you, Professor. Thank you so much for to teach us how to make neurosurgery with art. Thank you.
Okay, now I am going to present the next case, and I'll share the screen. Oh, let's go with this one. Okay. Brainstem, troncocerebellar. That's fine. Oh. Okay. Can you hear me?
Yes.
Can you hear me? Okay,
Yeah,
great. So we have this case. Oh, sorry. We have this case. That is we have the AP view. We have vertebrovascular angiography.
Wait, we cannot see your screen yet. Maybe try again. We could not see the.
Not this one.
There you go.
Okay, it's all right. Okay. All right. Actually, I'm just giving you guys a few more seconds to analyze the angiography. What do you think about this AVM? It's rather compact AVM. Do you have any idea where the AVM is located? Obviously, posterior fossa, but more precisely, So over the midline, we can see over the midline, this is AP view, and also on the top, so upper vermis, I would say. Okay, in this kind of AVM, what kind of feeders do we expect? You know, what kind of arteries will be supplying the AVM? For sure, branches of the superior cerebellar artery. Okay, and how about this over here? Small branches from pica, and also we have a cortical branches from. Let me remove this. Cortical branches from pica as well. So basically, superior cerebellar artery, pica, and probably not. I'm not expecting to find ICA feeders from here, and the draining. Venous drainage is towards the straight sinus over here. See, you can see here. All right. So that was before embolization. This is after. They did a great job. Okay, and then we can see much better. You see the branches from superior cerebellar artery, branches, cortical branches from pica, and probably some branches over here. It's close to the fastigium. Okay, so let's see the surgery. So this is a posterior view. We can see this is the hemispheric vein. It's starting from below, and we'll get the branches from the cortical branches from pica first. Why can he start from above? Because it's good to have the AVM, because the venous drainage is over there. And also if you keep the AVM attached, the gravity will not, you don't have to retract superiorly. So he started working from below to get the branches from pica, okay? So we are working on the left side and just checking out the branches going to the AVM, okay? This will stop at do you remember the upper half of the roof of the fourth ventricle? That's where we are. And now he's moving towards the superior part, the tentorial surface of the cerebellum, and then he went back to the superior tentorial surface of the cerebellum, taking out branches of the superior cerebellar artery that go to the AVM. And also you can see the material of the embolization that the materials helps a lot also to localize, for us to locate, to know where we are at the resection of AVM. So it's dissecting around the AVM, and in the end we're gonna see the vein of superior cerebellar, of the cerebellum mesencephalic fissure. We can see here. So he asked me to emphasize the importance of analyzing the angiography, and then from there you can have your strategy, surgical strategy. So once again, this is a vein of the cerebellum mesencephalic fissure. This is this is him removing the AVM. Patient had cerebellar ataxia, for about 6 months, and then got the full recovery. And I'll move on to the next case.
Beautiful.
Yeah. Does anybody want to comment on something about this case? Okay, so let me move on to the second case. Just a sec. Survey VM screen. San Diego. San Diego. San Diego. Okay, San Diego is good. Okay. Shares. Can you see? Not yet? Okay. Stop share. I have to share this one. Yeah. San Diego. Share. Not yet. Stop share. Again, share screen. It's here. I don't know why. It says that your screen sharing is paused.
Why don't you check and see if you're sharing the right screen? It could be that you need to choose a different sharing option, that you might be sharing the window versus your desktop.
Oh, I'll try. Let me see again. Stop share. Share screen. How about this one? Yes. Oh, yes. Oh, all right. Thank you.
No problem.
Well, you know, nowadays, you know, tip of basilar aneurysm, basilar tip aneurysm seems to be very, how do you say? Now everybody's doing, right? That's my impression. Everybody's showing cases, beautiful cases of a basilar tip aneurysm. But this case was done maybe 15 years ago. So he was one of the pioneers, you know, after Dr. Drake, after Professor Yashargil, Professor Sugita, and he was one of pioneers. So we have to keep in mind this video was like a 15 years old. Okay, we have this case, and you can see that the basilar bifurcation is kind of low. Without looking at, I don't have to look at the lateral projection to say that this basilar bifurcation is low. Why? Why? Because you can see this. What artery is this one? This is a PCA, right? PCA has to go up to reach the ambient cistern. Okay, this has to go up. The superior cerebellar artery has to go up to reach the tentorial surface of the cerebellum. So that's why just by looking at an AP angiogram, I can say that's probably this basilar bifurcation is rather low. So, and then we have to check this X-ray, this angiography. I cannot see very well the posterior clinoidal process. I would guess it might be here. So the basilar bifurcation is rather low. So let's see his surgery. This is under this Arterional approach. He's splitting the sylvian fissure. Okay, this is a right side, the frontal, temporal. This is a right orbit. How slow, how steady is his movement. Atraumatic, minimally invasive to the brain. Cutting the arachnoid membrane, releasing, separating the temporal lobe from the frontal lobe, as without cutting the veins. Try to preserve as much as possible. And now he's opening the chiasmatic cistern, the arachnoid over the optic nerve, to free the frontal lobe from the optic nerve. So we'll make it much easier, the retraction of the brain. Now he's working You see the third nerve over there, trying to release that. You can see the posterior clinoid process is over here. This is carotid artery. Now it's open in the dura. That's posterior clinoid process. Now this, he has to drill out this piece of bone. Very careful. You see, he does not drill like this, back and forth, back and forth, back and forth. He just follow one direction. And then it bleeds, cavernous sinus bleeds. Somehow he has to stop the bleeding. Now he's removing the rest of the bone, piece of the bone. And then we can start looking at the, the basilar artery and the branches. Now we have a better view. This is posterior clinoidectomy. Okay. Now he's checking out you see the opposite third nerve, the white structure. On top of the third nerve has to be a PCA. Okay. Now he's checking that PCA is right here. This is a third nerve artery going up, and this is a PCOM. He's coagulating PCOM. Why doesn't he coagulate right here? Because all the branches will come off the PCOM at the anterior 2/3. Now he has the access to the basilar trunk for the temporary clipping, and then he's tried his attempt to clip the aneurysm now.
No, I'm done. I am done.
Okay, you see here's the fenestrate clip. So the fenestration will allow, the PCA to be free, not included in the clip, in the shanks of the clip. Okay, now clipping the aneurysm. And his adjusting and removing the temporal clip. You see the third nerve here? He's making a stitch to anchor the clip, to hold the clip in position. I don't know if you guys have ever seen this before. And this is, now he's checking. And the flow of the basilar bifurcation is usually very strong. Usually one clip might not be enough. So this is additional clip. Just to keep in mind, this was done like 15 years ago. Okay. We got 5 minutes. Maybe, hey Juan, what do you think? We got only 5 minutes.
No, I think you can extend, keep showing the videos as you wish, because we have 30 minutes of discussion at the end. We can use those minutes to keep showing videos. So just show what you wanna show.
Okay, I'm gonna show maybe one more.
Yeah,
and if we have more time in the end.
One.
All right, okay, let's go. Okay, let's go and share screen again. Let me see here. Which one is this one? Toronto. This one is... Você já foi, é. Assim não abre. Ok. Stop share. Share screen. Eu tenho que abrir aqui. How about now? Yes. All right, I'm learning. you know, for surgeries of anterior third of the mesotemporal lobe, probably the best approach, I would say probably the most used approach is the Arterional approach. You know, Transylvian, just like what Professor Yashargil advocated. Okay, the posterior one, probably you can come from behind. The problem is in the middle third. It's difficult to reach from front and difficult to reach from behind. So if you do the subtemporal, one of the alternatives is, why don't you come from here? Just go, that's the shortest distance. So why don't you go subtemporal approach? One of the problems right here. Can you tell me what problem would that be? You have to retract the temporal lobe. And what's the problem with that? You know, the complex of vein of Labbé and other veins that drains to the transverse and sigmoid sinuses. So you can get venous infarction if you rupture those important veins. Also, you can see the shape of the tentorium. The tentorium is like this. Tent is higher medially, lower laterally. So you have to do something like this, subtemporal, and then go up all the way to this region, the middle third of the mesotemporal region. That's something very difficult to do. So you have to go low and then go up, and then vertically go up to here. So actually, this approach was advocated by Professor Yashargil, and then used later by his successor, which is Professor Yonekawa. But interestingly, in 2012, on the same issue of Journal of Neurosurgery, there was a paper from Dr. Vander's group advocating the supracerebellar transtentorial approach. And also there was a paper from Professor Ture in Turkey describing the same similar approach. They were on the same issue of Journal of Neurosurgery that month, March 2012. So now I'm presenting a case located in the temporal lobe. That's the approximate middle third of the temporal, middle third of the mesotemporal region, an AVM. We don't see that much of the nidus because this AVM is rather more like fistula type of AVM. Okay, but it's located at the basal surface of the mesotemporal lobe. So we have the MRI over here. So for sure, this is a PCA. So the basal part of a temporal lobe, it has to be supplied by the branches of the PCA, and also the inferior temporal arteries, and also the parieto-occipital artery. We're gonna see here. This is the surgery. This is a positioning of the patients. It's a rather long, straight incision because he has to expose way superior to the inium, external occipital protuberance. Here is after the dural opening. Now he's dissecting carefully the thick arachnoid over, just at the level of cerebellar mesencephalic fissure. So now he's coagulating the tentorium. This bipolar seems to be very nice. With irrigation, you can see. Self-irrigation, very nice. And now you have to coagulate well, and then you have to have this very nice support of anesthesiologist to keeping the venous pressure a little bit positive, so the vein will bleed. Instead of air coming in, the blood will go out. So now he's exposing cutting the tentorial to expose the very large amount of the basal surface of the temporal lobe. Okay, now he's removing the tentorium, and then we are at the level of the AVM right now. As I said, this type of AVMs rather is more like a fistula. So he has to coagulate the branches, arterial branches, and keeping this draining vein. So every feeder, arterial feeder that go to the AVM will be coagulated. And obviously, you have to maintain the vein intact. So now it's working around AVM, around the vein itself. This position is very tiring with the the upright position. Semi-sitting position is very tiring. We all know about this. Now he's just coagulating around the AVM and the feeder. This is a parietal occipital artery. Continue to cut the arachnoid, identify the feeders, coagulate the arteries, keep the veins. In the later stage, coagulate the veins. You can see the arterial feeders, mainly from the parietal occipital artery. Now continue to cut small feeders. How do you know this is the feeders of this AVM? Because this is at the region of the parietal occipital sulcus. So the branches are from the parietal occipital artery. So it's still working from lateral to medially, because the venous drainage is towards the deep venous drainage system. So he's keeping the artery intact and coagulating small feeders. And this is parietal occipital artery. Very steady hands in this semi-sitting position is not easy. So still coagulating around from lateral to medially around the AVM. As I said, it's like a fistula type of AVM. So not much of the nidus. We're not talking about nidus. We're talking about fistula. To continue coagulate, you have to have very nice bipolar forceps. See him working around. He always says for him it's very clear, the pathological, the sick small branches. He can easily identify which small branch is sick, which small branch is the normal one, which one belongs to AVM, which one belongs to the normal brain. And also it's easy for him to identify which is artery, which one is the dilated vein. That will take some time to get this kind of experience. So continue to work around the AVM. Small branches has to be coagulated, and the main artery, the parietal occipital artery, has to be preserved. You can see just coagulating branches coming off the parietal occipital artery in going to the AVM. And now, finally, the vast majority of the branches came from the parietal occipital artery. But he already knew beforehand because this region corresponds to the parietal occipital sulcus. And then final stage of the surgery. and the removal of the AVN with preservation of the proximal artery. You see there? This is a final aspect of the after the surgery, after resection. Maybe, hey Juan, how about this? Can we start with the ex-fellows, ex-residents talk? If there's still time in the end of the our session, I could come back with one more video maybe. What do you think?
As you wish.
Okay, maybe those guys are anxious to speak, right? Am I right? Yes. Who's the first one? Vicente, this guy from Spain, the Brazilian Spanish from Valencia. So you're the first one, right? So why don't you just go ahead and introduce yourself to everybody? And how did you meet Professor Evandro? Just a very short description, okay? And then go to your lecture, okay? Thank you very much for joining us, Vicente.
Okay. Hi. First, sorry if my connection is not good. I'm not at home, so I hope everything works okay. Okay. Well, as you said, I'm like Spanish Brazilian or Brazilian Spanish or something like this. I went to Brazil, Sao Paulo, 10 years ago, and then all my life changed. Professor supported me from the beginning, and he teach me everything, not only about microsurgery or neurosurgery, but also many different aspects of life and his philosophy of life and work. And that's why I will be eternally grateful to him. So thank you, Professor, once again. Let me share my screen. So I'm supposed to talk about or is related to sinus. But first, I would like to thank the
Dr. Vicente, it seems like your audio is cutting out. If you turn off your video, since it might be better, your audio might be stronger.
It seems we have some issues with Vicente's video and connection. While he fixes, just let me say, Vicente is definitely one of the most prominent surgeons right now in Spain doing cerebrovascular and skull base. He carries on Evandro's legacy and translated to Spain. And, you know, as a Spaniard myself, I'm proud to see him succeeding as he is, doing amazing surgery and amazing cases. I hope he can share with us. Vicente, are you with us?
Is it working now?
Yeah, we can hear you.
Yeah, we can hear you.
Vicente, they were saying that perhaps you turn your video off, your audio will be better.
Yeah, but once I stop the video, it seems like you cannot hear me.
Oh, I see.
No, if I stop the video, you cannot hear me.
Okay, well, let's try with
Let's
the video.
try to continue.
Yeah, I can hear you. I can hear you this way.
So thank you, the organizers, and thank you, the Rhoton, to the Rhoton Society. It's my pleasure and honor and be part of this amazing event. It's a great opportunity. So I would like to give special credit and thanks to my professor, mentor, and friend, Evandro de Oliveira. You all know him as a great microsurgeon, but I can tell you he's a better human being. So you know he is a great microsurgeon of neurosurgery. I would like to tell you quickly what he means for me as a human being and as a master of microneurosurgery, just spelling his name. So Evandro means excellence, not only performing surgery, but also in all aspects of his life. He means vision. He has a real 4-dimensional vision to understand the pathology and plan the surgery and be able to treat different kind of vascular and tumoral pathology of microsurgery. That's why his surgery becomes an art that we all know and we all try to understand and perform like him. He has also a natural instinct to treat different kind of pathology. You all know his cases of tumors. He has an has extreme determination to make his dreams reality, and that's why he achieved all that he did during his career. Finally, he's a responsible leadership. He has been training a neurosurgeon from all around the world, and that's why today he is our soul, and he is performing surgeries all around the continents, being the soul of many neurosurgeons and microneurosurgeons of all around the world. So thank you, Professor. And I would like to show you just some remarks about the microsurgical remarks that I learned from Professor Evandro de Oliveira, and just to show you how this cavernous sinus region is deep located in the skull base, so it's in relation to many neurovascular structures, and we have to be able to understand this skull base anatomy and the bony anatomy of the skull base, all the landmarks, the anatomical landmarks in relation to the anatomy from different point of view, and achieving this ability to create and recreate in our brain the different locations and the different organization of the neurovascular structures inside the skull base and cavernous sinus, and then be able to perform surgeries through neurosurgical approaches, microsurgical approaches, or endoscopic approaches, as Professor Fernandez Miranda will show you later on. So through different point of view, once we have enough knowledge about the cavernous sinus anatomy, we will be able to visualize through small approaches the anatomy that we have to master to deal with different kind of vascular and tumoral pathology. let's review the microsurgical anatomy of this cavernous sinus, starting from the roof. We microsurgeons usually work through the roof or through the lateral wall of cavernous sinus, and finally we can reach the posterior part. Usually the medial wall is easily to reach, like from the endoscopic point of view. Then that Professor Fernandez Miranda will show you a nice picture from the endoscopic point of view. And if we start reviewing the anterior part of the roof, you can remove the dura covering the anterior clinoid process, and then remove the roof of the optic canal and the lateral attachment as the lesser sphenoid wing, and finally the optic struct, release and remove the anterior clinoid process and expose the most anterior part of the roof of the cavernous sinus, opening the carotid-oculomotor membrane, and then being able to get proximal control through the clinoidal segment of the internal carotid artery. We can then dissect the rings, the distal dural ring, and get total control of the clinoidal segment and the first segments of the internal carotid artery to deal with paraclinoid. We can continue and removing the posterior clinoid process. Professor Wen showed you in this vascular aneurysm case from Professor Vandro de Oliveira, that we can today get control using fibrin glue, and then finally totally enroof the cavernous sinus and be able to perform real transcavernous approaches to the posterior fossa, to the basilar tip, the basilar artery, or even to the brainstem, as the case that Mateus showed you from this cavernous malformation of the midbrain. So this is the anatomy that we have to know from the roof of the cavernous sinus, and how to dissect the lab, as we are going to do in the OR. We can get a to understand the relation from the artery and the nerves, and then get a view from the medial part of the cavernous carotid artery, some branches from the ascending segment, the meningiohypophyseal branch, and now the dissector is pointing to the Microneurosurgical capsular artery. Just zoom a little bit and see how thin is this medial wall of cavernous sinus, and how we can even visualize the pituitary gland through the thin layer and the artery that's running to this sellar region. Now we are moving to the middle fossa and lateral wall of the cavernous sinus. We know that we can peel the dura from the lateral wall of cavernous sinus and then expose this periosteal layer that keeps intact, avoid bleeding from, and then we can control of vascular structures, or get control of the bleeding, or even release CSF from posterior fossa to relax the brain and be able to work nicely over the cavernous sinus, middle fossa, or even the mesial temporal lobe. We can work between fourth nerve and first division, and then get exposure of the horizontal segment of cavernous carotid artery and get proximal control while dealing with paraclinoid aneurysm. We can open a window between V1 and V2 small arterial branch trunk coming from the horizontal to the foramen rotundum. We can open the Gasserian ganglion, the megascape, sorry, and expose the Gasserian ganglion. We can open even a big window to release CSF from posterior fossa, relax the brain, and be able to perform a peeling until the posterior edge, and even perform anterior petrosectomies to get access to the posterior fossa, brainstem, or neurovascular structures of the upper part of posterior fossa. This is an superior view, just to show you the relation between third nerve, fourth nerve, first division, and we are missing here the sixth nerve that we can expose, just retracting V1 laterally, and then we can see how the sixth nerve is coming from the posterior wall of cavernous sinus through the Relus canal, then running laterally to the ascending segment of cavernous carotid artery, then below the inferolateral trunk, and then running medial to V1 to enter the orbit through the orbit. Just a zoom of this sixth nerve running lateral to the cavernous carotid artery, medial to the nerve of the lateral wall of cavernous sinus, zooming out. And now a panoramic view of how we dissect the roof, the lateral wall, how we can peel the middle fossa and then reach the Petrous edge and the superior petrosal sinus to be able to perform anterior petrosectomies. This is a lateral view. Once we dissect this lateral wall of cavernous sinus and roof, again, if we retract V1, we can expose sixth nerve, and we can even control the horizontal segment. This is the inferolateral trunk coming from this horizontal segment running laterally to the foramen rotundum. We can expose the GSPM and the geniculate ganglion, and this is a good landmark to identify the petrosal cavernous carotid artery. So we can, from different point of view, be able to identify this structure, the GSPM, geniculate ganglion. This is a the tympani laterally covering the middle ear. So once we identify these structures, we can drill or dissect to expose a small segment of this Petrous carotid artery, or get a huge window to get proximal control in case of tumors, or even get control, a good segment, a nice segment to perform intracranial bypasses for using as a donor the petrosal carotid artery. This is just zooming a little bit. And now we are going to dissect as microsurgeons the posterior wall of cavernous sinus. Sorry, before we are going to expose the posterior medial triangle, this so-called Kawase quadrilateral or triangle. So once we identify GSPN, geniculate ganglion, we can unroof the internal acoustic meatus, and then visualize the dura, open the dura, and identify 7 and 8 cranial nerve. And now we have a piece of bone here that we can remove using the drill to open and the posterior root of fifth nerve, and laterally all semicircular canals. This is another dissection to show you all these structures, how laterally we have many structures we don't want to damage. But medially we can work safely and get a nice window to work on the upper part of posterior fossa, brainstem or vascular structures. Back to the same dissection, we have this piece of bone at the apex of the Petrous bone that we can remove and get access to the upper part of posterior fossa in between the internal acoustic meatus, the posterior root of fifth nerve, and posteriorly to the Petrous carotid artery, trying to avoid this anterolateral corner where the cochlea is located. Again, another dissection to show you all these structures. And finally, now posterior wall. Now, as microsurgeon, again, middle, the posterior wall, and expose the sixth nerve running through the Dorello's canal. This ascending segment of cavernous carotid artery, meningeal hypophyseal arteries, the inferior hypophyseal, Bernasconi, and meningeal branches to the dura of the upper clivus. Now we can finally expose all neurovascular structures, all branches of cavernous carotid artery, the middle, lateral, and posterior branches of this cavernous carotid artery, and how all nerves are in relation to all these vascular structures. This is a lateral view. And now another landmark we use during surgery, this petrolingual ligament as the distal part of the Petrous carotid artery and the starting point of this cavernous carotid artery. Just to finish, show you one piece quickly of this giant aneurysm and how to master the microsurgical anatomy of the cavernous sinus can allow us to perform or to imagine different options to treat pathology. In this case, we plan and we perform an bypass proximal segments of the MCA. And this is what we did in surgery as we are used to do in the lab. I'm going to show you how we do the same. We try to perform the same steps during surgery and the same steps that we perform and we learn in the lab, trying to identify the same structures during surgery, the same structures that we are used to identify in the lab. And finally, the results performing this extracranial, intracranial, just to finish, we come back to the beginning. We come back to the lab, to the training in the lab to master the anatomy, the microsurgical anatomy of the skull base. And now once we master all this anatomy, we can location of these neurovascular structures and totally reconstruct the puzzle to treat in, around, or through the cavernous sinus. Thank you, Professor. We all are so grateful to you. You share with us many thoughts, all your knowledge. We are going to be eternally grateful to you for it.
Thanks, Vicente.
Great presentation. The audio was not that good, but that's not your fault. I know you are biking around the country, so I don't know if you're in your bike with your phone or what are you doing, but great work.
I'm sorry I'm not at home, and that's, I cannot get better connection. Sorry so much.
Not a problem. We enjoy having you. Thank you, Vicente.
Okay.
Bueno, I think we have Carolina next.
Yes. So our next speaker is Carolina Martins, and she will tell us what she learned from Professor Evandro de Oliveira. And you can also tell us a little bit about how you met Professor.
Yes, Wayne, thank you. I will do that. Can you hear me okay?
Yes.
Yes.
So let's go. I will tell you how I met Professor Evandro during my talk. I will mention that, and I will tell things I learned from him. But I need first to acknowledge some people, I guess. Hold on. Yeah, here. I need to acknowledge some people, so I want to ask you all and the attendees, while I thank several people, to start reading those sentences and picking the ones that today may represent your thoughts. So I want to take this time to thank Professor Evandro. I feel very honored to be here. There are several people that could be in my place. You have so many great people that have worked with you over the years. And I just can conciliate that to think that I'm speaking for them using their voice. So thank you very much. Thank you to your family. They have always welcomed me every time. And I want also to thank my friends at the board, our president, Dr. Kobayashi, our senior vice president, Dr. Matsushima, for making the point to have this Congress in your honor, and Juan, and of course, Wen, to putting all this together. So while I think you have learned or read these sentences and pick the number that represent you today, because we will need that to understand what I'm talking about. So what I will be speaking is things I learned with Dr. Oliveira. And if we do a little experiment and ask 100 people to speak about this man, we will find out that these 100 people picked very different subjects, because he's such a guy, he has made such an impact everywhere that all the fields can be touched in their thinking about Professor Evandro. But if we boil down all these thoughts about him, we will probably find a coincidence. We will probably find that most of these people will agree to say, and me together, that he's a very talented guy. And talent is something very important in our field, in the surgical field. We used to think in the surgical field that if someone has a big talent, just like Professor Evandro, he's in the right place. But we surgeons, we should think sometimes, and we express that if talent is small, we may want to advise the person to choose another career. This is something we believe, this is something we speak about in the surgical field. This is like a fixed belief in our field. There are others, some more in some places, in some centers, some more in others. And another one of these fixed beliefs is that not all surgical parts of a procedure have been created equal, that there are differences between the parts of the procedures. Some are more important than others, and those important parts of the procedures must be performed by very talented surgeons. while the other parts, they may be reserved for less experienced, less talented surgeons. So this is a second fixed belief in the surgical field. And there are third one, that surgeons, they start learning, but up at a point in their careers, they reach a plateau and there are not more else to learn. So these three are fixed beliefs in our surgical field, in neurosurgery as well. But I must tell you that none of them, not one of these three fixed beliefs I learned from Dr. Evandro de Oliveira. So what did I learn from him? I have been observing Professor Evandro for a long time, more than 20 years, you can tell by the picture. And I have been observing him as if he were a puzzle. I was keen in what made this guy tick, the value he placed into things, how he organized his work, because that made a lot of sense to me. And I could not put that into words, but as I kept teaching my students, as I kept operating on my patients, and more since I reached seniority in neurosurgery, that had made a lot of sense to me, that have made me bounce back immediately after unwanted results, that kept me learning, growing, enjoying what I do every day. So he really has done a major service in my life. So I probably didn't have the words because the words were not there yet. At the same time, I was observing Professor Evandro in the social sciences. Several theories were coming up, theories about our beliefs, our mindsets. This has become into a school of thought, now housed in this institution that is housing us at Stanford University. The major name in this research is Professor Dweck. And this research into mindsets has made a huge impact, not only in the social sciences, but has spread everywhere and has become proven in these 20 and plus years, and have been reaching policies, national and international educational policies. So if you have kids, you want to have a look at this. And what is this mindset all about? Mindset are the beliefs we have about our capacity and the capacity people has. And the mindsets, they may be resumed, summarized into a fixed or entity mindset and a growth or process mindset. So anytime we think that skills, abilities, traits are fixed, carved in stone, let's say, we are displacing a certain type of mindset. Just as these two, 1 and 2 sentences here. So those are the fixed mindset sentences. And for this state, there is a risk. When we encompass those beliefs, there is a risk, because once we don't think that we can improve, that things are carved in stone, failure becomes a major problem. Failure is something to be avoided. Otherwise, it will hurt ourselves. In the other way, there are other mindsets. There is the process or growth mindset. In this state of mind, we think that things can be improved. The number 3 and 4 sentences, if you pick those represent a different mindset in which we believe that through practice, through training, and above all through method, we can become better. We can improve attention, memory, skills. We can become better surgeons, if you will. And that's the growth mindset. It's not that the growth mindset doesn't find failure. We do. Anyone does. But when we face trouble, we do not get discouraged. We understand problem as a way, we understand failure as a problem that needs to be dealt with, need to be learned from, and we need to get past them. So in fact, we want to have challenge. So what I'm saying to you tonight, in Brazil at least, is that Professor Evandro de Oliveira is the paramount example of a growth mindset in neurosurgery. You may be asking me for evidence. I do have. Exhibit A, his post-surgery behavior. Whenever he finished a surgery that, for me, in my fixed mindset, was perfect, he would say, whenever I finish, I start thinking, how can I do better next time? Whenever he was discussing an approach, he would say, I did this such and such in the past, this how I do it now, and he would discuss and say why he had changed. When in his courses with heads, he would not jump to the major part of the procedure. In fact, every step counted, every step count. He would set up the drapes. He would position the head with the same importance that the major part in any procedure. And mostly, he would insist anytime in a clean, spotless field of work. Mostly because for Professor Evandro, we need to see the anatomy, every structure count. Anyone that has operated with him knows the heavy signal he would give if an innocent vein was taken out of one of his patients. And if you want exhibits, his lab, the way he thought about lab is a great exhibit, a great evidence. Only someone that thinks he and the others are in the process of becoming would give such importance to the lab work as Professor Evandro does. And he has been laboring and speaking about and to discuss complications as a fast track in our specialty to make us improve as surgeons. Professor Evandro raised the bar to every part of a surgical procedure. He would name and give importance to any of them. He would raise the bar, and once the bar was raised, he would not accept lower. And that provoked that everyone working with him would very soon become involved with his or her learning curve for any part of these procedures. And this in part explains the high quality people that have been working with him over the years. Anyone looking at these people from a fixed mindset would say simply they are chosen. But in fact, these were people learning under the Evandro mindset effect, learning very fast. These were all people learning. If they think about their time, this is how they will feel. They will agree with me about that. So what is the effect, Evandro effect in neurosurgery? A big quality leap in anything he was involved, surgery, course, congress, society. And he would insist in speaking about surgery and the parts of surgery. And if we think, it's hard to speak about improvement, improving if the matter we are working with are people's brains. It required someone with Evandro's scientific sincerity to tell us that there are different and better ways of doing things, because he put value in every part of a surgical procedure, and would have fun. If you were close to him, you would see he was having fun while doing that. He showed us the roadmap to self-improvement. He proved to us that there are more to learn, that no one is yet ready. Everyone is becoming. And because he has always insisted in discussing complications, he has proved to us that neurosurgery is an endless road of learning, that we need to keep involved, especially the senior neurosurgeons, that we keep to be passionate for what we do. And this is truly what I learned from him. And what I want to say to finish is that among all things that Professor Evandro has been doing over the years, we should not let out one of his most important contributions to neurosurgery, his mindset. His mindset is one of his most important contributions to our field. I am deeply honored to be involved with this, to be close to you, Professor. I and my family, my husband Antonio is also a surgeon. We tap into your mindset every day in our work. We think about how you think. We value that. And at night, I keep thinking that the prophets and the angels, they did speak to you in your dreams so that you show us every day how to do surgery, neurosurgery, and also to live, because you face your challenges and very big challenges. So I go full circle to say that I learned from you neurosurgery. I keep learning with you about life. Thank you so much for listening. Thank you, guys.
No. Hello, Carolina, thank you so much for your very wonderful presentation. And the next speaker is Antonio Mussi. Mussi was also Dr. Rhoton's fellow, and he's from Dr. Evandro's hometown, Florianopolis. He's going to talk about the anatomy and approaches to the region of the posterior incisorial space. So why don't you tell us a little bit about the relationship between you and Professor Evandro, and then start with your talk. Thank you for joining us.
Okay. I will talk about this. Anatomy and approaches to the region of the posterior incisorial space. I was Dr. Rhoton's fellow from 1998 to 2000. And now to talk a little bit about Dr. Evandro and the influence he had in my life and my career as a neurosurgeon. I was his resident, so he started to influence my career since my first days. When I did my test to become a resident, he was present. So since the beginning, after I finished my residency, he accepted me. I had the honor to be accepted as his fellow for 1 year in Beneficência Portuguesa. And then he got me a position in Dr. Rhoton's laboratory, which was a tremendous impact in my life. And after the 2 years in Dr. Rhoton's laboratory, he has given me the opportunity to participate in many of his courses in São Paulo and also Portugal. I was even in Russia, in Siberia. So I think I thank him for all he has done in my life as a neurosurgeon, and for, like it was said before, for being such a mentor, a hero, and this was what I would like to say, and for the introduction. And now to come to the topic, I will talk about something that was shown in the last video that Dr. Wayne showed, which is the posterior incisorial space. So when we look to the tentorial notch, the brainstem divides this area into 3 areas: an anterior incisorial space anterior to the brainstem, a middle incisorial space lateral to the brainstem, and a posterior incisorial space posterior to the brainstem. But this region is larger. We can see that it has also the posterior part of the temporal lobe with the parahippocampal gyrus. It has also the interhemispheric fissure with the occipital lobe, and it has also the atrium. The atrium is located just above the posterior incisorial space, as the frontal horn is located just above the anterior incisorial space. I'm sorry. And I will talk about the 2 main approaches to this area, which are the occipital transtentorial approach and the infratentorial supracerebellar approach. Of course, there are other approaches, but these are the most important ones. And I would like to show you the differences in the same specimen, so you see which structures are exposed in each one of these approaches in the same specimen. So to talk about this region, we have to remember the shape of the dural anatomy. The tent of the cerebellum meets the falx at the level of the straight sinus. And if you look to the relationship of the falx with the corpus callosum, you see that in the posterior part, it goes all the way until it reaches the corpus callosum, while you have a space anteriorly. So it's much easier to get to the level of the corpus callosum when coming posteriorly than when coming anteriorly. Another thing, if you look to the sagittal view of the incisorial space, you notice that in the anterior incisorial space, you have arteries, mainly arteries. And in the posterior incisorial space, you have mainly veins. So these are the structures that make a surgery in this area different from the anterior one. Now, this you see also, if you remove the falx, you have the parietal occipital sulcus here, the cuneus. So you also have the cingulate gyrus, the posterior part of the cingulate gyrus, the precuneus, and also the temporal lobe, which comes all the way here. So these areas have also to be looked at when we talk about this region. And of course, also the third ventricle. When you get to this area, you also can get to lesions located inside the third ventricle, and of course also the tentorial surface of the cerebellum. So let's review what are the brain structures that can be exposed. So you have the posterior part of the parahippocampal gyrus. This is the calcarine sulcus, anterior portion, and the parietal occipital sulcus. It divides the cuneus. Inferior to the calcarine sulcus, you have the lingual gyrus, and lingual gyrus is the continuation posterior, like the posterior continuation of the parahippocampal gyrus. And of course, you have also the splenium of the corpus callosum and the posterior part of the cingulate gyrus. So these are the areas that can be exposed when we reach this region. This is an anterior view. The thalamus was removed. This is the choroidal suture. This is the pineal gland. And this is the posterior incisural space. So when you get to this region, you can get laterally to the posterior part of the parahippocampal gyrus. You can get through the interhemispheric fissure to the cingulate gyrus, and you can get also to the third ventricle. The main vessels in this region, regarding the veins, you find the internal occipital veins. They pass just below the splenium of the corpus callosum, and they meet with the basal vein of Rhoton to get the Galen vein and drain to the straight sinus. This is the basal vein of Rhoton going around the brainstem and receiving some other veins like the lateral mesencephalic vein and this vein that drains through the calcarine sulcus. Another view, now posterior view, the pineal is here, quadrigeminal plate, basal vein going around, meeting with the internal cerebral vein, receiving on the midline the precentral vein and forming the vein of Galen. This is, you see also the precentral vein coming here to drain to vein of Galen here. So these are the venous structures that we'll find in this area, the posterior incisural space. And in this slide, you have an upper view. You see the internal cerebral veins bilaterally, the pulvinar of the thalamus, the pineal gland, the third ventricle, and both internal cerebral veins coming here. Laterally, you see basal vein of Rhoton, and you also see veins draining from the atrium, which are the medial atrial veins. So you can see that the most difficult structures in this area is related to the deep venous system. Now, regarding the arteries in this area, we have mainly the posterior cerebral artery. The posterior cerebral artery goes around the brainstem and irrigates the inferior part of the temporal lobe. And finally, it gets inside the calcarine sulcus to divide in parieto-occipital and calcarine arteries. So this is the view from below, the posterior cerebral artery, here the hippocampal branches, and it goes here to enter the calcarine sulcus and divide in calcarine parieto-occipital. This is just the inferior temporal branch. So this is a posterior view of the area. The pineal is here. You see the internal cerebral vein. You see the dissection around just above the calcarine sulcus. So this is the calcaravis. This is the atrium of the ventricle. And this here, you can see the splenium of the corpus callosum, just the end of the splenium. So you also can, when you get to this region, it's not so difficult to get also to the atrium of the ventricle. And now regarding the third ventricle, you see the lamina, the arachnoid attaching to the lateral side of the thalamus and going up to the pineal gland. You see the posterior pineal, the suprapineal recess. Through the suprapineal recess is how you get to the third ventricle when you come from posterior. This is the internal cerebral vein, the splenium of the corpus callosum, and the pineal gland, and this is pineal recess, abennular commissure, and posterior commissure. So when you come from posterior, you open the suprapineal recess and get to the third ventricle. So now let's see with more detail the two most important approaches. The occipital-transtentorial approach can also be called the posterior interhemispheric approach. When you do this approach, you place your craniotomy from the posterior occipital protuberance 7 centimeters upwards. You'll find the lambda, and this area you can see that it's almost devoid of major veins. You start to get more important veins from the lambda at the level of the parieto-occipital sulcus. So you can see here, you can do a craniotomy like this, and you expose the sinus. The sinus does not bleed so much when you do a posterior approach as it bleeds when you do more anteriorly, so it's not so difficult. And you can open the dura like this, and usually you have a major vein here at the level of the lambda, at the level of the occipital, the parieto-occipital sulcus. And this area here is devoid of veins, and you can get straight to the posterior incisural space, as it is done, shown here. The occipital lobe is retracted superiorly and laterally, and you can also open the tent to expose, if you need, the upper side of the cerebellum. You can get access to the pineal region. You can get access to the posterior temporal lobe. And here you see the vein of Rosenthal coming here. Usually you can do a 3/4 prone position. The side that you are entering by gravity, the cerebrum falls down, and you can get interhemispheric approach. You can do several kinds of incision, do the craniotomy. That's just like the anatomy that I shown you. You see on the upper part the vein, and you have a big corridor here, usually devoid of veins, that you can use. You can have a lumbar drainage also to facilitate the falling of the brain. And you see the tent, the straight sinus, the falx, and you have access to this area. So let's see the occipital transtentorial approach. This is the view that you have. The straight sinus is here, the tent, the falx. This is the basal vein. This is the vein draining along the posterior part of the corpus callosum. And this area here, this is the calcarine sulcus. So this area is the lingual gyrus, and this is the posterior part of the cingulate gyrus. You can open the tentorium, and you see the tentorial surface of the cerebellum, the quadrigeminal plate, the pineal gland, the internal cerebral veins. So this approach can be used, for instance, for tumors located in the pineal region. This is, you have a view of the venous structures on the middle of your approach. You can enter the third ventricle just above the pineal gland on the suprapineal recess, as I said. And you see here the vein and the artery going on the roof of the third ventricle. And you can also go laterally, more laterally. This is the calcarine sulcus up here. So this is lingual gyrus. This is posterior part of the parahippocampal gyrus. You see the posterior cerebral artery, the vein of Rosenthal, and you see the inferior temporal branches of the posterior cerebral artery going to the inferior part of the temporal lobe. So you can go more laterally to get lesions on the posterior parahippocampal gyrus. And another thing that is important in this approach is that you have a very good view above the galenic system. You can see the posterior interhemispheric fissure, and you can see also the posterior part of the cingulate gyrus. Now, using the same specimen, these are exactly the same structures, but now seen from the infratentorial supracerebellar approach. So when you can go either median or paramedian. this is a view of the median approach. You see the precentral vein, the superior colliculus, the pineal gland, the basal vein of Rosenthal on this side, on the other side, the internal cerebral vein, and this is pineal gland with the suprapineal recess. You can open the suprapineal recess, and this offers you a very direct view to the third ventricle. This is the splenium of the corpus callosum. And you can also go more laterally, a paramedian approach, but you can also open the tentorium from below, as Dr. Wayne showed in Dr. Ivandro's paper and video, and you can get access to the parahippocampal gyrus. So this portion here, you see the branches of the posterior cerebral artery coming here, and you can get access to this region from below. This is the publication that Wayne showed. So this is, if you look here, this is the calcanean sulcus. So you see that from this approach, it's more difficult to get a view above the galenic system as it was with the other approach that I showed you. But you can get from the calcanean sulcus below, you can get exposure of this region and access directly to the third ventricle from below. A paramedian approach, you can come more laterally, as it was shown, and you can open the tentorium, and you get this curving of the cerebellum to get this area, and you can better see the trochlear nerve and the quadrigeminal plate. Now, I will show you some cases. Most of the cases, you can choose either you go from above or you go from below, but there are some specific cases that I want to show that points you for one or the other approach. Now, this instance, this is a tumor in the pineal region, but when you look to the sagittal cut, you see that this tumor is just above the galenic system. It's on the posterior part of the cingulate gyrus. So this was a glioma, and because it was above the galenic system, we chose to go from above occipital transtentorial approach. This case, it has a tumor on the posterior parahippocampal gyrus. This was a metastatic lesion. I think you could go either from above or below. We chose to go from above, occipital transtentorial approach, and we removed this lesion. This was an AVM. We saw an AVM operated from below. This is an AVM. If you look here, the feeding branches are from the posterior cerebral artery, and you can see occupying the posterior parahippocampal gyrus. It's this region here. We chose to go from above, and we could do the excision of this lesion. Also, tumors, usually, sometimes it can spread more posteriorly. So if it spreads more posteriorly to the occipital or the cuneal region, of course, you can choose to go upwards. So this tumor, you can see all this region going posteriorly. We chose to go from above also, and we could do a greater resection. Also, tumors of the pulvinar of the thalamus. You can see this tumor here on the pulvinar. You can also go from posterior, all using the occipital transtentorial approach, just as I described, and resect the lesion. Another example, posterior parahippocampal, but this going above the pareto-occipital sulcus. We can choose also from below, and you can see the resection here. Finally, two more cases, just two more cases. This is a child, 12 years old, with a small lesion inside the ventricle. If you come from laterally, you may cause some visual deficit. So you can also come occipital transtentorial or interhemispheric approach to this lesion. You can see the atrium is just above the posterior incisural space, so you can see you can come from the midline. I'm sorry. This is superior, this is inferior. You find the corpus callosum and you do an incision just lateral along the posterior cingulate gyrus, and you get to the ventricle, you remove the lesion, you don't cause deficits to the visual system. And this is a view inside the atrium from, again, the occipital interhemispheric approach. And you can see you do just a small incision here to remove the lesion. Now this big tumor, if you see on this sagittal side, you see that the tumor is located also above the venous system. And you see that it's much more supratentorial than infratentorial. This was a meningioma, falcotentorial meningioma. So the same thing, the same craniotomy, the same thing you can see. And you can, in this case, that you had a tumor that went to the other side, you can also, besides opening the tentorium, you can open the falx just above the straight sinus, as it was done in this case, and you see the tumor on the contralateral side, this tumor on the contralateral side, exposing tumor bilaterally, you see the occipital lobe on the other side, and you can remove this tumor through the same approach. So thank you again, Professor Evandro, and thank you all for your attention.
Hello, Antonio. Thank you so much for your wonderful presentation. So let's move on our program. We have the next speaker is Pablo Rubino. He's from Buenos Aires, Argentina. Can you tell us a little bit about your relationship with Professor Evandro, and then give your talk, okay? Wonderful to have you with us.
Okay, just 1 second. Hello? Can
yes,
you hear me?
We can hear you.
Okay. Thank you, Gwen, for the introduction. My talk is about Evandro's philosophy and the impact of Evandro philosophy as a personal perspective. So maybe in my talk, I will tell you how I met Evandro, but it was 20 years ago in Pinamar, a place that you know. So thank you for the possibility to talk here. Thank you, Juan Carlos, for your words. Let me tell you that your words reaches the depth of my soul. Thank you very much. I'd like to start with my presentation. I'm going to talk about the impact of Evandro philosophy as a personal perspective. And when we are talking about Evandro's philosophy, we can divide his philosophy in different aspects of Evandro's life. Okay, so regarding surgery, I think that Evandro has different aspects that I like to highlight. One is the study of anatomy. He's always promoting to the young neurosurgeon to study anatomy and show us that the anatomy was one of the most important tools to become a good neurosurgeon, or at least to try to be a good neurosurgeon. The second element is that Dr. Evandro in surgeries, his philosophy was try to achieve a very clean and very safe surgery, which is very important, not only for a surgeon, because it's surgery like an art, but it's very important for the patient. Another thing that I learned from Dr. Evandro's philosophy was the importance of taking care of the patient. Not only taking care in the operating room, but also to taking care of the patient outside the operating room, in the pre-op and the post-op stage of the surgery. I think that's very important. Another important aspect of the Evandro's philosophy is that he always gives the best, and he stimulates the different disciples to give the best, and not only in surgery, but also in our career, to give the best with the patient, with the study, with the knowledge, with the effort. So this is a very important thing that, at least for me, was the most relevant from Evandro's philosophy. Maybe we can talk the whole day about Evandro's philosophy, but this is the main aspect, at least for me. We can also talk about Evandro's philosophy in life, not only in surgery. The thing that I learned from Evandro is to help, not only to help the patient, but also to help everybody, every young neurosurgeon, especially, I would say in my country, Argentina, but maybe I can extrapolate this Evandro's aspect to many other surgeons, not only from Argentina, but also South America, maybe Europe, and around the world, we can say. And he's always was helping everybody. At least in my case, my career changed 180 degrees after knowing Professor Evandro. The second aspect of Evandro in life is loyalty. Maybe loyalty you can learn from your home, with your parent, of course. But a master like Evandro show you what important is the loyalty. Unfortunately, maybe I cannot include all the Evandro disciples in this aspect, but it's a very important aspect that I learned from Evandro. Another aspect of Evandro's life is teaching. He's teaching not only anatomy, he's teaching neurosurgery, he's teaching how to improve by yourself. So this is a very important aspect of Evandro, and he's teaching, and not only his wonderful technique is not for him, it's for everybody, and maybe everybody can learn from Evandro because he is a generous person. And finally, caring of the people. I feel that every time I meet Evandro, he's always caring about me. He's always asking not only for my career, he was asking for my family, and he gave me a lot of advice from the personal aspect of my life. So I think this is a very important aspect of Evandro's philosophy. Then, when I talk with Evandro, I talk a lot about, I want to be a good neurosurgeon. It's impossible for me to be like Evandro, but I will try. And he gave me, not only to me, to everybody, the Evandro's recipe to become a good neurosurgeon. One is passion, passion for your job, passion for for the patient, passion for neurosurgery. This is one very important aspect of Evandro. The second aspect is talent. That everybody has talent, but no, it's not the same in all the surgeons, but everybody has some talent that we can increase with training, with learning, and what else. Another important aspect of Evandro's recipe is courage to treat lesions that are very challenging. He is always one step beyond of the rest. So this is a very important aspect of Evandro's recipe. And finally, tenacity to treat complex lesion, to never give up. So this is, I think, that Evandro's recipe, and it's very important for everybody who want to be a neurosurgeon. Regarding Evandro's journey, everybody know that after finishing his training program in Uruguay, he moved 1 year to Argentina, and he spent with one of the best Argentinian neurosurgeon, who was Professor Raúl Carrera. Then he moved to Switzerland to learn from Professor Jasserhill, microsurgery. And finally, he spent near 2 years in Gainesville with Professor Rhoton. In this place, he completed his wonderful training, and there he could complete a wonderful job in neuroanatomy, especially with this wonderful paper that was published in Surgical Neurology in 1985. In this paper, for me, one of the best paper regarding the anatomy of the region of foramen magnum. I think this paper is still the mandatory reading for any young surgeon who wants to treat lesion in this complex area. You can find there all the information you need to operate on this area. What is the Evandro impact? We can summarize Evandro's impact in one word. And for me, the best word that summarizes Evandro's impact is revolution. He made the revolution in neurosurgery. What revolution means? Revolution is a drastic and far-reaching change in ways of thinking and behaving. So, how did he get his revolution? Promoting the study and application of the microsurgical anatomy, seeking bloodless surgeries, resolving complex lesions that were considered inoperable time before. And finally, he completed his revolution by spreading his technique around the world. Regarding my country, he was coming for 20 years to our country, and for 20 years, more than 500 Argentine neurosurgeons attending his courses, okay? Regarding Argentina, Evandro came in 1998, and for uninterrupted 20 years, he participated not only as a speaker, but also as organizer in our meetings. Regarding the first time I met Evandro was in 1999 in one of the most important meetings that we call Neuropinamar. It was 1999, and I was attending Evandro's lecture about AVN, complex AVN, and for me, this lecture was simply an incredible talk. Unfortunately, Dr. Ricardo Prina from Argentina introduced me, and immediately I asked Evandro to visit him and watch his surgery and learn anatomy from his team. And he was the first time just say, okay, you're welcome anytime. So for me, it was very important. It was a tremendous moment for me. And he brought many prestigious speakers to our meeting. As you can see in this list, maybe we can name at least 20 more very famous neurosurgeons around the world that came to our meeting because Evandros helped us to brought these speakers. He came to our hospital, Hospital de Cruce. We have the lucky to have courses with live surgery. In these courses, he treat complex aneurysm, AVMs, and brainstem cavernomas. We have more than 400 attendees with wonderful result in all our patients. So it was very important for us. It's just one of the picture that Evandros giving lectures, doing surgery. So I can draw this Argentine neurosurgery timeline, and I can choose from the beginning of the century to now. I can choose a time, and this point is 1988, when Evandro came to our country the first time. This is the impact of Evandro. So I do by myself this division, and before Evandro and after Evandro, and you can see the type of the surgery that we usually do before Evandro on the left side and after Evandro. Clean and anatomical surgery. This is because Evandro's philosophy influenced in our country. For the last 30 years, I can surely say that Evandro has been the most important and influential person in the development and education and improvement of the Argentine neurosurgery. This is my concept, and for me there is no debate in this point. Okay, and maybe I can extend this concept to many other countries, especially Latin American countries. So Evandro's philosophy impact in safer surgeries, impact in better result, and also impact in many patients have benefited with Evandro's philosophy, directly and indirectly with his philosophy. I think this is the most important aspect of Evandro's philosophy, how impact, at least in my country, okay? As Juan Carlos said in the first talk, Evandro is microsurgery, and microsurgery is art. How can I summarize what Evandro is? For me, Evandro is art. You can see this painting. It's called Il Battesimo di Cristo, was painted in 1475. There are two important artists that painting. One is Verrocchio, who did maybe most of the picture, most of this painting, but in the lower left side, you can see two angels. Part of the background of this picture was completed by one of the disciples of Verrocchio. And this disciple was Leonardo da Vinci. So I think that 500 years later, history repeats, now in neurosurgery. We have Verrocchio as a master, not only master of Da Vinci, but also Perugino and Sandro Botticelli. We have here Da Vinci, at least for me and for many others, as a genius. So you have an example here from a master, which is Verrocchio, and another example of a genius, which is Da Vinci. Let's do an exercise. You can pick some letters from the master, and you can pick some letter from the genius, okay? I can assume that the history repeats 500 years later in one person. And this person is Evandro. Evandro was Verrocchio, but Evandro is also Da Vinci. He was a master as Verrocchio, and he is a genius. He was a genius like Da Vinci. So genius and master meet again 500 years later in the person of Evandro de Oliveira. And why Evandro is a genius? For me, he's a genius because you can see this is a surgery that Evandro made in our hospital. A patient with multiple aneurysm, a vascular tip aneurysm, carotid bifurcation aneurysm, and ACA. And you can see the movement. You can see the elegance, the movement, how he goes very fast and safe. And in less than 30 minutes, he can complete the clipping of the multiple aneurysm without any problem. And you can see how he can did very well. He can do very well this surgery. It's like Leonardo da Vinci painting the Gioconda. It's very similar, the same feeling, simple and beauty. Is Evandro surgery because Evandro is a genius in neurosurgery. At the end of the Evandro surgery, I want to say, please tell this brain that Evandro was here, because maybe the brain didn't notice that Evandro was working here in the middle of the brain. Okay. Why is a master? A master because Evandro share his knowledge to everybody. He's doing the same surgery, and at the bottom, I am doing a very similar surgery. Just follow the step that Evandro showed to everybody. And this is very important for me because I have to do the same with, we try to follow the Evandro's philosophy. And as you can see, the very similar step that are doing all the staff in my hospital, because we are all follow Evandro's philosophy in not only in life, but especially in surgery. And you can see here some example of the people that are in my hospital, and all of them try to follow, and we are keeping Evandro's philosophy. So, in conclusion, I think that Evandro is a genius and is a master who has changed the microneurosurgery forever. Thank you very much for your attention, and thank you very much, Dr. Evandro. You know that I love you. Thank you.
Thank you very much, Pablo. That was a wonderful presentation. You know, I'm sure that all of us will have the same experience when we first saw Professor Evandro's surgery. That was a night-opening experience. You have never seen such a thing. And then it has opened up the whole world before us. So we all are here because we decided to follow his footsteps. So one thing I can tell you, he's following, all your talks. Vicente, Carolina, Pablo, Musi, he got very emotional, I would say. Okay, from time to time, I'll go to check on him, and today he's very emotional, I would say. Okay, he's very grateful, very happy for the demonstration of affection, and let's keep working. So, Juan, you want to say something? Sorry.
Just want to say that wonderful talk, Pablo. I really enjoyed it. Well done. And I am very emotional to knowing that Evandro is with us, following the symposium, and we send him all our love from here, from our family, to his family and to himself.
So we have the next speaker. And the next speaker is from Chile. Is Jorge there? Oh, yeah, I see you. Jorge, why don't you go ahead and introduce yourself, tell us a little bit about your relationship with Professor Evandro, and then give your lecture. Thank you so much for joining us today.
Thank you very much. Can you hear me?
Yes, I can hear you.
In my lecture, I'm going to talk about my relation with Professor Evandro. For me, it's a very huge honor to be here, to be pointed by him. I think all my life I was looking for that. Ever since I left Sao Paulo, I always want to be recognized by him. And then for me, this is very important. And I'm very nervous when he's listening, when you talk, he put you nervous all the time. Now I have more than 20 years of neurosurgeon, and I never put nervous in a surgery, but today talking and knowing that he's listening, I'm nervous, okay? And I only hope to not disappoint him. That's the same thinking I have ever since I left Sao Paulo. The relation with Dr. Evandro, before I show you my slides, is a relation that is complicated. I am a complicated person, and he's a complicated person as well. And but what I can say is the same that Pablo, that for me, know him changed my life. And I hope that changed the life of a lot of people in Chile, because I will show you why. Today I'm going to talk about the paraclinoid, where I have a big experience in paraclinoid because I was in love with paraclinoid aneurysms when I went to Sao Paulo, because we operate a lot of cases with Dr. Evandro at that time. And I feel that it was very important to know how to deal with the anterior clinoid process. And I try to do that all my life. And this is my disclosure. And I was very lucky because Dr. Evandro gave me a work to do when I did the fellow, and after I finished, to make a publication. And I have a publication in year 2000 with Dr. Rhoton and Dr. Evandro. I have to say that I am the only one who is not a fellow of Dr. Rhoton. But Dr. Evandro said to me the last year that I am a Evandro boy. And for me, that was very important. He made my day and my week and my year, probably. And I want to show you that in this paper that we made about the trigeminal artery, he gave me one dissection of him to make this publication. And the region was the same, the clinoid, anterior, the posterior, very similar that Vincent showed in the lecture before me. In 1996, Dr. Evandro came to Chile to a course in the very same place where I work now, Clínica Las Condes. I work there now in neurosurgery. And I knew him. I was very young, thinner, you know, and full of dreams. And when I saw him, this spectacular surgeon, I was resident in my last years. I really want to go with him. And I insist with my chief, my professor, is very similar to him with the mustache and everything. Please, I want to go with Dr. Evandro to Sao Paulo. Please send a letter. He sent the letter. I have the letter. I take a copy. And after that, I went to Dr. Evandro in 1999 and 98 and 99. Sorry. The first part of my fellow was in the INESP, and the second part in the Institute of Neurological Science. And I was very lucky, because you need to be lucky in life. I was very lucky because in that year, the law in Brazil gave me the opportunity to do a clinical fellow. And then it was completely different, because I went to the laboratory for some months, but after that, I can go to the operating room and see Dr. Evandro operating and assist him in the surgeries. That was very, very important to me. And the other important thing was the people that I knew. I knew Elder. I worked a lot with Elder in that time, Elder Tedeschi, and I learned neuroanatomy with Gwen. With Gwen, I learned the passion for neuroanatomy. The neuroanatomy is alive. It's not something that is dead in a picture. It's something that you can apply in the patients. That's the philosophy of Dr. Evandro. The neuroanatomy is alive. It's the tool that you use to your hands to get to the patient, to help the patient. And then when I always remember in when that repetition is very important. That's why I always go to the same lectures to anybody that talk about for example, the clinoid, because always you learn something. If you think that you know everything, that's impossible, because every day you can learn. And Dr. Evandro, the day before I left Sao Paulo, was a Friday in February, he gave me the book. This book was published in 1999, and I left the very same year in Sao Paulo, and he made me this dedication in the book, and was very important to me because it was not quite the year 1998, but I learned a lot. And for me, he gave me these wishes or the successful in my personal and professional life. I cherish this book, and I have in very close to me. And the first thing I learned with Dr. Evandro is you need to teach if you learn. If you learn something and you know something, you need to teach to somebody else. And then the first thing I did when I went to Chile, I entered to the University of Chile, of my country, the oldest one in the country. I started a fellowship immediately in the next year. Take 1 year, the paperwork in order to have this fellow, the first fellow of neurosurgery in Chile, made in 2000. And now it's the skull base and vascular surgery. And this is about transcendent. This is about leave something to the future. That's the message of Dr. Evandro. I was in San Diego, this very important meeting that was with the Evandro Oliveira Symposium, but I went as well to the laboratory when I went in Brazil in 1999, the Beneficência Portuguesa Hospital. That's very important as well, because the name of Dr. Evandro is in the laboratory now, because thousands of people learned there. And then that is one of these legacies. The neuroanatomy is alive. And then we talked today a little bit about paraclinoid. And paraclinoid is the fusion of microsurgery and neuroanatomy. The neuroanatomy is very, very important in order to understand how you need to clip or you treat these patients. And then I was lucky because in 1998, when I was in Sao Paulo with Dr. Evandro, he published this paper with Eduardo Seoane, an Argentinian neurosurgeon. And I was in love with the clinoidal segment of the carotid. And the clinoidal segment of the carotid is the key for everything, not only for paraclinoid, it's the key for transcavernous, it's the key for if you want to do a cavernous sinus meningioma, if you want to treat a pituitary adenoma or whatever you want to do. This is a key. And I was in love with this and in love with anatomy. Because I made a paper with Dr. Evandro, the gemellar artery, I was very lucky to be there when Dr. Seoane made this paper with Dr. Evandro as well. And then when I went to Chile, they said to me, the end of the microsurgery. Now we have the ISAT, now we have the coils. You need to stop operate. After 18 years, we still have neurosurgery because Dr. Evandro and other surgeons gave the fight in that time for us. And we need to keep giving the fight, not the fight against endovascular, the fight for the patients, to provide the patients the best treatment, the best treatment. The best treatment is not the faster treatment, the best treatment is not the easier treatment, and it's important. I never know if I can be successful in a surgery, but I always try. I learned that for Dr. Evandro. Dr. Evandro said to me that one day, you need to try. The only patient I cannot operate is after I try. And then it's very important. And in 2020, the microsurgery still is good for rupture, for example, aneurysms. And the endovascular is not always good. There are complications. You see, it's easy to learn how to do endovascular because microsurgery, as Pablo said before me, is art. It's difficult to be artist like Pablo, like Dr. Evandro. I'm not an artist. I'm a neurosurgeon. I try to be an artist, but I never get a beautiful surgery. I try, but the thing is I need to provide the best treatment for the patients. And then I fight for the surgery. This is for this year in Dr. Morco's symposium about defending the paraclinoid aneurysm management for microsurgery because I believe in microsurgery. I think it's better than other treatments, is longer, is more anatomical. And I think that if I don't believe this, I'm sure that I prefer to do endovascular, but I am convinced that microsurgery is better because I learned from the best, Dr. Evandro, you see? And then the neuroanatomy is important, and you have the names there, Dolens, Hakuba, Parkinson. Vincent showed this in tumors. And the definitions and the school of neurosurgery came from the neurosurgeon. You need to have your heroes. For example, the Americans love the subdural clinoidectomy because they learned from Drake, who defined the carotid ophthalmic. The Japanese, they look the extradural clinoidectomy because they learned from Kiyoshima, Kobayashi, Hakuba, etc. And the European, they love the subdural and extradural clinoidectomy because they learn from Dolenz. And then we have history, we have heroes. We need to follow the heroes. And then there's a lot of people that study this. Drake for one side, Hakuba and Dolenz for the other side, to show the extradural clinoidectomy. That for me is the best one, the extradural. And then I read this paper about the Hakuba. It was in 1982. The problem is in Japanese. Then I translate the paper to the English in order to understand how he did the surgery, because Dolenz published in 1983. They both did the same concepts, very similar. Look at the figure 1996 in the book of Hakuba. Dr. Evandro in 1998, he invited Hakuba to Sao Paulo. I knew the guy, the professor, and then I knew the people. The books are only paper. You need to know the people, how the people do the things. And then we have a big experience in paraclinoid, but today I'm here to talk about how Dr. Evandro influenced me in order to do the things. And then, of course, we have complications. Of course, we have a problem with the optic nerve. We have morbidity, we have mortality. There's a lot of surgeons who show 0 mortality, 2% of morbidity, and then they are better than don't have the pathology. I am a surgeon. I have complications. I learn from complications, unfortunately. But I learned that for Dr. Evandro. There's no a surgeon perfect. You need to improve every day. You need to know neuroanatomy. I did the same that he did in the surgery. When I did the surgery, I came with the video and I see the surgery again in my computer all the time. And I tried to see how did wrong in the surgery. And then the paraclinoid are terrible aneurysms. The rupture are the worst. And then why the patient came to us? The patient came to us most of the time for visual problem. And in that kind of patients, the microsurgery is much better than other treatment like endovascular. For example, this case, I'm not going to show you the angiography of this patient because it's okay. I'm going to show you the visual field. She was blind in the right eye and very, very bad view in the left. And you can see after the surgery, the improvement. Only you can get this with microsurgery. And then the technique, you know the technique, proximal control in the neck. I learned in Brazil, proximal control in the neck or endovascular balloon. But the most important, you need to take out the clinoid. All the time, not all the time, 84%. 16%, you don't need that. And when I start my surgeries, I save the clinoids, all the clinoids of the patients. I stop in the clinoid 400 because the people think that I was crazy in the hospital. And then I stop it. But I have a lot of clinoids because for me it was important. You see, when you take your first clinoid, you never forget. And we did the same surgery from 1999 to 2014. And we start to do a minimal invasive alternative in 2015 because influence of mainly the Japanese surgeons. And why you take the clinoid out? Why? Because it is about anatomy. We take out the clinoid because we want to see better. You see, in the left side, the typical right side arterional view, third nerve, carotid artery, posterior clinoid, superior hypophyseal, optic nerve, carotid aneurysm. Why you take out the clinoid? Because you need to see the whole picture. You need to see the same than the angiography in order to reconstruct the carotid artery. That's very important. You need technology. You need intraoperative angiography. Why? Because we cannot see some things in the surgery. For example, this I clipped this lateral paraclinoid at superior hypophyseal for the left side, but in the ICG showed me the optic nerve irrigation. That's very important technology. You need to have your control with technology. The flow meter, for example, for bypass. You need to do bypass You need to do bypass, but the bypass are not the key. The key is neuroanatomy and microsurgery. In my series, 7% of the paraclinoid I did a bypass, and 16% of all my bypasses are did in paraclinoid. And then you need to be a master in clipping, like when show, for example, the microsurgery that Dr. Evandro did. For example, I have a tape that I take from the laboratory in 1998 with the clipping of Dr. Evandro paraclinoid, and I see all the time again and again, and the technique is the same technique that I use today. You see, I tried to copy him, like Pablo Rubino said. And you need to develop instruments, to develop new clips, to develop appliers, to develop keyhole appliers, to do surgeries, less invasive surgeries. You need to do better clips, improve the clips, like these clips that are made for keyhole surgery. Very important to be involved as a neurosurgeon in the development of instruments. You see, like the endovascular always show the new device, what happened in the future. But I like to live in today. And for today, I need to improve the instruments for the surgeons. For example, these clips are the last clips developed. It's important as well to use concepts. For example, the concept of endoscopy, suction irrigation. I use the concept suction irrigation in my surgeries. I have Japanese instruments for that. They have suction irrigation for microsurgery. And then we can go to less invasive surgeries. For example, to go from the classics for Dolenz or Hakuba approach, to go to less invasive approach, Arterional, for example, that the only difference is the limit in the superior temporal line, but the difference made that the muscle, you don't need to cut the muscle, and you have less atrophy, the patient tolerate much better the surgery. And even you can do a keyhole surgery for much smaller for some kind. You need to be with young people, like Dr. Evandro did. You need to go to people younger than you that have better ideas, have the energy to do the things. For example, Rafa is my fellow from Spain. Now he's in the United States, and we talk a lot about this kind of surgery, that we can do this. This is something that is worth it, or this is a stupid thing what we are doing. And we start to came with these concepts, and we published this in the last year, after just 20 years when I left Dr. Evandro fellow. We start to follow the principles on neuroanatomy. And this is one case I want to show you. This is published. This is a paraclino aneurysm, lateral, superior and lateral. This is the opening, proximal control, the surgery. You see, try to do the best thing. Interfacial dissection that I learned in Brazil. When I went to my hospital in Chile, they do only the classic myofacial approach, and we did this interfacial that I learned with Dr. Evandro in Brazil. And everybody now, all my fellows, more than 30 people in Chile, they did do the same, and we are trying to make it a difference. And this is the surgery. You see the opening. We came with the microscope very, very early in the surgery. This is all did by my fellow. And I learned the technique with drill or without drill. Because when I came to Chile in 1999, we don't have drill in the hospital. And then I can do with rangers or with drill. With any one of the two tools. And then this is the opening that we did. Sorry, this is the opening that we did. And the only difference with the classic is a smaller opening, but the principles are the same. You need to control the bleeding for the cavernous sinus. You need to open the distal dural ring. You need to expose properly the aneurysm. Here is the distal dural ring in the middle of the sac. This is the carotid artery, proximal, distal. Here we are releasing from the arachnoid. You see, and after that the clipping, very safe clip, and after that a second clip and a third clip to have a perfect clipping of the aneurysm. A coagulate, decompress the optic nerve, and after that the closing. We can publish this. And what is important about this? Again, the teaching. the teaching to make the surgery reproducible and competitive with endovascular, for example. And this is one of my fellows. Look at his face. The first clinoid that he take out in this patient that we publish, that make a difference. He loved the surgery now. He want to operate now. He went to a hospital, operate 25 aneurysms in 1 year because he loved the surgery. And we published this year with his help. That make a difference. And then you can try, for example, this. You can treat this kind of cases, terrible. And I said, you need to send to endovascular. No. You need to operate because you need to save the vision of the patient, the optic nerve. The optic nerve is not a peripheral nerve. The optic nerve is like the spinal cord. You need to decompress. And then you see this huge case, and we operate the same follow principles. We follow the same principles. Opening the meningoorbital band, take out the anterior clinoid process, opening the dura. I'm going to skip this because we don't have time. Sorry for extend more, but for me, this is very important. This is my opportunity to say to Dr. Evandro, he made a huge difference in my country with his teachings. And here you can see the optic nerve, you can see the clinoid segment of the carotid, and everything out. Now you open the dura, and you can clip this aneurysm. You can see here the open of the dura. I open the dura very different, just in front of the sylvian fissure. I open the sylvian fissure wide, preserve the veins, decompress the optic nerve, opening the distal dural ring, preserve the ophthalmic artery, and try to reconstruct this terrible aneurysm because we need to decompress the optic nerve of the patient. Here, clinoid segment, ophthalmic artery, distal carotid. So it's a very difficult aneurysm, but follow the principles of fenestrated clips and proximal control and suction decompression. Here we use the suction decompression, the contralateral carotid artery, the decompression of the optic nerve, and the use of fenestrated clips to reconstruct the carotid artery. Here, I'm sorry, I don't know what happened. Here, the reconstruction of the carotid, a lot of clips, preservation of the ophthalmic. This aneurysm had a little portion in the clinoidal segment. There's not a problem for surgery. We can reconstruct anything. Here, the carotid clinoid segment, the ophthalmic artery, and the distal carotid, everything preserved. This is the CT angio of the patient. We can treat rupture ophthalmic, of course. This is not for endovascular. This is a surgery that we can do safely. We need to fight for surgery because the surgery is good. I'm going to skip this because we don't have time, but it's very similar surgery, very similar opening. The clip in the neck of the aneurysm is beautiful. You cure your patient and you decompress the optic nerve. You give two things to your patient. And then this is perfect. The closing is not complicated. And this is the angiosity of the patient that did well. You can go further. And then it's my second paper that we published with Dr. Rhoton. And I was lucky to do this with Marcos Charulo from Argentina, a neurosurgeon who worked with Pablo Rubino. And we made the keyhole surgery. The keyhole surgery is for decompress the optic nerve. We can decompress in meningiomas. We can decompress in this fibrous splash of the bone. A lot of patients are beneficiated for this kind of surgery that I learned because of the neuroanatomy. And we made this with Pablo and Professor Rhoton before he unfortunately passed away. And then we published this paper. This paper talk about the instrumentation that we try to improve, the better clips to do a small surgery. And even we can treat some patients for keyhole in paraclinoid. For example, this aneurysm is small. The endovascular offered to the patient a flow diversion procedure. And then the patient came to me and said, "Doctor, I don't want you to open the head." And I said, no, we're going to make to you a very, very, very minimally invasive surgery, but you don't need double antiaggregation. You don't need this kind of very complicated follow-up with angiography. We can use angio-CT and we decompress your optic nerve. And this kind of aneurysm with the ophthalmic artery from the neck, You can do a very small surgery. This is a surgery you need to follow the same principles of the regular surgery, but you use a keyhole, proximal control, distal control, decompression of the optic nerve. But you need proper instrumentation. The regular clips are not good for this kind of surgery. But you can treat this aneurysm. You can say that this is dangerous. No, the surgery is dangerous when you offer to the patient a greater risk than other treatments. And then we published this as well this year, and with Rafael. And I just want to show you, this is other case, that we follow the neuroanatomy, the same neuroanatomy, temporal dura, frontal dura, periorbita, meningoorbital band. You take out the bone, you take out the clinoid, you see, you open the dura, and after that you can treat the aneurysm. This is not for beginners, of course not. But this surgery we did a lot in my hospital for the compression of other pathologies, mainly meningiomas and other kind of tumors. And there's an alternative, less invasive, good clipping, the patient, very, very small surgery and very fast recovery. And then to finish this, the neurosurgical techniques evolve every day according to necessity to offer less morbidity or better results. The paraclinical aneurysm are one of the best examples. Some techniques are here to stay. Nevertheless, we can modify our master teachings. In my case, Dr. Evandro Oliveira, applying the same safe microsurgery and neuroanatomy philosophy with less invasive concepts. We're inventing nothing. Everything is invented before. The microsurgery is safe, offer better results in optic pathway compromise. The optic nerve is not a peripheral nerve. We must be crystal clear. The key exposure, you see, they diminish the surgery to less invasive, have the goal of being as effective as the classic, but offering the patient a faster and safe recovery. The endovascular techniques evolve, new devices, but the neurosurgery evolve at the same time. New clips, we have new instruments, we have our heroes. We need to follow our heroes. The neurosurgery is not something cold. You need to put a face when you operate a patient. When I operate a patient, one of the faces that came to me, and I said to you in the beginning of my presentation, I feel a little afraid, is Dr. Evandro saying to me, "What? ¿Qué está haciendo Jorge? ¿Qué está haciendo Jorge?" That's the voice of him that I came to my head when I operate. I sent him to everything, because the surgeon I'm today is because of him. And of course, nothing is absolute. This aneurysm I operated in April, my aneurysm 405. And in this case, I did arterional interfacial approach, because doing a minimal invasive surgery is impossible. And I clip it. And I use a lot of clips, but I decompress the optic nerve, and I learn, and I use what I learned.
Mas aí, o sucesso desse tipo de cirurgia não depende.
And then I want to say thank you to my fellows. My fellows are fellows because of Dr. Evandro, because of Gwen, because of Elder, because of Casilda, a lot of good, because Israel, a lot of good people that I knew in Brazil in 1999 and 1998. Thank you very much. I'm sorry to take too much time of you, but I need to say thank you to Dr. Evandro for everything, the good things and the bad things. Thank you.
Thank you so much, Jorge. Mura, just to make you more nervous, he watched all your presentation, okay, the entire presentation.
Okay.
And he seems to be very, very proud of you. You are doing a great job. And certainly you're influencing neurosurgery in Chile as well. So you're doing a great job, okay? He's very proud of you. Be sure of this, okay? Now, the next speaker, I just want to show you guys how big is the influence of Dr. Evandro. He has extending, his influence not only in the brain surgery, but extending downwards towards spine. So then our next speaker is Alberto Capel from São Paulo, former Dr. Rhoton's former fellow, and he's gonna give us his presentation, and also he's gonna tell us a little bit about his relationship with Professor Evandro. Go ahead, Capel. You're muted, Capel. You're muted.
I'm sorry. Okay. So I'm very happy that you are over there with Mateus, with Dr. Evandro, and he's listening. So a warm hug for you, Dr. Evandro, and your family. Probably you know that we are the luckiest neurosurgeons in the world. You, I, and Antonio Mussi, because we maybe not luckiest, but the blessed, because we had Evandro in our residency, and after that at the Beneficência Portuguesa Hospital, and he gave us the unique opportunity, and not more than be with him, but to spend some time with Dr. Rhoton in Gainesville. So let's start it. Okay. So hello, everyone. It's a privilege to be with you in this very special meeting and unique moment. Good morning, friends in Japan, China, and Korea, because it's already Sunday morning over there. I don't know if in Europe they are awake. And good night, friends in Brazil and Americas. So what I do remember most about Dr. Rhoton is his great energy and unstoppable work to make surgery, the neurosurgery, more accurate and safe through the knowledge of anatomy. And he achieved that creating and disseminating an enormous database of microneurosurgical anatomy among over many years and tremendous effort. We know that. I heard that the most that can be achieved in surgery is the practical use of anatomy. I don't know who said first this, but I learned it from Evandro. He used to say that good is not enough, that we have also, and we have always to pursue perfection with a lot of passion, with discipline, commitment, all based in knowledge and blessed hands by God. This is Evandro. So after I finished my training, I went to Dr. Rhoton's lab in Gainesville, and I had the opportunity to spend some time with Dr. Muratani from Japan and Dr. Eduardo Seuani from Argentina. That was me. I didn't have too much white hair, probably because at that time I didn't have an ex-wife. So we had a nice microscope. We didn't have any digital camera at the time, but we did a great job, a good job, I think. And today I'm going to share with you my thoughts about the craniovertebral junction and spinal tumors. And please, the youngest, when you see or heard something about neural anatomy, understand that we are talking about microneurosurgical anatomy. So that means the anatomy that you need to know to get your surgery better. We all know that the craniovertebral junction is an area, a funnel-shaped area between the skull and the cervical spine. Where are located very important neural and vascular structures. So let's apply the anatomy to our surgery. And we know that lower clivus meningiomas or lesions in front of the foramen magnum are a very special challenge for us. Years ago, we had this case and the young resident asked me, can we do it through the nose to endoscopic surgery? I said, it's okay. And he mentioned, it's a straight and no retraction at brain is needed. Okay, there is no brain over there, but it's okay. It's feasible, but let's think about anatomy. To do so, to the front, we have to drill out the anterior arch of C1, and after that, we have to remove the odontoid process. So looking again to anatomy, in this specimen, we remove the lower clivus and open the dura. And after removing the anterior arch of C1 and the medial portion of the lateral mass and the medial portion of the occipital condyles, we will be able to see the odontoid process. And we see some ligaments over there, the apical ligaments and the transverse ligament. So we have to remove the odontoid, the apical ligament, and the alar ligament that runs from the tip of the dens to the medial portion of the occipital condyle. So we have to remove everything. And after that, we will find the transverse ligament. We can remove it through the nose. We can. We should to reach the intradural space. Can we do it? Yes, it's feasible, but maybe it's not the best. And why? Because we need to understand the craniovertebral junction as a joint. And when we see the 3D anatomy of that, we can understand the relationship of the occipital condyles with the superior surface of C1. We can have some flexion and extension movements of this area. And also we can have a lateral flexion, a little bit, and almost nothing of axial rotation. And if we look a little bit down to the C2, we're gonna see the dens and the superior surface of the C2. And this arrangement with C1 is something like a horizontal shape fossa joint. We allowed also extension and flexion movements in this area between C1 and C2. A little bit of lateral flexion. And the most important movement over there is axial rotation, something like 40 degrees. It's half of the movement of the rotation of the arrowheads. And also we can have some movement like this, a translation that doesn't happen because we have the transverse ligament. So if we remove the transverse ligament in our surgery, we're gonna create a huge instability of this region because this ligament put the proper position of the dens related with C1. So maybe in that case, the better approach is a far lateral approach, a transcondylar. And the resident asked me how we do it. And it's not a problem, it's not a big deal, but it will allow us to see the anterior portion of the foramen magnum and doing suboccipital craniotomy and removing the posterior medial part of the condyle. So in that case, we are able to see in the left side the vascular and the neurostructures. So the VA, pons, medulla, the accessory nerve, and we are able to see the tumor. So this approach, we will be able to see more lateral to the accessory nerve. This will create some space, nice space, to achieve a complete resection of the lesion without retraction of the medulla. So this is the pre-op, the post-op. And how we do it, we remove the occipital bone, something like a extension of the retrosigmoid approach, and we have to remove the posteral medial part of the condyle. And where is our landmark? Is the hypoglossal canal. So as soon as we reach the intracranial part of the hypoglossal canal, we already remove 1/3 of the condyle. And usually we don't need to remove any more to have a nice access. Another important thing that I have to show you is about the VA that runs from caudal to cranial, from medial to lateral. And as soon as it crosses the transverse process of C1, it goes down and backwards behind the lateral mass of C1 and over above the posterior arch of C1. So another specimen we can see from caudal to cranial, medial to lateral, crossing the transverse process of C1, go medial, just behind, between the occipital condyle and lateral mass of C1. So it's just in front of you during this approach. So to avoid any lesions of the VA, we need to understand the anatomy of that. And the understanding of the suboccipital muscle triangle will help us. I did this video, this is a VHS in 1997 to Dr. Evandro, I'm sorry about that. Showing that. So this is the right size. We can show the suboccipital triangle, retracting laterally the superior oblique, medially the posterior major hetero, and inferiorly the inferior oblique muscle. And we are able to see the VA. So after that, we can open the transverse process of C1, retract to protect the VA, and we are able to drill the occipital condyle till we find the cortical bone, open it, we will be able to see the venous plexus and the hypoglossal nerve. We open the dura, and we will be able to see a very nice space just in front of the medulla, lateral to accessory nerve. So this is another case, a meningioma of the cranial vertebral junction, foramen magnum. Someone said that there is no need to remove the occipital condyle in this situation, but I learned that it's not always like that, because I can work laterally, not between the rootless, the spinal rootless of the accessory nerve, because sometimes you have a huge tumor, but very hard and very bleedish. So we have, if you can gain some space, it will be better for you and your patient. And how much we can remove the condyle will create some instability over there. Sure not. We did a study on 1997 with fresh specimens. We did a transcondylar approach, and we could see that it creates an increase of the rotation of cranial vertebral junction, but not instability. So you can remove it at all. The posterior 1/3 with not compromise the stability of this region. This is another case. This is a child with a clivus chordoma. In that situation, we try to do anterior approach, endonasal, even though we have extension of behind the dens. We have to remember the anatomy. So a good landmark is the sphenoidal sinus. Just down there, we can reach the lower clivus. We are able to see the tumor over there. We have to remember this is a not very large space. We can see the Stechen tube, and just behind that we have the Rosenmiller faucet with the carotid artery. We already can see the dura. And as soon as you open it, you start to see some neurovascular structures. So the VA In that case, we couldn't remove the final caudal portion. You can see the post-op result. We still have some tumor over there. So we decided to go from the back, like for a lateral approach. You could see the tumor. This is after the first surgery. And after the second, we didn't have any tumor at all. In some cases, we have a huge tumor, so it's not possible to remove it with one approach. In that case, we decided to go from the back because the occipital condyles were already destroyed. So we removed from the back the tumor. We did the occipital cervical fusion, and after that we went from front. And even though we still had a small amount of tumor over there. So we have to apply this anatomy not only to cranial brain, but also to approach spine tumors. So this is a young lady who had paraparesis and low back pain, and we able to see in this MRI a huge lateral schwannoma and not so big in the caudal to cranial. And we decided to do a minimal invasive approach and remove it. The patient did great in the first month. After 2-3 months, he started complaining back pain because we create a huge instability. And why? Even though we did just one level laminectomy, because we didn't respect the anatomy. And we changed the biomechanical, removing the fossa joints in the thoracic lumbar spine transition. So lesson learned, we did after that the correction of this deformity, and 6 months later, she had a nice bone fusion. So we have to apply anatomy and get better day by day. This is cervical meningioma, C71. It's anterior to that. We decide to do anterior approach, but we have to remember that space that we need is very small. Even though if I open and show all the medulla, I cannot touch and retract the medulla. So what we do is with a lumbar Casper retractor, we can remove the hemilamina of C7 and T1 in that case, a little bit of the medial portion of the lateral mass without jeopardize the stability of this region. We will be able to see the medulla, the roots, and the tumor, do our microneurosurgery, respecting the same principles. So this is the pre-op, this is the post-op. With no stability compromise, no deformity. This is another case. This is a very calcified meningioma at the upper thoracic spine, anterior to that. We did the same thing. A hemilaminectomy with a Casper retractor. I remove in this case just one facet joint. This is the pedicle, because we have the keep rage. This is very hard tumor. We couldn't cut it. We had to drill it. And clean it. So I will finish now. We're running out of time, saying a lot of work to do. Let's keep working. And let's keep the Evandro's philosophy with knowledge, pursuing perfection with a lot of passion and discipline and commitment. Thank you so much.
Hey, Capel, that was a wonderful presentation. Very didactic, very nice, really. And so we have reached the end of our session. And I would like to thank Rhoton Society. I would like to thank Professor Kobayashi, Professor Matsushima, and also Juan Carlos, the president of the Rhoton Society meeting. I would like to thank Jenny and also Stanford team, Megan, Ruth, and Jean, and all the speakers, the former fellows, and all the attendees in this meeting. And you all could make our dream come true to make this tribute to Dr. Evandro de Oliveira inside the Rhoton Society meeting. And as you know, we are broadcasting live from his home, his apartment. The guy watched the entire session of Evandro de Oliveira, and he was, as I already mentioned this, but he was very moved. Some tears, he cried a little bit. I have to say, but he was very happy. He is very happy now, very emotional. He's very grateful, very happy for having this tribute to him. And he's very proud of all the achievement you have made in your career and you will make in your career. He's very proud of all of you. And he asked me to thank you guys so much for this. Thank you so much. Hey, Juan, you want to say something? Thank you, guys.
Yes, when I want to thank you in particular for putting this together. You and Mateo, you guys put a great effort, and this means a lot for all of us. Being able to be a bit closer to Evandro now in these difficult times for him it means a lot to all of us, and I hope to him also. So thank you, and all love to Evandro and his family.
Oh, I forget one thing. We have to thank the most important person in this session, which is Professor Evandro de Oliveira. Thank you very much.
Thank you, Professor. Thank you,
Bye-bye.
So I believe we're going to continue live, and we have our next session started at 5. So we have a 30 minutes break now. We can do whatever you guys want. We can go for a break and relax a bit, or we can, you're going to show some more videos of Evandro. That's another option. I also know that we have online perhaps Dr. Morcos. I see him there, and if you want to make any comments while we go for the next session. I saw Mike Rhoton around too. I don't know if he's on or not, but you guys are all welcome to come up and speak.
Well, I had a glass of wine ready to toast Evandro, and that's what I am raising my glass for the king of surgical anatomy. I've said it last year when we did this unforgettable April 2019 session in his honor. Evandro, at some point we run out of words to tell you what you mean to all of us, and but you can see the love and the admiration, and I always thought of Al Rhoton, the king of pure neurosurgical anatomy, and I always thought of you as the king of surgical neuroanatomy. So, and that's how you will always remain in my own memory. Thank you for all your teachings that are both direct and indirect. By teaching some of us and we teach to somebody else, you've touched thousands of neurosurgeons and you've made millions of patients better from what you've done. And the discipline and the love of anatomy and surgical technique. So here's to you, Evandro.
Thanks, Jack. That was great. I have orange juice. I don't know if that counts, but it's a bit early for wine for me.
What do you mean? It's 4:30 on a Saturday, isn't it?
Good point. So I see, Jack, that you are getting ready for a good session with your cup of wine.
Of course.
There you go.
But you should probably take the break, no? Because I assume some people would be following the schedule if you start too early. You don't think of, yeah, right.
I think we should start at 5. So what I'm gonna do, I'm gonna put up a few slides, pictures, and we'll see you guys in at 5. I think for those that are gonna be talking, you wanna test your presentation. I think that will be fine, but it will work fine.
You guys hear me? Mustafa?
Hey, Juan, hearing you.
Jack, how are you? So, you guys ready? We'll start in a couple minutes.
Yeah.
I'll let you guys run the show. You know, I'll be in the background, back and forth, but you, Mustafa, Jax, Mike, I don't know if Mike is around.
Yes,
Mike?
I'm here. I'm here, Juan.
Hey, Mike, how are you? Thanks for joining us.
What's that?
Thanks for joining us.
Yes, of course. Thanks for having me.
This is an exciting session. Dr. Tong, you with us, right?
Yes, thank you.
Very good. You guys know Dr. Tong? Some
Yes.
of you do.
Yes, I know.
You know Mustafa, you know him very well.
Hi,
Yes.
hi, Tong. Dr. Tong.
Thank you. So, yeah, you guys have the order of lectures. You do have it, right?
Yeah, we have.
Do you want to do a brief introduction, any of you? Just say a few words, whatever you do, or we can jump directly into the first talk, which is Dr. Kawashima, who I see him there, who's going to talk about anatomy. Masatsuo, how are you?
Hi, fine, thank you. How are you?
Good to see you.
Thank you very much for having me in this wonderful meeting.
Thank you. Excellent.
Are we ready to go live?
So not yet, Jenny. So Mike, Mustafa, you wanna start? I can make a few words, introduce you very briefly, and then you do whatever you want.
I talk with Mike. I think Mike should start, and Dr. Tong and myself, we take it from there.
Very good. Okay, Jenny, we can go.
Happy to do it.
There you go, Mike. Jenny, we can go live anytime. So good afternoon or good night or good morning, depending on where you are. We have a spectacular panel for this next session on bypass surgery. We're going to have as moderators Mike Rhoton, who needs no introduction. He's world-renowned expert on cerebrovascular surgery. We have Mustafa also, who is also an spectacular surgeon in cerebrovascular surgery. We saw him yesterday. And we have Professor Tong, my dear friend. We worked together in Rhoton lab many years ago, and I've been very impressed with his progression and evolution in cerebrovascular surgery, doing bypass surgery. And I think he's going to share some of his spectacular work with us today. So I'll let you guys take it from here, please.
Thank you, Juan. So I'll just say a few words for this session. It's really great to be here. And Juan, congratulations on organizing a wonderful meeting. This is a great session to follow here. We've got about 3 hours worth of bypass talks. The theme is bypass surgery to boldly go. I want to welcome all of you on behalf of my other co-moderators, Mustafa and Dr. Tong. There's some great speakers in this section talking about the anatomical basis of surgery, the journey from a laboratory training to actually doing these cases in real life. Some talks on revascularization for ischemia, and then some special lectures at the end on instrumentation and innovation. So it really is a great lineup of talks and topics, great lineup of speakers, and I'm really looking forward to moderating this with my co-moderators. And I think with that, I don't want to waste any time. There's too much to learn here, so I'm going to turn the podium over to Dr. Kawashima, who is our first lecturer.
Masatsuo, you're up. Please unmute yourself.
Can you hear me?
Yes, we can hear you.
Oh, okay. Let me start. I'm Dr. Kawashima from Japan. Today, I'd like to talk about the anatomy of cerebral bypass surgery. Let me introduce myself briefly before starting a lecture. I live in Tokyo now. My hospital, IUHW Narita Hospital, is in Narita City, 50 kilometers away from Tokyo. The hospital is near Narita International Airport, which is a kind of entrance to the Tokyo metropolitan area. And this is a teaching hospital, but we will also welcome foreign visitors for one medical treatment in Japan. And I was a fellow at Dr. Rhoton's lab from 2001 to 2003. I studied about anatomy of bypass and distal ACM aneurysm surgery and pineal lesion. I met many fellows from all over the world in the lab. We published several anatomical papers, including anatomy of bypass surgery in international journals. And we also published the bypass textbook, I think about 5 years ago with Dr. Spitzler. This was amazing for me. Just a moment. Now, I'd like to turn your attention to what I'm doing in Japan now. Today, I'd like to talk about 3 bypass procedures in the anterior and posterior circulations because they are most frequently performed in bypass surgeries. So in the anterior circulation, STMCA bypass for Moema patients and high flow bypass are mentioned. And in the posterior circulation, the OA pike bypass is discussed. First, I'd like to mention the STA-MCA bypass, which is a basic procedure for a vascular surgeon. The bypass is performed when you need the blood supply for relatively small area. The STAs are divided into the, just a minute. The STAs are divided into the frontal and parietal branches. The STA is anastomosed, usually to a cortical branch of the MCA or sometimes in the M2 in the sylvian fissure. Let me show you several clinical cases who had STMC bypass. This is a case with Moyamoya disease. Multiple infarctions are seen in the right matter of the brain. The MRA revealed the lack of vessels around the circle of the walls, which is characteristic of the disease. The STA MCA single bypass surgery is performed for the patient. The donor artery STA was harvested, and this is the MCA cortical branch. The STA was connected to the cortical branch of the MCA, and the bypass flow was confirmed by the ICD angiogram intraoperatively. This is the intraoperative video. The STA is harvested and the artery is connected to the cortical branch of the MCA. Bypass flow was confirmed by the ICD angiogram. The bypass flow was confirmed, also detected by the post-operative angiogram. The patient was fine after surgery without any complication. In some cases, when more bypass flow is necessary, the STMCA double anastomosis can be chosen. Let me show you a case. The STAs were harvested from a skin flap, and one STA was anastomosed to the frontal lobe and the other to the temporal lobe, like this. And the cortical surface was covered by the temporal muscle, expecting blood supply from muscle also. And this is very interesting case with Mohamed disease. The patient once had an indirect bypass surgery, but cerebral ischemia didn't improve. So she got finally a direct bypass 3 years after the first operation. This is a dura mater which contains the STA in the fibrous tissue. So the ST was carefully explored and harvested and anastomosed to the MCA like this. This is a very tiny vessel. Okay. Second, I've covered the high flow bypass of the anterior circulation. This bypass is performed when you need the blood supply for large area. Usually the radial artery is used as a graft. The recipient artery is a temporal branch of the MCA. The graft is placed between the M2 and external carotid artery in the cervical region. Let me show you a case with subarachnoid hemorrhage treated using the high flow bypass. He had a blister-like aneurysm here on the left carotid artery. The normal clipping surgery seemed to be very difficult, so we planned to do a left ICA trapping and high flow bypass surgery for the patient. First, the STMC double bypasses were established and confirmed the blood flow. And this is the M2 temporal branch. It was exposed in the syllabian fissure. This is the airway graft, and the graft, one side of the graft, airway graft, was connected to the M2 temporal branch here in the syllabian fissure. And the bypass flow was intact, confirmed by the ICG angiogram. And the other side of the graft was anastomosed to the external carotid artery, and the cervical ICU was occluded. This is the left arterional approach. This is the distal ICA, and this is the optic nerve left side here, and this is the aneurysm around here. Then the distal ICA was occluded just proximal to the posterior communicating artery. Here you can see. And this is the final view. And the post-operative course was uneventful. The left ICA was completely occluded, and all bypasses, including high flow and low flow, they are all intact. The patient was fine after surgery without any complication. Last, I'd like to talk about the posterior circulation bypass, the OA pike bypass. In the OA bypass surgery, there are 3 steps to complete the procedure, I think. First, you have to harvest the OA in the occipital muscles, then to connect the OA to the pica, and finally, to make a perfect duroplasty, preventing the postoperative CSF leakage. In the surgery, the donor artery is an occipital artery. the OA is divided into the two portions, horizontal and ascending. The average diameter of the OA is around approximately 2 millimeters. The OA travels between the splenic capitis muscle and semisplenic capitis muscle on the suboccipital triangle toward the mastoid glue, like this. And the OA is usually connected to the caudal loop of the pica here. So we need a wide operative field in the procedure. So we use the transcranial fossa approach, which includes the drilling of the posterior part of the jugular tubercle, and to get the wide operative field in the lateral part of the cerebellomedullary system. And in addition, opening of the cerebellomedullary fissure is also an important technique. The fissure is a kind of an adhesive structure between cerebellum and medulla oblongata. By opening the CMF widely from oblique to the lateral recess, the easy and safe retraction of the cerebellum can be achieved, I think. Let me show you a last case. This case is a subarachnoid hemorrhage patient with a ruptured left BA dissecting aneurysm. The aneurysm also involved the origin of the left pica here. So this is the surgical simulation image. We plan to operate VA tapping, left VA tapping, and OA bypass here. In this case, the left cerebellomedullary fissure was opened widely, making the cerebellar retraction easy. This is the intraoperative video. The patient was placed in the prone position like this, and this is OA. OA was harvested intact, and the left cerebellomedullary fissure was opened widely to make an easy retraction of the cerebellum. This is the caudal loop of the pica was exposed. Please pay attention to that. No spatula was placed on the cerebellum, and wide operative field was available without retraction of the cerebellum. The OA pica anastomosis was completed easily, and the proximal left BA and pica were occluded using titanium clips. The bypass flow was confirmed with ICG angiogram intraoperatively. The light over here is was anastomosis to the right pica caudal loop, and the BA aneurysm was thrombosed. No infarction was seen in the right pica territory. So in summary, before performing the bypass surgery, you should think which bypass is necessary, considering the area of blood supply needed and the level of surgery. And also it is important to do an accurate bypass procedure, proper preparation of donor, recipient, and graft vessels, and correct anastomosis between them are necessary. And when you do surgery in the posterior fossa, it's important to change a narrow and deep operative field into a wide and shallow one. This applies not only vascular surgery, but also the tumor surgery in the posterior fossa. So to accomplish it, a precise knowledge of anatomy and accurate surgical procedures are necessary. That's all. Thank you very much for your attention.
Thanks, Mastuo. That was great. So, Mustafa, I think you're next.
Okay. Good evening, Juan. Thank you very much, and congratulations on this wonderful meeting. And dear Mike and Dr. Tong, my co-moderators, and all the distinguished speakers and the participants, good evening, good afternoon, or good morning, wherever you are, or if you are sleeping, sweet dreams. So I was going to talk about the difficult cases, but then Juan asked me to cover the lab training. So I'll try to do both in 25-30 minutes. I have no disclosures other than loving neurosurgery, microsurgery, and practice. This slides, I think, summarize everything about the neurosurgery, and in particular bypass surgery, microvascular surgery. This is at Barrow, and I saw Mike practicing there and helping the participants, and I also sat down and tried my best. So this is the lab, this is the office microscope I have in my office, and I try to use if I have time. And the main thing is practicing in the lab and then going to the OR. And this is the curriculum we have here at the University of Wisconsin Medicine for residents, fellows, and international trainees. So I suggest all my residents or fellows to do this at least 3 times during their residency or during their stay, so they get better and better every time. The first step is the Penrose suturing, mimicking the arteriotomy closure in carotid endarterectomy. Starts with the 6-0, and then they go to the 7-0. Every time it's 6 centimeter length, and every time they note the time and they record their video, and we score this. And you see that one of the trainees first practice with the 6-0 and then the last practice with 7-0. There's a big difference between two. So you get better as you practice, as obvious. And the second step, doing the fake vessels, and we also a system model we can use, try to simulate the real-time surgery with the pumps and other things. And this is end-to-end, end-to-site with the 8-0, 9-0, and 10-0 practices, exercises. And then after the fake vessels, they go to the chicken tie with the end-to-end, end-to-site, side-to-site anastomosis with 10-0 nylons. And they complete this, and then we score them. And if they pass, they go to the next level, which is the red femoral artery, carotid artery, end-to-end, end-to-site, side-to-site anastomosis with 10-0 nylons. And then again, they record these, and I score. But believe it or not, other than many international trainees, residents don't have interest in these anymore. And they used to do more and more. Now it's just, we ask them to do, but not many of them, unfortunately, go to the lab and do this. And then there's also alternative practice methods. If you are in the operating room every day, you can use the operating room as a practice, but we also try to develop the practice models for the people who cannot access to animals or other high-tech stuff. So we have a grapefruit model, and we stimulate the side-to-side A3 bypass. This is recently published in World Neurosurgery. You can watch the videos on this. This is a nice, neat model. Ulash, one of my fellows, came up with this model, and we developed this as grapefruit. It looks like basically a frontal interhemispheric area, and then you dissect that, and then anastomose the fake vessels side to side. And there's also this method I learned when I was in Japan, a fellow with Dr. Sugita, suturing the gauze, and this is very easy, cheap way of doing it. And this is first thing they asked me to do when I went to Nagoya as a fellow. And then this is my dear friend Junichi Yamamoto from Albany, and he came up with this his wife's cake maker, and then you can go deeper and deeper, and then the practice the deep anastomosis and then there also for residents, fellows, opportunities during the lab, during the surgery, after the main bypass is done, they can use EDAS part, suturing with the 8O, 9O, or 10O, performing these dissections and suturing before they go do the real practice in the anastomosis. And as you guys know, Yashar introduced this closure of the arachnoid in Sylvian fissure or the cisterna magna. And this is the recent case of the brainstem cavernoma. We operated, and I asked my fellows to and the chief resident go there and practice the 10O suturing. Is a deep field, is nice practice, is not harmful, and is good time to do something for the chief resident or residents or the fellows. So there are many things you can do. You can go to the lab and clean the P arachnoid of the cadaveric head, and these are all practices. Or you can do surgery in insular glioma, and that's also microsurgery. That will help you to perform also bypass surgery. And then now the next part of my talk, indications for bypass and some difficult cases I would like to show you. Now is today we are in the endovascular era, and we do less and less neurovascular cases, open surgery, and it becomes hard to keep up with your skills. But if you do intracranial microsurgery, believe me, eventually it pays off. You don't need to do 10,000 bypass. You don't need to do 10,000 clipping. If you do GBM, the way you're going to do AVMs is microsurgery. Why we do the indications for bypass? Flow augmentation, flow replacement, and prophylactic or protective prophylactic. And there are so many ways of doing it. Mike is championing doing the inside to bypass and others, and everybody had come up with something else. So whatever you do, you just need to be aware. There are many bypass conduits hasn't been taught about it. So how I do my bypass, I learned this from when I first went to Helsinki live course from Rokia. I start STA harvest with under the microscope. It's more efficient, more clean, very dry, and I use very low intensity Colorado tip, micro tip electrocautery. It dries it and it helps you to dissect, and it gives you very bloodless dry field, and you see better, and your graft, a superficial temporal artery graft, remains healthy at the end of the harvest. Sharp dissection, blunt dissection, whatever works, but eventually you get the clean, nice STA. So, and then next step is doing all these steps. I always like to start with the aspirin, at least 81 milligram baby aspirin 1 week before surgery for elective cases. If it is emergency, I will give them right before the surgery. And I always give before the temporary clipping 1,500 to 3,000 unit IV heparin, depend on the patient's weight. Continuous IV irrigation with the heparin, and covering all the vessels with the warm nitrite, sodium nitroperoxide soaked gel forms. Perfect adventisectomy. Try avoiding the pinching or squeezing the vessels, and I like to use interrupted sutures except side-to-side suturing. And we have this Wisconsin broth invented by the vascular cardiovascular PA, who did like 20,000, some crazy number of vessel harvesting. So we use patients' own blood. We don't avoid blood, and I don't distant any vessel with any irrigation or anything like that. So a couple of examples. First, straightforward examples: Moyamoya disease. Dr. Kawashima showed nice cases. I don't need to go over the indications. In Moyamoya, I learned in Japan, I like to do at least a direct bypass if feasible, and EDAS combined with the EDAS, and then also I do frontal burr hole in cases that I suspect anterior cerebral ischemia or low perfusion with the pedicle pericranium. And this is a case who is actually Japanese, who had the surgery when she was a child, moved to United States, presented with basal ganglia hemorrhage, and this case is published somewhere. First, the direct bypass, and then EDAS with the parietal branch. And EDAS, the way I do, I put sutures into P arachnoid and tuck to the branch to the brain cortex, and also suture to the dura, that parietal branch. And good results, and she's been doing very well. Cerebral ischemia, same way. In cerebral ischemia, depends on the perfusion studies and the patient symptomatology. I like to do double barrel bypass, and this is the one case I always map, so this is the case. I'm going to show you. I use two branches at the end. It's going to look like this. For time purposes, I'm just jumping this. And parietal branch and frontal branch, and this patient has been treated with multiple treatment modalities and kept having the symptoms, and after the bypass, no TIAs and only on aspirin, and she's been living symptom-free at age 75. And these are the rare cases, and this is the 62-year-old woman with previous carotid endarterectomy, rest stenosis, stenting, and finally occludes and gets stroke, and then continues to have TIAs with the low pressure or exertion and significant perfusion deficits in the left hemisphere, in spite of multiple trials of the medical treatments. And if you look at the dynamic studies from the contralateral injection or the STA or the CTA, there's really no internal carotid artery, common carotid artery, or external carotid artery. Nothing you can find. There's no filling of the STA from the contralateral side, no post-auricular arteries. And this patient is severely symptomatic. Anytime she sits up or try to bulk, she gets symptoms. So what are we going to do? What kind of options we have? You can do vertebral artery to MCA, or so-called bone bypass introduced by Dr. Spetzler in 1980. So bicoronal incision, harvesting preparing the contralateral STA, simultaneously vascular team gets the endoscopic harvesting of the saphenous vein. Difficulty in this, it's not technically challenging case, but is mentally challenging. You have to go over every single level, every single step in your mind, because it's tough to estimate, number one, the true length of the graft you need, and you have to create a groove on the frontal bone, and then you have to perform the proximal bypass first, contrary to the other bypasses we do. And this is, again, is a good example, is good practice cases for the fellows, is there's no ischemia time, and very atherosclerotic STA, you see, you have to get all the layers, and since there's no time concern for ischemia, with ATO sutures, fellows or the chief residents can perform safely if they are good enough for this. Once it's done, you backfill the STA, you create a groove in the bone and tag the saphenous vein, check the back bleed, and then you are ready. But this brings also risk for air embolism if you don't get the air out before open. And you don't need fish mounting for the saphenous vein. and to overcome the mismatch, you make a long arteriotomy in the recipient MCA and perform the bypass. Then once the bypass is done, you take everything and you need to check the, you need to get the air out. So you have to make a small opening in the vein and then take the clips and get the air out. And then you have to close that with the also suturing. This is her bypass, and she's been symptom-free 2.5 years only on aspirin, and the bypass remains patent. So, and another area is the iatrogenic injuries. As you know, this is a 70-year-old man with this is his third surgery at outside hospital for recurrent residual tuberculous meningioma. When they are removing the tumor, they experience a profound, severe bleeding from in the field. They throw the gel foams and close the case. There's an infarct in the ACA territory, also pseudoaneurysm. They transfer him to us, and pseudoaneurysm is growing. Question about doing the covered stents, flow diverters, I think is the you can get by with sometimes, but is the most of the time I think you need a definitive treatment, which is a trapping and the bypass, and that's what we did radial artery graft and the trapping, and he was in DI, and we stabilized him post-op day 3, post-op 2 months, and now we are in the endovascular era, and this is the case done by one of my partners, ruptured ACOM aneurysm. He clips the aneurysm, patient develops a severe vasospasm, and he takes the patient to hybrid OR, performs the angioplasty. During the angioplasty, he realizes extravasation of the blood, and he called me immediately. So luckily, we are in the hybrid OR, everything is ready. We turn endovascular case to do open surgery. And luckily, again, he wanted to take this with balloon or coils occluded completely. I said, just wait it until I get there. And he opened until I get there. Of course, it's chaotic. We couldn't record the entire video, but there was a couple of millimeter tear in the distal M1. So I was able to control the bleeding and put 3 and 10 nylon sutures, and so this is not a bypass, but is like a bypass. It's life-saving procedure, especially if you are in the hybrid angio suite, hybrid OR. This is the perfect case, and we used that, and it worked out very well. And believe it or not, patient did well. And in aneurysms, yes, clipping, coiling, flow diverters, but we'll still need a bypass procedure. This is a 62-year-old woman, 2 sessions, each session 12 hours, 24 hours, 3 endovascular guys, excellent endovascular surgeons, try to flow divert this aneurysm, and every time they failed. And this is my poor drawing and writing explaining patient what we are going to do. So since she failed, and this is a fusiform aneurysm, giant aneurysm of the posterior communicating artery segment of the ICA, and so I offer her a bypass trapping, and that's what we did. As we first expose the aneurysm, expose the Sylvian fissure, find the recipient artery, atherosclerotic vessels, perform the bypass first from radial artery to M2, and then after the bypass, we will explore the aneurysm, and you need anterior clinoidectomy in this case. If possible, I like to trap before the distal to the ophthalmic artery to preserve the ophthalmic artery flow. And then the last trapping clip should go proximal to the anterior choroidal artery. And again, high bifurcation. Our vascular, peripheral vascular colleagues use these vascular punches. They are very useful, makes a very good arteriotomy, but this patient is quite atherosclerotic, didn't do a good job. I'm extending that hole and making almost elliptic. And sometimes in this common carotid or external carotid in elderly atherosclerotic patients, 8-0 doesn't work. You may need to use 7-0 or 8-0 with the big needles because it's very hard to pierce the artery wall. And that's done. And now we are going to perform the extradural clinoidectomy, which I feel more comfortable doing in these cases, and then go intradural, cutting the falciform ligament and exposing the ICA distal to the ophthalmic artery. Once the ICA is exposed, now we are ready to take the temporal clip from the ICA in the neck and move to the head and place the temporal clipping on the ICA. And clipping the PCOM. PCOM is luckily is not fetal configuration. Clipping the ICA distal 2, bypass is working. Now it's time to decompress the aneurysm. Aneurysm bleeds, looks like bleeding, but I think it's trapped vessel and patient had severe optic nerve compression. So I just decompressed to open the aneurysm and this is the results. And she's been doing very well. And fusiform aneurysms, this is a 10-year-old proximal pericallosal aneurysm, and pericallosal artery comes out very small. So what are the options here? There's no endovascular options. Don't even think about it. Reconstruction, clip reconstruction is not possible. Simple trapping, maybe, but we did the dynamic angio, posterior circulation. There is no good posterior pericallosals filling the. So it's very likely he's going to fail, but we'll defer that to the surgery. And if we do bypass trapping, A3, but see the distance between two, or STA to A3 bypass with interposition graft with either radial artery or saphenous vein. We studied this well, and we prepared the leg, arms, everything, and plastic surgeons, everybody's on board for this 10-year-old, and we extensively dissect these STA branches. Then it went interhemispheric, expose the aneurysm first, try to do the A3 bypass, or at least see is it feasible. You see the difference. I dissect these branches many times. It's no way I could bring the together. And then I put the temporary clip and I do the ICG green, not simultaneous flow. So simple trapping is not possible. And we measure before, during the surgery, 18 centimeter interposition graft we need. And plastic surgeons start harvesting the graft. And while I'm getting the proximal control, and once we clean, we realize there were several holes in the radial artery, and it turned out to be radial artery is only 12 centimeters. In spite of all these calculations and the pre-op and intra-op evaluations. So we decide to first do the bypass and then mobilize the frontal branch so I can overcome the short interposition graft, but there's a big size mismatch. And we use the dilators, plastic surgeons, microvascular surgeons use in spite of that. So I did this tapering technique of oblique cut and making the radial artery smaller. So it fits like this here, you see. So ICG green work, and he did very well. Post-op day 3, post-op angiogram showing the filling of the A3 from the bypass interposition graft. He's back to school. He's happy, no headaches. All the swelling is gone from the thrombosed aneurysm. This is a recent case of the fusiform aneurysm, 70-year-old, no subarachnoid hemorrhage, multiple dysplastic vessels, and a large ACOM and large near giant size distal MCA aneurysm. So if you study the angiography well, one artery comes here, goes under, another artery comes here, and then I try to locate the angular artery at surgery, and I found it, and it's very deep and distal part of the fissure. So first I did the bypass with the STA, parietal branch, to do this angular artery. That's done. And then I exposed the aneurysm. And when aneurysm exposed, I realized there is no way I can get inside to bypass and something else with this branch. So I trapped this branch, but luckily I create a space here. I put another clip here, and then I put the angle fenestrated clip to fenestrate the other branch like this. So this is the area I thought I can put the clip. This branch is trapped, that's the angular artery, and I'm creating a space, and this clip looks good, excluding the aneurysm, angular branch here, and the bypass is done on that branch and looks good here. And then we go to this artery, see, is coming from the this fusiform dilatation of the artery, part of the aneurysm, fenestrating that, and that worked very well. And this is post-op day 1. Bypass is working, no stroke, and you see the bypass, and we exclude the aneurysm and also clip the ACOM aneurysm. This is another recent case, morbidly obese, grade 5 subarachnoid hemorrhage from the pica dissecting aneurysm, and it's hardest ever case I have done. Many reasons: very steep posterior fossa, very thick bone. It took us 3 hours to do craniotomy, because once we did the posterior fossa craniotomy, this steep angle didn't allow us to do any dissection. So I have to take this entire bone, nuchal line, make it flat to get the view. And then another difficulty was, look at the pica loops, how high they are. My initial idea, if I can, I would like to pica bypass. If not, occipital artery pica bypass, but due to the morbid obesity, there's no way I could find the occipital artery. Then we already prepared the leg and the arm. We went for the radial artery, but once it's exposed, you'll see there's no way I can do the radial artery. I had to resect the tonsil, ipsilateral tonsil, find this ipsilateral pica. And there's retractor there, it's very steep. And while I'm preparing for this, a million people watching, and the plastic surgeon says, radial artery was perfect. Right before the harvest, it got thrombosed. What are we gonna do now? Luckily, I knew we can use the cephalic vein, and I think it's published before. And we harvested from the same exposure the cephalic vein, and we did the cephalic vein. Is huge vein, you see, V3 to pica, and then they trapped the aneurysm. And he was grade 5. Everybody gave up on him, but me. And 6 weeks, 3 months, 8 months, and he's still improving, and robust bypass. Mycotic aneurysm is the same story as submillimetric vessels. You can do inside to bypass here. This case is published. You can watch too. It's very small arteries. We found an en passant artery parallel to the. So we did the end to end and end to side, inside to bypass, and get rid of this dominant hemisphere M3 mycotic aneurysm. Traumatic aneurysm is the same story. Don't put any stents in these. They don't work. And you can do double barrel bypass, juvenile rheumatoid arthritis, suicide attempt, and depression. And now his bypass is working due to frontal lobotomy bilaterally. He's not depressed anymore, happily living. And blister aneurysm, same story. Blister aneurysm to me is the bypass therapy case. I'm stopping. And if this happens, just keep calm. And sometimes there are blister aneurysm in different various types. So you have to trap it, or you can do bypass prophylactically and then explore the aneurysm. And if you can clip reconstruct with restenosing the artery, you can do that too. That's what we did here. And it's 80% of, maybe 70% of the lumen stenose, but it's patent, it's grade 2 subarachnoid hemorrhage. We didn't give up on the artery, and good results. Skull-based tumor, same thing. You can do these with the bypass, radial artery first, and then the cavernous sinus exenteration in 3 stages. This patient had 6 surgeries, multiple radiation, many experimental therapies for grade 2 radiation-induced meningioma. And in conclusion, go to the lab, start in the lab, mentally prepared. You have multiple backup plans. There are many ways of doing the bypass procedures. Learn from the other disciplines like peripheral vascular, cardiac vascular, or ENT colleagues, plastic surgery colleagues, and go to lab. I forget, I see, I remember, I do, I understand. Go listen. I still watch, and I will still learn. And today I'm going to learn from the other masters. Thank you very much.
Great talk, Mustafa, as always. I'm curious, when you take your residents to the lab and you score their performance on their drills, what scale are you using?
I use 1 to 10. It's just very subjective. It's only me. And I don't go to lab. I ask them to record. And then mostly my international fellows do that. The residents don't do anymore. Last few years, I have 1 or 2, just scarce number of residents doing it.
And if you have a chief resident or a real proficient resident who wants to do his first bypasses as a resident, what do you use as your criteria to allow them to take that leap?
Or just, again, very subjective. You know from the beginning who can do, who cannot do. So it's starting. I start picking them on the PGY 5, 6, and then when they became chief, I check it. But tell you the truth, I'm hesitant to let them do STA MCA bypass. If they are very good in last few years, I let them do a high flow bypasses, proximal anastomosis. And not more than that, unfortunately.
Yeah. And last question, the bonnet bypass, you're one of the few that seems to be continuing to do that and enjoying it. Do you really like that bypass, or
I love it.
Yeah.
I've done 3, probably by now, I've done more than Dr. Spessler. I don't know how many he has done.
I think he did 2, just so that he could say he can publish them.
I did 3, and it works very well. All 3 are working nicely.
Excellent. Any of the other panelists have any questions for Mustafa?
I would just add, Mike, that and Mustafa, that the lack of lab training by our residents extends to also surgical neuroanatomy. There are very few that really are committed to go and train, and that's, you cannot, they've always asked me, why don't you put a mandatory course? I don't think that works. It has to come from them. There has to be commitment and willingness for them to do those things.
100%. So we have a new lab, and it's cadaveric lab, and they can do this anastomosis. We have permission for animal surgery too, and only few goes there. Out of 14, maybe 1 or 2. It's very sad.
Yeah, for all the young neurosurgeons and residents watching, I think it's important that we on the faculty side of this equation like to see that, and it certainly goes a long way in convincing us that you're ready to do those on the patients.
Absolutely.
All right, I think we're a little ahead of schedule, but our next speaker is one who consumes time when he talks. So it's probably a good thing that we continue on with Professor Marcos. Jacques, you want to take this away?
I'm taking it away. I actually paid Mustafa to finish earlier. I didn't tell him jumble all your words along the way, but anyway, thank you for finishing so early.
And Jacques, that doesn't mean you get to use all of his extra time.
Yeah, I know. I'll do my best. You know, we all have something in common on this panel, the passion for what we do, correct? So, and that's what we'd like to communicate to those who are.
When you say passion with that accent, it means something different than the rest of us.
Oh, okay. Well, let me get going then before this conversation goes elsewhere. Okay. Well, bypass for cerebral ischemia. And well, first of all, Juan, as I told you before, congratulations on a spectacular program that's still not even halfway.
Thanks. By the way, let me interrupt you. The title of this session is actually Jack's title. So thank you for that. He helped me put all this together.
Okay, so I'm going to talk about ischemia. I'm going to try to show at least our audience how bypass is both art and science as well. Disclosures, like a cogent, but two other very important disclosures. I'm a huge admirer of Rhoton, and I am a little bit addicted to math and physics. So you'll understand what I'm going to talk about. I'm going to try the outline, physiology of ischemia, little math and physics and CFD of bypasses, surgical principles and techniques based on that math and physics, very quick surgical results and very quick work in progress. Physiology. Well, this has been known for a long time. Oxygen extraction fraction that goes up in the stage 2 ischemia, the interplay between CBF, CMRO2, and OEF. Stage 1 autoregulatory vasodilation, you can see in the right graph what happens to CBV, CBF, OEF in stage 1, and it's only in stage 2 that OEF will go up, as you can see here. The cost study, I'm not going to go over it. You know, it was negative for bypass. We've published kind of a semi-rebuttal when it came out with criticisms. Absolutely no time to go over any of that. But I just want to remind you that of the Kaplan-Meier curves of the cost results, they began to cross right here. By contradistinction, the Sampras intracranial stent study, the curves never crossed, meaning surgical morbidity was the reason why cost didn't seem to work, while intracranial stenting, it was both surgical morbidity and lack of effectiveness. Nobody is arguing that bypass for ischemia cannot lead to improvement. The problem is, can you do it with low enough morbidity? Grubb himself said, had the surgical M&M been 8% instead of 15%, cost would have been a positive study in favor of surgery. Luckily, the Chinese did not listen to the cost investigators, and they have their own CMOS study going on, the results of which I'm not aware of. Okay, bypass for ischemia. Let's get you a little bit, a touch of math and physics. We're going to be thanking Pythagoras and his geometry friends for making us understand how to fashion the bypass conduits. We have to, of course, thank Bernoulli. So what is Bernoulli's equation? Very simply stated, it's pressure plus kinetic energy of flow plus potential energy. They remain constant, meaning if you have a conduit that is narrowed here, meaning velocity goes up, meaning kinetic energy goes up, the pressure must go down. And you all know this principle. It's a little more complicated than that, but that's certainly good enough for our purposes. And in a conduit like this, where there is a hydrostatic change, that also gets into the as a factor. What is Hagen-Poiseuille's law? Well, that has everything to do with viscosity and friction in the wall of the vessel, and that's the equation. And what makes the resistance higher? The longer the conduit, the more viscosity, and inversely proportional to the 4th power of R. That's the resistance that will determine the interplay between flow rate and the delta P. And of course, you can see the exquisite effect of R in this curve on the right on the relative flow. I'm going to come back at the end of the talk, a little an analogy between Poiseuille's law and Ohm's law in electricity and resistors and so forth. It's very similar concept. This was actually Poiseuille's setup in 1846, through which he devised or discovered, I guess, the law. Flow dynamics, of course, very complicated topic, and I certainly don't claim to understand it at all, but it is based on essentially continuity equations and momentum equations, and that determines everything else. If we could understand it and predict it, we would understand how to construct the absolutely perfect bypass every time. To solve this, you have to solve 3 things: fundamental principles, conservation of mass, Newton's second law, conservation of energy. What can we as surgeons, what do we control when we make a bypass? We do not control really blood rheology or morphology of donor surface. We only control the geometry of the bypass and the donor to recipient diameter ratio. So what are causes of failure when we do a bypass? Well, surgical injury, compliance mismatch between donor and recipient. And this is the next 2 lines are very important. If you have too large of a donor, you will achieve low wall shear stress and intimal thickening. If you have too small of a donor, and when I say too large and too small, I mean relative to the recipient, then you will get high wall shear stress and endothelial injury. These 2 extremes are both bad. We need to achieve or try to achieve a relatively physiologic range of wall shear stress. Wall shear stress, let me change this a little. Wall shear stress is inversely proportional to D3, but if you don't want to think of it in mathematical terms, it's velocity of blood times viscosity divided by vessel diameter, not in those power, it's D3. When we do a bypass, we have to think of the toe, the heel, and regarding wall shear stress, you have to think of the floor at the recipient and the angle at which you construct it. So for example, 25-degree angle in this model here, this angle here, much better than 60-degree. Look at that, much less turbulence than here. Look at that in a more colored way, comparing 45-degree angles end to side with 25-degree, much less turbulence at the 25-degree. Particularly look at the toe area of the bypass and look at the floor of the recipient. So the take-home message from those couple of studies I showed you, the smaller the angle results in less turbulence, less stagnation, more physiologic wall shear stress ranges. This study looked at different angles of bypass end to side, 25, 45, 60, and different diameters of donor, with the donor being smaller or equal or larger than the recipient. They analyzed all these very important factors. And again, I'm not going to bore you to death with the math of it, but just a visual of what it showed. Essentially, the left column is a smaller donor, the middle column is when they're equal, the right column is when it is larger, and there is a distinct, and again, without going into the second graph, the take-home message from that is laminar flow is less at the floor of the recipient when you have a smaller donor. The stagnation point, which is bad to have because that will create thrombosis, shifts proximally the wider the donor up to a limit. The OSI increases with a small angle and a larger donor, and wall shear stress, both spatially and temporally, the variation on wall shear stress is maximal at the floor and the toe. And it decreases with a smaller angle and larger donor. So the take-home message, low wall shear stress is bad, high wall shear stress is bad, the vessels will always try to adapt eventually to achieve as near physiologic wall shear stress as it can. The stagnation point shift is a good thing, and it occurs more at 25 degree of a bypass, for example, than a 45 or a 60. So the lower the angle, the higher the diameter ratio up to a point improves wall shear stress and the other factors. And this is very interesting. This is bypasses followed over time and calculating wall shear stress. The vessel seems to want to achieve physiologic wall shear stress eventually, even though at the beginning, after you construct the bypass, it could be very high or it could be very low. That seems to be, I'm not going to call it a constant of nature, but certainly a biologic constant that our vessels love to do. Another study showing the same thing, I'll skip that. Surgical principles and techniques. Well, we all know the Rhoton rules of 3 for posterior fossa anatomy. So when I thought of this many years ago about bypasses, I realized it is a rule of 3 for bypasses, in the sense that you have to plan, execute, and verify what you have done. Planning comes in 3 categories, and each one of those categories is divided into 3s. Execution is the same. Verification of flow is the same. You can categorize bypasses into 5 types based on number of anastomoses and types of donors. Any bypass, simple or complex, we can fit it in any of these cells. They all have different names, but the principle is the same. To echo what Mustafa has said, it's very important to understand your instrumentation, your position. Going now back to physics, you need to understand that your instruments are levers, and the amount of force you put in your fingers, how it transmits to the tip of the instrument, and how different, for example, it is to suture with a forceps versus a needle holder. Just basic physics will show you all the equations you need to know. This is the difference between a class 1, so-called class 1A, and a class 3 lever. So we talked about the geometry. Well, what are the 3 geometries? End to side, thanking Pythagoras, if you fish mouth by the diameter of the vessel, of the donor, you will quadruple the cross-sectional area. That's where the power of fish mouthing is. Now, of course, it comes at the cost of doubling the length of the anastomosis. When you do end-to-end, whenever possible, you want to achieve the same principle by obliquing your cut rather than doing a 90 degree to 90 degree. And of course, side to side, you have to know how to do a running suture. All the others, or the other 2 I've shown you, you certainly can do simply interrupted, but here you must master the technique of running the back wall. And these are the usual sites for side-to-side bypass. Where do you place your arteriotomy in a side-to-side? At least bypass, the way I do it, where it's in red, meaning you don't want to do the arteriotomy on top of both vessels, even though it's the best view, but it's the worst apposition. You don't want to do it where it's the best apposition, but the worst view. I choose, I split the difference and do it in between. You can call it 130, then 30. Quick examples. I'm going to go quickly on this. Our 2 previous speakers have shown examples. This is Moya Moya, but just to show you the principles of what we're doing, it's important to measure vasomotor reactivity. We do it in Miami here at our center with transcranial Doppler, with this formula, and this woman who actually is a neurology stroke nurse, very poor VMR on both sides. This is many years ago. We did SPECT with Diamox. Now we do CT perfusion or MI perfusion. This is an example of a double barrel bypass, taking both vessels to do measuring flow. I am absolutely a believer of quantitation. You need to measure flow. This is a flow meter in cc per minute, not centimeter per second. This is cc per minute. You measure the flow of the recipient. You do your bypass, you measure the flow when you finish, and I've collected all this data for the last 20 years now. And my current fellow, Nicholas Khan, is actually helped me analyze all this as we speak. So this is the flow at the end, and you examine how does it split, antegrade, retrograde, and so forth. We did the first side, and I brought her back a few weeks later and did the other side. And then I did the angiogram. So that's your kind of poster child of bilateral moya-moya bypasses. Atherosclerotic ischemia, more controversial, but properly selected patients absolutely benefit. This is a man who was having daily TIAs. He was 76, carotid artery occlusion. You can see that. We studied him physiologically. We established that he has misery perfusion. His VMR was 19%. In the other hemisphere, it was 55%. Did a bypass, has not had a single TIA till he died 10 years later at 86 from a heart attack. Here he was early post-op. What are my surgical results with bypasses for moya-moya and ischemia? I'd like to thank my residents, my partner Bobby Stark, who did the statistics, and my current fellow who's updating the series, Nick Khan, who came to me from Memphis. We studied in over a period of 10 years, 105 anastomoses. Interestingly, the cost did not drop my referral volume. It actually, because we have smart neurologists who understand the limitations, I got referred more cases after costs than even before. I looked at moya-moya and analyzed intra-op flow data. My bypasses, I had only 1 out of 105 acute occlusions during surgery, but long-term, 10% occluded up to 603 days. When I analyzed the cut flow index that Charbel published, I could not replicate his findings, meaning the CFI did not seem to correlate with the delayed occlusion. I don't know why. I don't know what's different between our two series, but important to note, occlusions tend to be asymptomatic. I looked at the moya-moya data as well. This is a Kaplan-Meier of the patency rate. Again, same thing, about 10% delayed occlusion, no correlation with the cut flow index, and all of those occlusions remained asymptomatic. I lumped both together, moya-moya and atherosclerotic, again, could not find a correlation between delayed occlusion and any of the flow measurements I was doing. This is graft survival over time. What matters is clinical outcome, and patients do get better. Whether you look at moya-moya, this is pre-op MRS, post-op MRS, or cerebral ischemia. This is moya-moya on the left, atherosclerosis on the right. You look at it, pie chart, same thing. This is an important message. Properly chosen patients improve. We need to keep the bypass skill going. Couple of video examples, how I'm doing it nowadays. 1 donor, 2 recipients, meaning I usually choose the parietal branch of the STA. I'll skip some of this stuff. Physiologically hypoperfused, you can see infarct, pre-op. We like to study the area of uncompensated hypoperfusion, and we're looking at that data currently. Try to, maybe that will allow us to understand which ones might occlude in the future. I like to save the anterior branch to keep going to the skin, and I normally would do a double barrel, not a double barrel, and a side to side and an end to side with the same donor. The 1D, 2R bypass. I'll skip some of that. We're going to skip all that. Just to show the numbers. The numbers are always interesting. This is a 0.8 millimeter vessel. I measure the flow. It was 3 cc per minute antegrade, 10 cc per minute in the other cortical branch before we start the bypass, and we're going to see what happens at the end. You construct In this case, I sometimes do the side to side first and then end to side, depending on the local anatomy. In this case, I'm doing end to side first. We're going to skip that. Again, interrupted is good for teaching fellows and residents. I measure, now notice the number. I'm measuring the flow. By the way, you know, the way you hold the graft can change the flow. Very important to follow the natural curvature of the donor. And the flow is, I think, 58, here it is, 58 cc per minute before doing the second bypass. So now I'm going to go side to side here, and I'm going to do to the frontal M4. You can do sometimes running, interrupted, depends on the local anatomy of the case. And look at that, 63, it went up. Of course, it makes sense, as I will summarize later. Why does this single donor, double recipient bypass make more sense to increase the flow? Here are the numbers. 63 is meaning cut flow index 1.4 almost, higher than the so-called maximum. I'm going to skip the other case, which is, actually, no, let me just show you. It's an identical case, but just to show you the benefit of using ICG that is incorporated in the microscope. It just shows it to you better. And it's identical type of case, just to show you what you can do with that ICG that is infused in your microscope. Again, the cut flow at the end, the total flow is higher than the cut flow at the beginning, and you can play with the saturation of that. These are the numbers. Again, the concept is important, not the numbers. Uncommon bypasses, that's what I'll essentially finish with. Our first speaker showed a very nice example of occipital to pica bypass. Very, very underutilized in posterior cerebral ischemia. This is such a case, multiple posterior circulation ischemia. This is planning before surgery. Craniotomy. I also love to use the Colorado needle to get the occipital artery, cutting the dura. Cerebellomedullary fissure, you know, you just expose the pica, the donor. It's not a difficult bypass. It is deeper, but the space is huge. And you just need to make sure you're saving the perforators, and you can bring the pica closer to you as long as you're not avulsing, of course, the anchoring perforators to make the bypass a little easier. And then the rest is the same, just occipital to pica and to side. Again, I'm skipping. It's all repetitive, you know, these anastomoses, as long as you follow the basic principles. I love to use curved needle holders to increase my degree of freedom in maneuvering, and the closure as watertight as I can possibly make it. Not always possible. That's a post-op angiogram. Nice bypass right here. Unusual bypass, occipital artery to angular artery. Again, I thank George Zenonos, who was my fellow, who edited these couple of videos I'm showing. He's now in Pittsburgh. This is a tumor that was unresectable, radiation therapy and radiation-induced hypoperfusion of the left hemisphere. No STA.
Angio suggested absence of flow.
And all I want to show you is that you can use occipital artery to angular artery to achieve an anterior circulation bypass.
The artery was traced.
This is George's lovely voice.
Now, before completed.
And you have to create a tunnel in the bone. And the actual bypass isn't difficult at all. It's just you need to be able to reach with the occipital artery. And it just about makes it to the angular artery. And on the post-op angiogram or in ICG, you can see it here. And you see the tunnel you have to create for the occipital artery. Very similar to what most, I have 2 bonnet bypasses. I don't have 3. I have 2. I'll show you. Well, it's almost identical to Mustafa's case. I can skip it, but what's interesting is the flow measurements. So this is the ipsilateral STA. It only had 7 cc per minute. So it confirmed to me that I cannot use it because the common carotid was occluded. And very similar to what Mustafa showed you, this is a contralateral STA. And of course, you have to put the proximal bypass first. I like to use the bifurcation of the STA to match the saphenous vein ostium. This is kind of going back to Carrel 100 years ago, how you construct an ideal anastomosis. We're going to skip all that. You groove the bone. And the only thing I did slightly different from Mustafa, I added plates on top of the vein, kind of to keep it, titanium plates to keep it in the groove. And at the end, it looked like, you see the plates I put there. I think I'm near, okay, so to finish, well, almost to finish, technical tips. Keep your bypass donor as short as possible. Try to do a donor to recipient ratio between 1.5 and 2. If you go more than 2, you will have serious problems hemodynamically. Fish mouth the donor unless there is a large discrepancy between donor and recipient. Try to achieve 30 degree, but if it's awkward, 45 degrees is fine. Of course, you think of it geometrically. The smaller the angle, the longer the necessary fish mouth. It becomes totally impractical to do it too much. When you are near the toe and the heel, place your sutures closer together because that's a higher wall shear stress. What are we working on now in progress? We're analyzing the single donor double recipient bypass flow data. We are doing the analogy with electric circuit, and as you know, it's like circuit in parallel. You drop the R, the more you add. So when you do a double bypass, as I said, the peripheral resistance drops, which is why the flow goes up. We're analyzing angiograms by superimposing them like this, trying to figure out the area of perfusion without compensation. We do it on this. We do it on this as well. Conclusion, please, direct bypass is very effective in reducing stroke in symptomatic moya-moya disease, certainly also in hemorrhagic moya-moya as proven by a randomized clinical trial, and very select atherosclerotic occlusive disease, very high immediate patency rate, only 1 out of 105, I failed to get the bypass to go. Intra-op flow measurements, very important. We don't fully understand cut flow index and those concepts. I have no comments on indirect bypass in adults. I've used it extremely rarely. It's almost always possible to do direct bypass. It is a great mistake to abandon bypass surgery for ischemia. You can certainly put your patients in a registry. And lastly, I encourage you to join our University of Miami Thursday series. For example, next Thursday is Juha Hernesniemi and Binju, who will talk about Juha's experience with 40 years of aneurysm surgery. Thank you very much.
Well, Jacques, as predicted, you consumed all of the extra time that we had made up from the prior speakers. Thank you for doing that. I do want to ask you one question. The 1D2R, you seem to be a real fan of that. Is that because of the physics that you presented, or have you shown a clinical benefit to that?
No, I cannot. That's why I did not claim clinical benefit, but I have enough cases now, Mike. I've only started doing it routinely, and not on every case, but the last 2.5 years. So we are literally looking at the data right now, and I will come back to you and others with what we find, if it has any benefit. The physics makes sense. Now, the times I have not used it is if after the first bypass, the flow is too high, I am not adding the second bypass, but those are rare cases.
I worry a little bit about the effect on patency. And I wonder if by doing the additional bypasses on your donor trunk, you compromise that.
I don't know. I haven't seen it. I mean, it's been short follow-up, 2.5 years, but I haven't seen it. You're worried that the side to side will stem. I mean, as you know, the side to side that gives you that H configuration doesn't really stenose anything. The end to side is fish-mouthed. I'm not worried about that. And every single case, I've measured higher flow than the cut flow. You know that. Now, of course, it's cheating because the cut flow, as you know, we measure it when you cut the long L. I'm not measuring cut flow by making both the distal end and the side cut at the same time. I don't have, it's not possible to measure that reliably. So, but if we're going to use the CFI index that Charbel has introduced, the ratios are almost always more than 100%. I don't know if I'm being clear, but that's what I want to say.
Yeah, good, thank you. Well, we better continue on with our next speaker. Dr. Abe is going to talk to us on subtemporal approach for STA to SCA and PCA bypass.
Thank you very much, Dr. Michael Rhoton. Can you hear me? Okay.
Yes.
Okay. So I'd like to talk about the subtemporal approach for STA and STA-PCA bypass. My presentation is a basic knowledge on the anatomy, mainly for young neurosurgeons. So subtemporal approach has a anterior root and the posterior root. So anterior root is a anterior part of the middle fossa is a very deep and cup shaped. So need to strong retraction of the temporal lobes. Sometimes need to remove the zygomatic arch. And for contrast, posterior root is a very flat area. In the superior surface of the Petrous bone is very flat. So no need to have the retraction of the temporal lobes. So we always use the posterior root for the STA or PCA bypass. So subtemporal has, there are key points, two key points. One is avoid the temporal lobe injury and preserve the temporal lobe veins. So we have to accurate temporal craniotomy, sometimes partial petrosectomy as needed, and careful dissection around the temporal lobe veins and cutting the tentorium as needed. So temporal lobe veins has many variations. This is vein of Lappe and temporal basal veins, sometimes entering to the middle fossa dura. So posterior root is very flat here, and we have to know the vein variation entering to the transverse sinus. So, and temporal veins entering points have also many variations. These entering to the posteriorly, and this vein entering to the middle part of the middle fossa and very strong adhered to the dura. And we have to know also tentorial sinus anatomy, and we always cut around here. So this is a very less tentorial sinuses. Posterior part has a many tentorial sinus. So this area is very dangerous to cut the tentorium. So I'd like to some cases as STA, SCA bypass. Position is slightly vertex down. So this STA, SCA bypass is a look down projection. So SCA is located inferior to the tentorium, so no need to look up. So slightly vertex down is enough. And the skin incision is along the parietal branch of the STA and extended to posterior inferior, inverse small H shape. And the craniotomy, this is transverse sigmoid sinus, and the keyhole is here, just above the transverse sigmoid junction, and root of zygoma, and here, and one more buffer in the parietal region. So this is enough to do for SCA bypass. So this is a lower limit of the craniotomy. This is transverse sigmoid junction, and this area is this buffer and root of zygoma. So this is a 74 years old female, transient ischemic attack cannot improve under the dual antiplatelet therapy. So we decided the SCA bypass for posterior fossa ischemia. So these veins, there are some temporal base veins there. So maybe 2 or 3 veins in the temporal base, but we cannot identify that this is a cortical vein or interdural vein or both. So very difficult to identify the which is a cortical vein, which is a dural sinus. So very difficult to understand operatively. So we have to decide intraoperatively how to manage these veins. So right side STSC bypass video. So after skin incision, ST is harvested and the temporal muscle elevated anteriorly. So after craniotomy performed, so this is the transverse sigmoid junction around here, and here is a root of zygoma. So STA is protected by the temporal muscle. So after craniotomy, dural open, and this is a one temporal basal base vein. So this is this was a cortical vein, so we can disattach from the brain surface and entering the deeply. So this is vein of Rappe to just protect using the Sarge cell and the fibrin glue. So these 2 veins is here is a cortical vein, and this area is very strongly attached to the tentorium dura. So very difficult to retract the temporal lobe. So, and I try to detach the veins from the tentorium, but it's very difficult. So in this case, we can cut the tentorium. So this is superior petrosal sinus, and this is arcuate eminence. So we can cut tentorium very long way. So after cut the tentorium, we can elevate these veins with tentorium. So this is a tentorium edge, and this is fourth nerve, releasing the CSF, and the cut the tentorium edge posterior to the fourth nerve, and very long tentorium cut performed. So this is a tentorial artery. So coagulate and cut. So after cut the tentorium, we can very easily access to the SCA. So elevate the tentorium, and we can retract the tentorium with these temporal veins. So very wide operative field. So this is SCA, and this is fourth nerve. And SCA is elevated using lava sheets and fix the lava sheets to the tentorin. To elevate the SCA and fix and put the continuous drainage tube and confirming the STA long and fish mouth trimming and repairing the two-stage sutures, in this case using a 9-0 flooring. So temporary occlusion and so after widely cut the tentorium, this operative field is not so shallow and little bit deep, but enough operation field to do a safety bypass. So that keep the operation field is very important to accurate anastomosis. Yeah, I'll pass this way. After bypass, ICG angiography shows good patency. This is SCA and the cortical branch tentorial surface of the cerebellum. Post-operation, patient improved the transient ischemia attack, so no new complication. This is another case, left vaginal SCA partially thrombosed unruptured aneurysm. So this is partial thrombosed. So I tried to, at first, SCA bypass and clip the proximal part of the SCA, and after the bypass, stent assist coil embolization is planned. So this case have no temporal base vein, so very small cut of the tentorium is enough to do the STA bypass. So different from the first case. So this is a very small tentorium cut. So after the bypass, proximal clipping performed using a right angle clip. So this is a perforating arteries. It confirms using Doppler and ICG angiography shows good patency of the SCA bypass. So after the operation, very small infarction in the midbrain dorsolateral surface, but fortunately, patient has no neurological deficit. After the bypass, stent assist coil embolization performed and good result. So next is a STA-PCA bypass. So position is different from the STA-SCA bypass. STA-SCA is a look down projection, but STA-PCA is a look up, need a look up, so strong vertex down needed to look up the PCA. And the skin incision is the same as a STA-SCA bypass. And so this is a STA bypass operating projection, look down. But STA PCA bypass is a look up. So this bone is very, we have to drill out this area. So we always do a partial Petrosectomy like this. So we drill out this area to look up the PCA. So just remove this area to preserving the semicircular canals and external auditory canal. So only this small petrosectomy very useful to look up the PCA. So this is 48 years male and right right PCA fusiform aneurysm. So we planned to the bypass, STA-P2 bypass using this proximal portion of the calcaneal artery. So this located the, and I'm sorry, and after the bypass, I clip the distal end. And if possible, I will try to the dome clip, preserving the this medial posterior colloidal artery. But if impossible, we will try, after the bypass, we will do the coil embolization. This is my plan B. So, and this recipient artery is located this portion. So very and not so deep and high position. So I think this is the best way to do the ST-PCA bypass here. And this patient has very small parietal branch, so I use a frontal branch. So skin incision becomes question mark skin incision to use the frontal branch. And after temporal craniotomy, partial petrosectomy performing here, this marking the transverse sigmoid junction. So during the partial posterior petrosectomy, this is a transverse sigmoid junction. So, and preserving the semicircular canal. So this is enough to look up the PCA. So releasing the CSF from the ambient system. And so this patient has very few temporal base veins, so no need to cut the tentorium. So look up the, we identify the aneurysm, and this is a lateral surface of the midbrain, and this is a P2. And this is a P3, a proximal portion of the calcaneal artery. So we decided to use this artery as a recipient artery. So I always use a rubber sheets to fix the recipient artery and to elevate the recipient artery. So using a rubber sheets, very easy to do the anastomosis. This is the same way, so I'll skip the video. And after the bypass, I clip the proximal portion of the P2, just distal the aneurysm, and preserving the perforating arteries arising from P2. And very strongly adhered third nerve to the aneurysm. So we decide the only distal clipping. And ICG shows good patency of the bypass and no filling of aneurysm. So we planned after the bypass, endovascular team will coil embolization, but post-operatively, aneurysm was thrombosed, and very small infarction is medial temporal lobe. But fortunately, patient has no neurological deficit. And angiogram shows no filling of the aneurysm and preserving the medial colloidal artery. So no need additional therapy. So this bypass and distal clip, and this is a complete treatment archived. So this is just not a subtemporal approach, just shows the option of the ST-PCA bypass. This is a left ICA fusiform aneurysm, and the fetal type PCOM arising from aneurysm and no P1. So PCA is vascularized only from the ICA. But ACOM is here. So we decided to the STA P2 bypass through the Sylvian fissure and STA M2 bypass and then trapping the aneurysm. So this is just last case. So widely opening the Sylvian fissure. So this is aneurysm, these are the P2. So retract the uncus, we can see the P2 segment and elevate the P2 using rubber sheets. So this is a very small and deep operative field. In this case, I need a special instrument. This is a Dr. Kamiyama and Dr. Tanigawa's instrument is very useful in such a cases. So after the STA-P2 bypass, the STA-M2 bypass performed and trap the aneurysm. So ICG shows a very good patency of STA-P2 bypass and the STA-M2 bypass and no filling of aneurysm and preserving the anterior choroidal artery. So after the operation, small infarction in the anterior term perforating artery infarction, but and mild right hemiparesis but improved after 3 months operation. So conclusion, accurate temporal craniotomy and preserve the temporal lobe veins are important for subtemporal approaches. Cutting the tentorium is effective for preserving the temporal lobe veins entering the tentorium sinus. Partial petrosectomy is effective for STA-PCA bypass. Thank you very much.
Hiroshi, Mike, can I ask Hiroshi a quick question?
Yeah,
Yes.
Let's do one question and then let's keep going.
Hiroshi, beautiful presentation. Do you sometimes, when you do the petrosectomy, go completely pre-sigmoid and cut the tentorium and superior petrosal sinus, or that's not what you normally do?
Just not normal. So if the high flow bypass need a widely operation, so pre-sigmoid space using the cut the tentorium is very useful, but low flow bypass is no need so much operation field, so
yeah,
no need to cut the tentorium.
Well, thank you for that. Let's move on to our next speaker. It's a real privilege for me to introduce Rokuya. I see you on the screen there, Rokuya. It's good to see you after so many months. You look well. We've all benefited not only from Kamiyama's instruments and all of his innovations on the scissors, but also yours adapting some of his instruments into the super bypass line. And we're all really excited to hear your special lecture on his instruments and surgeries and how you have carried on his legacy. So Rokuya, it's all yours.
Thank you very much. Can you hear me?
Yes.
Okay. Thank you, Michael. Yeah. Very fast time flies. Already 6 months after we saw. Anyway, this COVID-19 pandemic is terrible. Many meetings canceled, but we have a very good tool to do such a high-level educational neurosurgery meeting. It's a good area to run neurosurgery for everybody. But today, I am very honored to talk about the Professor Kamiyama's instruments and his surgery. I have my COI like this. Okay. Professor Kamiyama, what he taught us, at first, attitude of a neurosurgeon, he always says, complete what you plan, never give up. And blood-wide exposure of the lesion, clear vision, and preservation of cerebral veins. Don't sacrifice, don't coagulate. If you cut veins, you can't operate ever. When I was a resident, he told me. And he taught us a microvascular reconstruction. His tenet is immediate arterial reconstruction in case of injury of arteries. And as well, always try to reconstruct veins if injured. Actually, Professor Kamiyama and I are working in Petrosectomy Hospital, and he is the chair of the Brain Research Center of Petrosectomy Hospital. Many of you know that Professor Kamiyama was a pupil of Professor Zentaro Ito in Akita Prefecture Cerebral Vascular Research Center. Unfortunately, Professor Zentaro Ito passed away in 1984 when he was 42 years old. After his death, Professor Kamiyama completed his neurosurgery book about the cerebral aneurysms and vascular reconstruction in 1985. It was published from Elsevier Nishimura in 1985. In the atlas, the Professor Kamiyama drew the many illustration pictures like this. This is his drawing of the precise microanatomy of the cistern and cerebral artery and the veins, the microstructures. And as well, this beautiful picture of the arachnoid trabecula, which is holding the cerebral artery and the veins. In this book, Professor Zentaro Ito mentioned about the difference between a subfrontal and transcranial approach. Professor Zentaro Ito taught Dr. Kamiyama to do a distal transcranial approach to separate, to open the fissure widely to achieve the operative field sufficiently, not only middle cerebral artery aneurysm, but also carotid distal basilar aneurysms. As well, in early 1980s, in 80s, Professor Zentaro Ito developed a high flow bypass using a radial artery graft like this. This drawing by Professor Kamiyama. More than 30 years ago, they had already done such a beautiful bypass. The current our skill to do a high flow bypass is completely following this way. Professor Kamiyama developed many instruments. His instruments supported his surgery, and now those instruments are necessary to do a accurate neurosurgery. This is the Kamiyama scissors developed in 1989. everybody knows this is a very useful, excellent micro scissors to dissect the cerebral fissure and especially interhemic fissure. You can see the tip of blade, the sharp tip, slight upward curve, and inferior lower blade has a blunt tip, and the blade thickness is very thin. So it is very useful in interhemic fissure. After the development of first micro scissors, he developed another thick blades, serrated scissors. This is designed to cut the coils in the aneurysm. As well, this is very useful to cut the dura during skull-base surgery. And he developed the Kamiyama irrigation suction system like this. If you push the pedal, you can get water flushing through the suction tip. At this moment, the suction is completely off. And in the neutral position of the pedal, the suction and water flushing completely stop, and you can use the suction tip as a dissector in the neutral position of a pedal. This is the inside structure of the original Kamiyama irrigation suction system. There is a small silicone tube to control the water injection, water flushing. By pushing the pedal, the the small silicone tube is released and you can get water. And suction hole is closed by a rotated valve like this. This is the structure of a Kamiyama irrigation suction system, and this is very useful to clean, to maintain the operative field clean. And if you have accidental sucking of a vein something, you can immediately vomit the structure, and then you can preserve it. This is actually example of usefulness of the Kamiyama suction irrigation system during a cerebral dissection. Now, I let my young colleagues to separate the distal cerebral fissure. There are many gel form mines in the cerebral fissure. He fight so much, and he couldn't separate the superficial cerebral vein. And now I'm scrubbed in, and I am trying to detach the superficial arachnoid membrane from temporal side superficial cerebral vein. With this section, as I told you, with pedal control, you can control the suction power, very weak power to a full power. So it's easy to manipulate the vein like this with a suction tip, and you can continuously dissect the cerebral fissure with in a left-hand sucker and right side micro scissors. In this situation, the temporal side superficial cerebral vein is detached from a temporal lobe, and with the highest magnification, you can see the arachnoid trabecularis in between cerebral fissure. And the arachnoid trabeculae between frontal lobe and temporal lobe can be dissected. And in this case, MC aneurysm is exposed. He said always preserve all cerebral veins. A neurosurgeon who cannot preserve superficial cerebral veins cannot preserve important apparatus at basilar bifurcation. This is an actual case of ruptured basilar top aneurysm, subacute hemorrhage, low position basilar top aneurysm. You can see the top of the aneurysm is a similar height with the posterolateral process. This is the right side distal transcranial approach. And with the Kamiyama irrigation section system, you can rinse the subarachnoid clot in cerebral tissue frequently, and by repeated rinsing of a subarachnoid clot, we can get a very clean operative field. And here, this is the third nerve coming into oculomotor foramen, into cavernous sinus, and the temporal uncus is a bit retracted, and PCOM and the P1 and the third nerve is confirmed in the retrocarotid space. In this case, the postcranial removal is necessary to secure the proximal basal. You can see the aneurysm is exposed, and the bilateral P1 is very just next to neck of aneurysm. And I am confirming the rupture point after temporal basal occlusion, where the rupture point, you find the rupture point is left side of the blade. So at this moment, you can complete the neck clipping. Then basal artery could be reflowed. And the remnant is closed with additional tape. And this is IC green angel, shows a very good obliteration and preservation of everything. And additionally, this is a subacute hemorrhage. So in this case, contralateral cerebral fissure had a very thick clot. So through the chiasm, the contralateral cerebral fissure is rinsed. Repeated irrigation performed to take out the contralateral subacute clot. And this is a post-op CT scan. Almost clot is taken out. And the CT angel shows a good result. Patient recovered well. Professor Kamiyama developed to use urokinase 60,000 international unit in a 5 milliliter irrigation water saline. It was 1992. Using a Kamiyama irrigation section system, at the beginning of the micro approach, you can irrigate the rinsing the fissures, and you can take out the almost subacute clot in a major system. With this procedure, we could improve the result of a superacute surgery for subacute hemorrhage. Especially, we can reduce the incidence of a symptomatic vasospasm to 15%. At that time, the standard in Japan was more than 30%. So the urokinase and the using a Kamiyama irrigation section system was very effective. He said, the use urokinase and irrigate subacute clots. The purpose of superacute surgery for subacute hemorrhage is not the clipping, but the prevention of vasospasm. He always told us. And this is the newest result we have published on the World Neurosurgery. in this in the patient hospital. The cervical hemorrhage 158. The ratio of symptomatic vasospasm was 3.8%. Angiographic vasospasm 24.1%. The good outcome was 82%. And in our study, the post-operative amount of cervical clots on a CT scan related to symptomatic vasospasm. It was significant difference, and a poor outcome related to over 60-year-old lab reference grade and post-operative amount of clots on CT scan. So surgical removal of cervical clot and continuous low-dose intravenous microneurosurgical administration was very effective to prevent symptomatic vasospasm. This case is a 72-year-old female, WFNA grade 3, ACOM large aneurysm rupture. The maximum diameter was more than 12 millimeter. This is a super acute subarachnoid hemorrhage surgery, anterior interhemiscal approach. Due to a subarachnoid clot, the trabecula's in interhemiscal tissue is not easy to recognize, but the irrigation with the urokinase irrigation water, gradually the microstructure, not only trabecula's, but also tiny veins, pial veins could be recognized. And in pericarotidial system, the pericarotidial, bilateral pericarotidial arteries are exposed like this. And from the bottom of the pericarotidial system, the other tip of the triangle, small triangle, you can cut the arachnoid trabecula, then you can find the microperivascular system. That system is related to carotid-marginal artery. You can see it, and gradually you can extend the interhemiscal tissue from the deeper area to a shallow area, and as well, again, this is a perivascular system of the proximal part of the carotid-marginal artery right side. You can see it. And gradually, the interhemiscal tissue could be separated. And this is the left side, A1 and A2. In this case, the dome of right side is embedded in right gyrus rectus. And like A2 is adherent to neck, and in the bottom of the aneurysm, there is several hypotonic branches. With a 4-point control of a bilateral A1 and a bilateral A2, you can completely shrink the aneurysm, and you can make the neck plastic with the multiple clips. Because of the sclerosis of aneurysm, it is difficult to close the aneurysm with a single clip. Patient recovered well. Professor Kamiyama said, achieve the skill to separate interhemiscal tissue. If you once obtain the skill, every other dissection becomes easy. So using a Kamiyama suction irrigation system, the suction tube is an irrigation tube with a high pressure. So injecting water into a tissue like the internal tissue or cerebral tissue, you can effectively rinsing the subacute clot, cleaning the operative field. And additionally, we can use suction water to test the water resistance after dural closure. This is an example of dural closure and the water resistance test. Like this, inject the water inside subdural space, then check the water resistance. No water coming through the stitching interval or needle hole. Professor Kamiyama said, dural closure is important. A neurosurgeon who cannot stitch the dura watertightly cannot stitch brain vessels. He developed surgical embolectomy around 30 years ago. This is a recent case of a 78-year-old man left internal carotid artery occlusion due to cardiogenic embolism. This is a left side carotid occlusion. But through the Transcranial approach from a skin incision, we can reach here around 10-15 minutes. Then you can inside the distal carotid, and assistant is preparing temporary clip at the proximal segment of a carotid, and the pulling out the thrombus in the carotid, and put the temporary clip on A1 to block the crossflow through ACOM, and the remaining long thrombus could be taken out from M1 segment. And proximal temporary clip, distal to anterocoroidal artery, then the anterocoroidal artery recanalized at this moment. And 3-4 stitches with 9-0 or 10-0, you can get the hemostasis and the complete reflow of the carotid system. The post-operative diffusion image showed a very limited high signal area in inside system, and the patient recovered well. And his big work is surgery for moya-moya disease. His pupil, Dr. Ishikawa, Tatsuya Ishikawa, published the pan-arteriosynangiosis for moya-moya disease. Pan means that very wide area of cerebral vascular territory to perform the STA, MCA, and simultaneously STA bypass. Right side illustration, this is my drawing when I published it in 2010 in Japanese literature. The two branches of frontal and the parietal branch of STA is harvested, and frontal branch is placed in medial rectangular craniotomy and make the STA ACA bypass. And small branches of frontal branch can be on a small to MCA territory, and the parietal branch on a small to MCA territory additionally. And the final view after the bypass like this and the dural closure with EMS, temporal muscle is patched on the lateral craniotomy, and medial craniotomy is patched with the periosteum or Garrier flap. And instead of the disappearing of temporal muscle in epidural space, remove the bony tip should be placed on the temple, and the temporal fascia cover the bony pieces to avoid the temporal depression. This is the actual case, 11-year-old female, moya disease. She came to us with the paralysis of TIA. This is the preparation of STA, the parietal branch and frontal branch, and small branches like this from frontal branch is harvested as well. And several 2-3 small branches from frontal branch is preserved to perform the STMC bypass. And this is the dural opening. We make the dural penetration by deflecting the dura into a subdural space as a EDS. And middle meningeal artery is preserved. And the medial rectangular craniotomy with the K-shaped dural opening. Then the medial, in the medial rectangular territory, the anterior cerebral artery, which is arising from internal fissure, is secured. And this is a preparation of STA with the fishmouth streaming. STA, this is the STA ACA bypass. In this case, STA ACA is performed as a double bypass. Two branches of a frontal branch is used. And this is the first STA ACA bypass. And another branch of a frontal branch is an small to ACA. And this is the second STMC bypass. And this is a MCA on the temporal side. This is the parietal branch. Parietal branch is on the smooth to temporal side. So in this case, STA ACA double bypass, and this is the periosteum covered the medial rectangular dura, and temporal muscle is covered from temporal craniotomy. Postoperative CBX study shows a very good recovery after bilateral operation. This is another case of the angiogram after surgery, bilateral revascularization. This is adult moya as well, the very good revascularization. This is Professor Kamiyama's case. The patient came to him because the recurrence of the basilar top aneurysm after coil embolization. Now he is trying to take out the coil inside aneurysm. So much coils in the aneurysm, like this, and awful situation happened. After taking out all the coils, the basilar top wall disappeared. Basilar bifurcation disappeared. So this is a radial artery patch graft. This is a patch graft of basilar artery. He is trying to reconstruct the basilar bifurcation. Now you can see this is the left side PCA, and the right side PCA is recovered with patching to a basilar bifurcation. Now, even after the reconstruction basilar bifurcation successfully, the bilateral SCA is occluded because of a very bad condition of neck, and coiler embolization causes the chronic injury of the intima. So he is now trying to reconstruct the bilateral suprasellar artery using STA graft. This is the frontal branch of STA. is connected to a contralateral SCA proximal portion and as an end to side fashion. And another branch of STA is used to reconstruct the right occluded SCA. Now, you can see the STA and the right SCA is reconstructed by STA bypass, STA graft. So bilateral SCA and the bilateral PCA basilar bifurcation is completely reconstructed even after cerebral coil and coil removal. This is Professor Kaneyama's surgery, and this surgery revealed his tenant. This is a 63-year the post-stent assist coiled IC econ aneurysm. This was initially cervical hemorrhage, so the patient was saved with this procedure. But unfortunately, the aneurysm continuously growing up. So the patient came up to improve the growing up of the aneurysm. We planned to do a high flow bypass between external carotid and MCA, M2 segment, and we try to do a therapeutic carotid occlusion at the neck by occluding the cervical internal carotid artery. Now, this is the radial artery external carotid anastomosis, and the internal carotid at neck is occluded, then the high flow bypass is open, and we confirm the good working of radial artery graft, and then we can occlude the cervical internal carotid in the neck. Fortunately, nothing happened. The PCOM and corridor artery territory has no ischemic complication, and the patient recovered well. Now, we are carefully observing the aneurysm, whether it is growing up or not. Another case, the Professor Kamiyama developed the temporary radial artery bypass by lifting up the patient's hand during operation. This is an operation in 2009. I performed in Abashiri. This is a left side operation. At first, we usually perform the STA M3 bypass. And after the STA-M3 bypass, the patient's left hand is lifted up, and the radial artery already harvested like this. And radial artery can be separated from the wrist. And the radial artery is anastomosed to M2 segment inferior trunk. And into side anastomosis is completed. Then in this case, the aneurysm is expanded distal dural ring and elevated optic nerve. And the patient had almost sensus luminous, very bad visual acuity. Now, the retrograde suction decompression is performed through the carotid, cervical carotid. And aneurysm could be separated from left optic nerve. This is the adhesion of aneurysm to the A1 segment and the chiasm. And here is the expanded distal dural ring, and this is the optic sheath. I am decompressing the optic nerve and confirming the ophthalmic artery, the medial to the aneurysm. And now I could put the neck clipping So in this surgery, I could preserve the internal carotid anterograde flow. So the temporal radial artery bypass is returned to the wrist, and the radial artery and the small at the distal radial artery at the wrist. The patient recovered well, and the patient visual acuity amazingly recovered very well. And this is an example of a skull-based during. This is a lower basilar aneurysm, so we need a combine the posterior and anterior petrosectomy. This is a middle fossa dissection that expose the temporal rhomboid like this, and the temporal during along the Petrous edge. You can begin the during, and along the GSPM just beneath it, there's the C6 internal carotid. You have to be careful not to draw the C6 carotid. That is the C6 carotid. You can confirm the Doppler sound. And in the anterior temporal root, you can expose the anticlinal process lateral edge and confirm the ultramotor and internal carotid and posteroclinal process. And then you can go to a posterior to perform the mastoidectomy. These are landmark of mastoidectomy, the supramastoid crest, spine of the handy, mastoid tip, Arterional root of zygoma. These are the very important landmark to do a mastoidectomy. Now the mastoid antrum is exposed, and gradually the sigmoid sinus skeletonization and temporal tegment is skeletonized. And in the antrum, you can find the incus, and just anterolaterally, there is the Fallopian canal. And diagnostic reach is a good landmark to start mastoid foramen, and the Fallopian canal gradually visualized. And lateral and the posterior hemicycle skeletonized. And here the sinodural angle, the SPS is exposed. The remaining, the bone at the temporal segment is taken out. Then you can find the archaic eminence, which is a suprasemicircular canal. And then you can go to a middle fossa and additional petrosectomy. This is the overview after the mastoidectomy, post-petrosectomy, and just posterior to endolymphatic duct. Partially, it was opened. I stitched and closed the endolymphatic duct, and middle temporal dura is opened, and superior petrosal sinus is ligated and cut, and inside the tentorium through the free edge, not to cut the fourth nerve. Under confirming it, you can find it. The fourth nerve is right there in the depth, and you can expose the P2A, and just beneath it, you can find the third nerve and basilar medial to a third nerve. This is the actual case of a V2B-P2 bypass for vertebral aneurysm. Initially, this patient had the bilateral vertebral artery aneurysm. The left side was occluded as a vertebral artery proximal occlusion. And the right side, after the first operation, after closing the left side, the right side vertebral aneurysm is gradually bigger. So we tried to perform the V3P2 bypass to reconstruct the vertebral basilar system. And this is a mastoidectomy for post-petrosectomy to make the sufficient operative space to perform the radial artery P2 bypass. This is a P2P to perform the radial artery P2 bypass. This is a preparation of a radial artery with the fish mouth trimming, 60-degree cut, and the same length cutting up. And this is the PCA. with mastoidectomy, post-petrosectomy, and tentorial cutting, you can get sufficient operative field to do P2 bypass with the radioartery. And this is a proximal anastomosis with radioartery graft and V3 segment. I usually use out punch to make the arteriotomy on whatever artery, as well as in external carotid artery. And now the V3P2 bypass is completed. And in this case, I skipped the STSA bypass. We always perform the STSA bypass prior to regular P2 bypass. Anyway, in this case, the aneurysm trapped after the vascular reconstruction, and we confirm the IC green of the good, whether the good flow or not of the radial graft between V3 to P2. And as well, the IC green shows the complete obliteration of the aneurysm. I am confirming all the perforator around the aneurysm. And this is the closing head, and post-operative angiogram shows a good reconstruction of the basal system, and partially filling this aneurysm, and this is completely occurred in several days. Professor Kamiyama said, go to cadaver dissection course, learn skull-base anatomy. Knowledge of anatomy will be not only for your patient, but also for yourself. So, how long can I talk? Is this almost time? So, okay. He says, always try to reconstruct the injured major veins if you really wish to treat a patient. I skipped the actual venous reconstruction video, but this is as well, this is a very important tenet of Professor Kamiyama. So we learned tenet of Professor Kamiyama. Preserve all veins in your approach to the lesion. Try to reconstruct the normal structure if you injured. Never give up on the way to execute the procedure which you plan. Maintain the operative field clean with irrigation and suction system. And the most important thing is attitude and passion to neurosurgery. That's all. Thank you very much for your attention.
Thank you, Rakuya. That was fantastic.
Thank you.
All right, we're getting a little behind schedule, so why don't we go immediately to Professor Tong. Professor Tong, are you ready?
Yes, I'm ready.
Okay.
It's okay. Okay, am I clear?
Rakuya, thank you. That was a wonderful lecture.
Okay, am I clear?
We can hear you very well, Dr. Tong. Go ahead.
Okay, thank you. And thank you for all giving me opportunity to introduce some bypass surgery in our department. So I'm Dr. Rhoton's fellow from 2003 and 2005. I want to introduce some bypass for complex MCL aneurysm and huge basilar T aneurysm, and and something like this, just like extreme and urgent. At first, I want to introduce direct repair complex MCA aneurysm. Just count this aneurysm, 46 years old. And we have several options, including bypass, clipping, and direct repair. And we choose direct repair. And at first, we do the anastomosis and remove the aneurysm. And finally, we do the anastomosis. So the first step, we do the M2 to the other branch of the anastomosis. This is the ICG. And we remove the aneurysm and re-anastomosis the segment. So this is the intraoperative ICG. And after that, we can see the aneurysm disappeared. And we can only see a little stenosis around the M1 segment, no aneurysm. So this is the pre-operative and this is the post-operative, and this big aneurysm totally disappeared. And the patient's MR perfusion nearly normal. So we rotate occlusion during operation nearly 45 minutes, no severe infection. And the patient recovered very well. So sometimes for ECA, radioartery M2 bypass is a reliable bypass and can be regarded as a kind of deep flow diverter. And this is a female, this is a male, 63 years old, and recurrent ICH and M1 descending aneurysm. This is the ICH patient, and this is the huge dissection on the M1. And we can see this M1 dissection aneurysm. And the most difficult is the post communicating artery from the aneurysm. So it's difficult to do the operation. This is the prominent post communicating artery. So we do this kind of operation in the hybrid operation room. We do the ECA radioartery M2 bypass. Reverse flow is the best policy. So this is the ECA radioartery anastomosis, and we need very good flow. And this is the M2 radioartery anastomosis to keep the flow direction. This is the intraoperative DSA. We can see flow to the post-communicating artery. You can see this, this is the result of bypass, where you can see the post-communicating artery. So patients recovered normal. After 1 year follow-up, we can see the M1 dissection segment become nearly normal. So we can see the artery seems normal and the patient return to normal life. So this for the M1 segment aneurysm. So sometimes we are very difficult to treat the huge basilar tip aneurysm, but we can reset the ICA to the normal flow. To the female patient, persistent headache, unruptured aneurysm, bilateral ICA occlusion, and huge basilar tip aneurysm. So we can see bilateral the artery occlusion and the big basilar tip aneurysm. So patient's blood flow nearly normal. So how can we treat this disease? This is the flow related aneurysm. So we decided to reconstruct the right common carotid artery with the saphenous vein. This is the first stage. And the second stage, we do the bypass from the vertebral artery to the carotid artery and occlude one vertebral artery. So this is the second stage. So this we do the first operation for the reconstruct the right common carotid artery. So we need high-risk saphenous vein and the incision. And this is the first operation. We rebuilt the right carotid artery. This from the subclavian artery to the right commented artery. So first stage, we set up the new right commented carotid artery. So the left is the pre-operation, the right after we rebuilt the right carotid artery. So after 1 year, we do the second operation. We rebuild the left internal carotid artery from the left vertebral artery. So after 1 year, we can see the right commented artery is very good. So we still can see the big aneurysm. And we do the second operation to rebuild the left internal carotid artery. So this is the vertebral artery, this is the carotid artery. And we use radial artery from the vertebral artery to the internal carotid artery. So this flow from the vertebral artery to the internal carotid artery. So this from the vertebral artery, reconstruct the left internal carotid artery. So post-operative DSA, we can see this is the post-operative left internal carotid artery, the normal left internal carotid artery. So within 2 years, we reconstruct bilateral carotid artery. So the aneurysm nearly disappeared. Just like we put the stent, the aneurysm gradually clotted. And we didn't treat the aneurysm, but we spent 2 years reconstruct bilateral carotid artery. And the headache disappeared, patient recovered nearly normal. For the huge dissection basilar aneurysm, we have several plans. And I just want to show one case just like this. We use the vertebral artery directly bypass to the B2, and we occlude the vertebral artery at the same time. So this is a male patient, 52 years old, have 30 years SAH, and the aneurysm become huge and compression. And this is the clot. So this is the vertebral artery. So we decided to do the 2-stage operation. Step 1, do the double bypass, vertebral artery, radial artery to P2, and occipital artery to PECA. Step 2, we occlude proximal vertebral artery. So we can see this is the incision and the patient's position. And in this operation field, we do the 2 bypass and occlude proximal vertebral artery. So this is the vertebral artery to the P2 and another occipital artery to the PECA. And we occlude proximal vertebral artery. This intraoperative ICG. And 1 week after operation, patient symptom become severe. We need tracheectomy and dyspnea and dysphagia. This 1 week after operation, we can see this angiography, we can see the flow can go to ICA. And this post-operative CTA, and this bypass from the vertebral artery to the P2. And this pre-operation imaging, and this post-operative occlusion. And from the MRI, we didn't see the stroke. The perfusion, MR perfusion nearly normal. So patient recovered after 2 weeks. So from 2014 to 2017, we do 14 such cases, but we have 3 cases have severe complication. From 2018 until now, we focus on the safety. This also dissection aneurysm, not so big, but have some clot. So we do the bypass and we do the coiling. So at the first, we do the bypass just like previously. This is the bypass from the ECA to the P2. We didn't occlude the basal artery, the proximal basal artery, just like patient becomes stable, because this is the non-rupture aneurysm. Patient's MR perfusion improved. After 3 weeks, we use the coiling the basilar tip, the basilar proximal segment of basal artery. And we can see the basilar tip supplied by the medial artery. And 1 month after operation, patient have third nerve palsy. 1 year after operation, we can see patient recovered. So this after 1 year, we do the angiography and the aneurysm disappeared. How the flow reaching down, how far? And we can see another case. This also male patient, severe brainstem compression symptom and the basal artery dissection aneurysm. And patient accept stent coiling and coiling. Patient hesitate to choose flow diverter and the surgery. Finally, they choose the surgery. This is all complex bypass team. And we do the ECA radial artery and the P2 bypass just like normal. And we can see the flow. And after that, we do immediately we do the angiography, and we can see the bypass, but we didn't occlude the basal artery. So after 3D reconstruction, we can see the flow, no problem. And we can safely occlude the basilar artery. So we use coil. The left one is our case, very short segment occlusion. And we can see the flow can reversely go to very deep. And this the 3D reconstruction, we only occlude very short segments of the basal artery. And the patient recovered very well. After half years, and we can see the patient recovered very good. So right now, we use the safety means to treat that kind of disease. For scar-based tumor, we also use the bypass. So this the nasopharyngeal carcinoma, epistaxis, and nose bleeding after covered stent. This rebleeding after stent placement. We can see entire this segment is not so good. So we decided to replace this. And at first we do the bypass, and we clip the proximal internal carotid artery just below the ophthalmic artery. So this the artery in the so we occlude the proximal segment and keep the ophthalmic artery. This is the ophthalmic artery. And after operation, we can see the ophthalmic artery. This is very good. And we totally replace the internal carotid artery. And this is the ophthalmic artery and the reconstruction. For skull-base tumor, multiple recurrent chordal sarcoma, we sometimes use the bypass and the combined operation. This recurrent chordal sarcoma, this patient had accept open surgery and endoscope. So this the tumor and the internal carotid artery encasement. We can see after several surgery, the internal carotid artery already encased by the tumor. So the patient cannot pass the BOT, and we decided to do the surgery. And this all incision. At first, we don't hope to use too long incision, and we do the bypass, and we need change patient's position, and this all complex vascular and skull-base team, and at the same time we hurry the radial artery, and we have two neurosurgeons. One for the we have two neurosurgeons together do the operation, and one for the endoscope, another one for the microscope. And sometimes we together use the endoscope. So at the first, we do this kind of bypass from the internal carotid artery to the C3 to C5. And after that, we have this surgery, we can safely use the endoscope. After bypass, and we use the trans-petrosal approach and the microscope combined with endoscope. Finally, we suture the dura. This all incision, and this is the previous incision and our incision. And this is the post-operative CTA. We can see this as a bypass. And this is the endoscopic view. And in the future, if the patient's recurrent, and we can safely to remove this, we can safely do the endoscope operation without worrying about the internal carotid artery. So this post-operative result, and this also the post-operative result, and this the post-operative result. So we are in our department, we do nearly all kind of published kind of bypass, and all case under the follow-up. This our hospital, and Professor Huang is also our invited professor, and thank you of all. This all my lecture. Thank you.
That was fantastic, Dr. Tong. And I'm not an expert in this field. Maybe Mike can comment, or Mustafa, or Jax, whoever, but that was amazing. I must say I've enjoyed very much visiting your hospital, and we've done some operations there trying to help your team advance skull-base surgery and Endonasal skull-base surgery. But, you know, thanks so much for sharing your amazing experience.
It's amazing. Dr. Tong, congratulations. Wonderful, wonderful cases.
Thank you.
Thank you. I think I'm going to announce the next speaker who needs no introduction, Professor Mike Lofton. And when it comes to innovations in cerebral bypass, I don't know who'll talk better than Mike. So Mike, please go ahead.
Thank you, Mustafa. Let me share my screen here. And let me play this, and hopefully you can see my first slide. Can you see Dr. Rhoton there?
Yeah.
Yes.
Okay.
We see it.
So just wanted to start by acknowledging Dr. Rhoton. I had the real privilege of inheriting his course with the CNS that he led for many, many years. It was a 4-day 3D anatomy course that was a combination of him talking and showing 3D pictures, and then going to the lab and practicing the operative procedures. And I did that for 3 years. 6 years after he had had enough, and it was a real privilege, a real honor to kind of carry on in his legacy. And it was particularly nice for me just to have the opportunity to listen to his incredible wealth of knowledge. And I really was as eager as all the students, all the residents in the audience during all those lectures. Well, what I've been asked to do is talk about innovations in cerebral revascularization. So let me just get right to it, since it's Saturday night here in Phoenix and it's getting late. These are my statistics, and you can see for yourself, been blessed to have a very focused practice that has allowed me to do many bypasses. And when it comes to aneurysm treatments, this illustration is just meant to say that for most aneurysms, we can do our nice subarachnoid dissections, we can expose the pathology, and then we can clip these things fairly routinely. But when it comes to giant aneurysms or aneurysms that are complex, I think it raises the question, are large aneurysms best treated like regular aneurysms? And I think the aneurysm is no. And is a completely different, are these a completely different entity requiring a different strategy? And I think the answer to that is yes. That strategy is bypass, and this is a great example. This is a dolichoectatic middle cerebral aneurysm. You can see I clipped it with this picket fence, but here's the 5-year follow-up showing a reconstruction of or recurrence of the aneurysm. So, sorry about that. My dog is keeping me company here, and she just saw something outside. Anyway, there's the bypass that we're going to do. This is a what I call a middle communicating bypass. We're creating a communication between the trunks of the middle cerebral artery in order to allow the trunks to communicate. So this is a view of the external carotid artery. This is a radial artery graft going in. And now it's been tunneled up to the Sylvian fissure, and we're back up in the Sylvian fissure. This is the temporal trunk off of the aneurysm. And so the graft is going to be reimplanted to that trunk. The graft is only long enough to get to one of the two trunks. So I basically supplied the temporal trunk. And then this shows you patency in the graft. But now what I'm going to do is I'm going to repurpose the stump of that temporal division by cutting it off of the aneurysm and transposing it over to the frontal division, which you see over here with the purple line. So the dead end of that temporal trunk becomes a donor for the frontal division. This is the interluminal suture line you can see here. And here's the completed construct. This creates this middle communicating artery in an analogous way to the anterior communicating or the posterior communicating that joins the MCA trunks and allows them to redistribute the flow on the back side of this aneurysm, which is now here being distally occluded. So there's the flow now. We've got all of the trunks being supplied by the interposition graft, and that's a nice way to rebuild this. It's meant to prove the point that for these really complicated cases, the clip constructs aren't necessarily the answer, and you need to resort to the bypasses. You can see here, this is the percentage of bypasses in my overall aneurysm experience and the percentage of bypasses in the giant aneurysm experience. You can see it's 5%, jumps to nearly half for the giants. So I spent a lot of time a few years ago putting this book together, and the purpose of the book was really to see if we can't innovate and evolve the craft of bypass surgery. I wanted to do a couple of things. I wanted a system of symbols so that we could create what I call blueprints. I wanted a taxonomy for bypasses so that we could really go down the list, the menu for our different choices. And I wanted to push these intracranial to intercranial techniques. And the metaphor I like to use is architecture. This is from my days in San Francisco, and you can see this beautiful Golden Gate Bridge. It's more than just a bridge. It was meant to not only connect Marin County to the city of San Francisco, but it makes a statement about what an engineering construct can look like, how it can become this, this beautiful thing. And it really is a work of art. And I think the same thing can be said of the Freedom Tower in New York, which has come to represent something more than just a building. It's a symbol of American resilience after a terrorist attack. We can say the same things about the Basilica La Sagrada in Barcelona, with what Gaudí has brought, the elements that he's brought into this architecture with the parabolas and the branch columns. You can say the same about Utzon's Sydney Opera House with the design that he used to create the feeling of a ship on the water, or Frank Gehry with his museum in Bilbao. All of these things are taking some architectural project and elevating them to an art form. And I think when I reflect on what we can do with bypass surgery, we have a similar opportunity to not just replumb the arteries, but to make an artistic statement. And that's really what I will focus on in this talk, is just bringing creativity, bringing personality and passion into the art of the bypasses that we do. Now, having built this house in Phoenix, I came to the conclusion that architects and construction workers use blueprints. It's the way that you communicate the vision and the details from one group to the next, and you ensure that you get the construct right. And here you can see, after all the construction is done, how it's so vitally important that you have these blueprints. Well, when I reflected on bypass surgery, it was clear to me that we really don't have blueprints, and yet we could really use them. And so these are the symbols that I developed with my artist, the different wiring diagrams for the cerebral circulations, the different symbols for the anastomoses, the different symbols for the graphs and the different things that we use, symbols for the different pathology. And with these, you can capture the construct that you're trying to build. Now, this is a little video just to show how we're building this, this app where you can go to our website, you can get on this app, and you can just do these clip drag and drops and start building these schematics for yourself. They're really handy. They allow you to kind of map out or plan out your design for your bypass. And it's a great way to communicate your plan to the team, or it's a great way for you as the architect to sort of refine your design. And you know, the difficulty with these symbols sometimes is that they're just hard to draw out. And the purpose of this little project is to bring these to you so that everybody can access this algorithm and use these drawings in a way that creates these. So in any event, this is just a little example. This is an example of an A1 to M2 double reimplantation bypass. You can see Here's the donor site. These are the two recipient sites. I guess it would be a D1R2 bypass in the Marcos terminology. But here's a great way to use this schematic to capture that plan. Now, this is a paper, one of the few, if maybe the only, that I wrote with Dr. Rhoton, where we completed his work on developing a nomenclature for the segmental anatomy. I think he did a wonderful job with all of the cerebral vessels, but didn't have an alphanumeric code for the cerebellar vessels. And just by completing these alphanumerics over here, we now have a nomenclature that has really an alphanumeric address for every segment of the cerebral vasculature. And the reason that's important is that when you're trying to build this bypass, you can represent it schematically in this blueprint here, as I've shown you, or you can use the alphanumeric code and you can capture everything that you need to know in that code. So this is that A1 to M2 double reimplantation bypass. And just by using the alphanumeric code, you can go from this pathology to this reconstruction here. And everybody who looks at that code should know exactly how to build that bypass. So it's a nice way to create shorthand and to make sure that everybody's on the same page and understands what you're trying to accomplish. Now, in my mind, I like to categorize or think of bypasses in these groups of 7. And I'll just quickly walk you through. The first group is the ECIC bypasses, your standard scalp artery bypass, the Yasser-Gil bypasses, the occipital artery or the temporal artery bypasses. Those are the first category or the first generation. The second category, the second generation, are these higher flow ECIC interpositional bypasses that use the carotid and the neck as your donor. The next 4 categories are all of the intracranial to intracranial bypasses. And these are either reimplantations, in situ bypasses, reanastomotic bypasses, or these short intracranial jump grafts. These 4 categories comprise the ICIC bypasses. The 7th category is a combination bypass, and that could be any combination of any of the above. It could be 2 ECIC bypasses, it could be 2 ICIC bypasses, or any mixture of the above. And these are the 7 bypasses that I think help organize your thinking when it comes to making your choices. I think you have to start with just a classification. You have to look at, where is the aneurysm? What pathology are you specifically dealing with? Once you have that clearly in mind, then you can go to your menu of options. This is the 7 bypasses here on the left here, and on the top here, you can see the different classifications of the aneurysms. And if you just work your way down the grid, you can look at the different options that you have available to you. And further, you can go down these algorithms and you can ask critical questions and you can work your way to selecting the very best bypass option for the particular pathology. So here's an example. This is a dolichoectatic middle cerebral aneurysm. You can see the exposure in the Sylvian fissure. As we come down, you'll see the giant aneurysm here. You'll see the frontal division here and the temporal division over there. And we bring all of this pathology nicely into view. And here both trunks are seen on the backside of this aneurysm. And so for this one, I'm going to use this A1 as the donor site. And so I've come to appreciate the A1 as an excellent donor. You can see how it sits right next to the carotid terminus. It's able to recruit very high flows, and it's also very accessible at the very bottom of the Sylvian fissure. So this is all very routine now. We've seen a lot of video here, so I'll just quickly show you the completion of this donor A1 anastomosis. Once that's in place, we complete that, and then we can run the graft up the Sylvian fissure. And this is where it gets interesting. Here now you'll see our saphenous vein graft. You'll see the frontal division coming out the aneurysm. And this is now going to be a side-to-side anastomosis.